your mind, we'll discuss what it is. We are applying care bundles to prevent nosocomial infection of patients. What are the care bundles? Ventilator care bundle, central venous catheter care bundle, sepsis bundle, urinary catheter care bundle, Clostridium difficile are some of them. Ventilator-associated pneumonia care bundle. What is it? When the patient is intubated and mechanically ventilating for some time, the patient can get infection due to this mechanical ventilation because of the breathing system, endotracheal tube. So we know they can get ventilator-associated pneumonia or VAP. So to prevent VAP, we are applying VAP care bundle. There are 5 elements to VAP care bundle. Those are elevation of head of the bed to 30 to 45 degrees, daily sedation, vacations, and assessment for readiness to extubate. That means we know when they are intubated and ventilating, we are sedating them because it's uncomfortable for them. But to extubate, I mean, as we discussed, the endotracheal tube inside, the breathing system inside, they are getting infection. So we have to take it out also. So we have to assess the patient is ready to extubate by waking them up. Then daily oral care with chlorhexidine, peptic ulcer prophylaxis, peptic ulcer disease prophylaxis, and deep venous thrombosis prophylaxis. So these all 5 elements together, if we apply, we can prevent VAP or the ventilator-associated pneumonia. So they call together all these 5 elements what? Care bundles. So you have to know these 5 elements when you work when you manage intubate patients. Then central venous catheter care bundle or CVC care bundle.
Recording in progress. Recording stopped. අනුවදද ඒ අපි කියන්නේ නෑ වල
Check 1 2.
සකුන්තලාගේ හස්බන්ඩ් ලක්ෂ 3මාරක් පඩිය.
Johan Dehigasat.
කවුද මල්ලි මේ?
Hiroshana.
ගහන්න එපා බං.
Hiroshana Sampath.
ලෙක්චර් ගහන්න ආවන ලෙක්චර් ගහන්න මල්ලිලා.
Hari Johan Ayye.
So, who is, may stop chatting on the chat box. This Iron Man to who is this? Only if you have question, put on the chat box. Others stop chatting on chat box. You understand? Only you have question, put on the chat box. Otherwise, don't put this rubbish on the chat box. Dr. Nandika, are you there or shall we go to the next question? Okay.
Yeah, sorry about this. So sorry about that. So I'll finish quickly. So central venous catheter care bundle. Again, your hand hygiene is important, and make sure you apply maximum barrier precautions in insertion. That is strict aseptic technique. And we have to use chlorhexidine antiseptic. Optimal catheter site selection.
Recording in progress.
Tubular vein, subclavian vein, femoral vein, for example, you have to, depending on your requirement, you can use the site and this daily review of line necessity with crumbs removal unnecessary. That means if you had used for unstopped the vasopressor support, when there's no more requirement, we have to signal that.
Dr. Nandika, you have a presentation?
We have applied during insertion and maintenance. Also, that means when you are giving drug or total cancer nutrition, whatever the thing, if you use the CVC catheter, you have to apply these 5 elements. Then urinary catheter care bundles. There are 2 sets for urinary
Nandika,
catheter.
hello. Nandika.
And catheter ongoing care. What are the catheter insertion things?
We can't see your presentation.
Sorry?
We can't see your slideshow.
Okay.
Do you have one or don't?
Now you can see.
No, you can't.
Now, okay.
Yes. Yeah, can see it.
So this is central venous catheter care bundle.
Dr. Nandika, you have to unmute.
Okay.
Can hear now. Yes.
So urinary catheter care bundle, insertion and ongoing care. So insertion care is insert only if indicated. That means if the patient can go to the washroom or can use the urinal, you can give that. Unless indicated, we should not use the catheters. Then follow hand hygiene before and after insertion, and personal protective equipment standard you have to use appropriate, and you have to use aseptic non-touch technique. That is the urinary catheter come in a paper bag, right? And you have to ask somebody to remove that outside pack, and the polythene, with the polythene cover you take, and you only remove the top part of the polythene cover, not whole thing. While the polythene cover is inside, you have to insert the catheter. After inserting in, only you remove the polythene catheter, and as soon as you inserted the catheter, you have to connect it to the sterile cross drainage system. Then, what is your ongoing care for the urinary catheter? Always hand hygiene when you handle the urinary catheter, and sampling should be aseptic, and you have to take samples only from the sampling pot. You don't prick the urinary catheter for sampling. And drainage bag position also important. It should be below the bladder level and should be nicely secured to the leg without to prevent dragging and things. And catheter to be manipulated with the aseptic technique. And again, like the central venous catheter, urinary catheter also, you have to daily review whether this is needed. When there's no need, you have to remove that. All 5 segments you have to apply when ongoing care. And few words on safety measures when managing patients with COVID-19 infection. You have to follow the standard precautions which we discussed earlier. In addition to that, you have to make sure contact and droplet precautions. These patients to be placed in adequately ventilated single rooms. Each patient has to have a single room. But if no such facility, patients to be grouped together in a designated area like this. All these patients are with COVID infection. And make sure beds are more than 1 meter apart. And the staff to be designated for that unit only. They should not work intermittently to another units and COVID unit at the same time. And make sure you use appropriate personal protective equipment and learn donning and doffing properly. What are the aerosol generating procedures? We have to make sure, take precautions when we do these things. They are the endotracheal intubation, open suctioning of the endotracheal tube, bag and mask ventilation, cardiopulmonary resuscitation, bronchoscopy, and non-invasive ventilations. Because aerosol generating procedures are high risk of viral transmission. How are we going to avoid these things? In your non-intubated patients, train your patient for self-mobilization and let them do their own. You can stay outside. And if the patient can use adequately energy and power, give them metered dose inhalers. When perform aerosol generating procedures, make sure you are in a well-ventilated room or in a negative pressure room. And there should be absolutely minimum number of staff. And make sure you are wearing a proper respirator. That means seal-checked N95 mask, eye protection with goggles or face shield, and clean fluid resistance coverall with long sleeves and gloves. And when you manage COVID patients, if you are doing aerosol generating procedure, you have use everything, and if you are non-aerosol generating general contact, you can use others. And if it happens to mobilize a patient from COVID unit to other area, always make sure it's better avoid moving or transporting patients and keep the patient in the designated area. The procedures you want to mobilize, is possible, keep them inside the unit, like portable X-ray machines, the ECG machines, scan machines. But if you have to use to mobilize the patient, if medically indicated, inform the receiving area early and take an appointment and take necessary precautions. You determine from which route I'm taking this patient, and it should be minimum exposure to other people. And inform the authorities to clear the path before you mobilize the patient. When the time is ready, inform the receiving unit, take your patient with all the precautions, get done the thing as soon as possible without staying there, and come back and inform the authorities, clean the transport route. And these are the important things you have to do when managing COVID patients. That is, these things are for your safety, well-being, and satisfactions. These are very, very important for us because self-care of healthcare worker. Maintain your immunity, have a nice meal with nutrition, and maintain hydration. If you have any problems, discuss with your colleagues. If not, if they can't sort out, call your seniors, and psychiatrists also will help you. And limit your long shifts for your capacity. Have a bath after your shift and have a warm drink. Check your temperature daily. Then you can diagnose early. I wish you won't get this. And avoid social gathering. Don't have your tea, coffee, meals all together. You go one by one to the coffee room and have them. And keep an alcohol rub in your side bag pocket always for your personal use. And don't touch mouth, nose, eyes with potentially contaminated gloved or bare hands after contact with the patient, because always think I am essential and you should be there to save the patient, save the country. So it is a teamwork. We can beat corona by teamwork. So your objectives, I think, I assume you have to know infection control, safety precautions, care bundles you have to follow in the ICU, and bit about safety precautions when managing COVID-19 patients. Make sure, please do take care of yourselves and stay safe. We wish you good luck for your future from the Faculty of Critical Care Medicine, College of Anaesthesiologists and Intensivists of Sri Lanka. Thank you for bearing. And sorry about the intermittent disruption during presentation. Thank you. Tanushka, are you there? Over to you, Dr. Roshan. Our next presentation is on hemodynamics, which would be done by Dr. Danushka Lianagunawardana, consultant anesthetist from Base Hospital, Karawanel.
Good morning, everyone.
So Danushka, you have to switch off one mic.
Can you all hear me?
All right. You have to switch off the computer mic, I think.
All right. Is it better now?
Yes. Now okay.
Is it better now? Perfect. Right.
Yes, yes. Full screen.
Right. All right. I hope you all can see the slides.
Yes.
Right. Okay then. So today I'm going to discuss about hemodynamics, and before moving on to the topic proper, let's see what is the clinical relevance of this topic. As clinicians, we all would like to like the survival of our patients with a good outcome. So since we all are made up of millions of cells, if we can make these individual cells happy, ultimately that will lead various organ systems happy, and in turn, the organism as a whole will be happy. So to achieve that, what should we do? We all know cells have energy-dependent cellular processes. One such example is sodium-potassium ATPase pump, which required ATP. In the absence, cell membrane integrity cannot be maintained. So how do cells produce energy? We all know it's by means of metabolism, which has two main arms, aerobic and anaerobic. Slide, sorry. To ensure aerobic metabolism, we need to provide oxygen for the continuation of electron transport chain. The other way of achieving energy is by means of anaerobic metabolism, but you all know compared to aerobic metabolism, anaerobic metabolism is less efficient, because when one glucose molecule undergoes aerobic metabolism, it produces about 36 to 38 molecules of ATP, whereas anaerobic metabolism will lead to just 2 molecules of ATP. Right. So this is the oxygen delivery equation which ensure adequate oxygen delivery to the tissue level. This DO2 indicates oxygen flux or the oxygen delivery, and this Q is the cardiac output. And then all the other segment is about the oxygen content in blood. And we all know oxygen is mainly delivered to the tissues bound to hemoglobin. So your hemoglobin content therefore is important, as well as how much it is saturated is important. So that is mainly the oxygen content. And when 1 gram of hemoglobin is fully saturated, it delivers 1.34 ml of oxygen. Right. And there's another small fraction, that is the dissolved amount of oxygen, which depends on this solubility constant. When there's a millimeter of mercury partial pressure, this is the amount of 0.003 is the amount of oxygen which is dissolved in plasma. But under normal working conditions, it is very less significant. So we mainly focused on the hemoglobin content, saturation, and the cardiac output in terms of tissue oxygen delivery. And since today's topic is hemodynamics, so I'm mainly focused on one of the factors which involve in oxygen delivery, that is the cardiac output. So to further elaborate the same thing, so the cardiac output in turn depend on your preload, how much your heart is filled, afterload, the resistance against which the heart pumps, and the myocardial contractility, the inotropic activity. The preload in turn depend on your CVP or pulmonary capillary wedge pressure, which are indices, and then afterload for the pulmonary circulation, it will be pulmonary vascular resistance, and for the left side of the heart, systemic vascular resistance. So we'll be dealing with this part of the flow chart. Right. So we all are familiar with Ohm's law. So it says when the resistance is constant, your flow is proportional to the potential difference. So when we apply the same thing to our hemodynamics, the potential difference, our blood pressure, equal to flow. So cardiac output into systemic vascular resistance. So we'll be going through these aspects with more detail in a little while. Right. To further elaborate with the Huygens-Poiseuille equation, these are the factors which determine flow, assuming it's a laminar flow. So phi and eta are constant. Your pressure difference is important when it comes to flow, and the radius of the tube plays a significant role. And you can see the flow is proportional to the 4th power of the radius. So if you double the radius of a vessel, or for example, say cannula, your flow will be increased by 16 times because proportional to the 4th power. And then the viscosity and the length of the tube. Right. So hemodynamics. Basically, that's all about how the heart pumps blood throughout the body, and the dynamics involved in cardiovascular system. So there are physical as well as physiological principles governing this movement of blood through the circulatory system. For example, kinetic and potential energy provided by the pumping action of the heart, the gravitational forces, hydrostatic pressures within the system, and the pressure gradients generated by 2 points, the resistance offered especially by the arterioles within the circulatory system, all comes into play. Right. So what are the benefits of assessing hemodynamics? Obviously, you can early detect any deteriorating patient. So that is part of the cardiovascular assessment. And then you can understand the shock pathophysiology. If there's a compromise, you can differentiate whether this problem with the volume, whether this is a problem with the pumping action of the heart, cardiogenic shock, or any obstruction to the flow, or this is distributive, such as occurs in sepsis. So you can treat accordingly. And then those are in terms of clinical practice, and then research or clinical trials point of view to develop equipment, drugs, interventions for evidence-based practice. Also, this understanding of these aspects are important. Right. So ultimately, as doctors, you have to make a decision when it comes to CVS support, whether to give fluids, iron drops, vasopressors, or any other interventions necessary. For example, if the patient is having pulmonary embolism, we may have to thrombolize. Or if there's pericardial effusion, we have to do pericardial tap. Right. So methods available to monitor hemodynamics. There are invasive methods and non-invasive methods. First of all, always do clinical assessment. History may give some clues. Examination point of view, you will be assessing patient's peripheral perfusion by means of capillary refill time, in warm-up, peripheral warmth, pulse volume, rate, and then blood pressure. And you can see whether there's any evidence of organ hypoperfusion. The brain, if there's a cerebral hypoperfusion, patient will have altered level of consciousness. The heart, patient may complain of chest pain if there's inadequate coronary perfusion. And kidneys will shut down, leading to reduced urine output if there's inadequate perfusion. And skin mottling indicates poor cutaneous perfusion. So those are some of the clinical tools. And then to further assess the volume status and more the fluid responsiveness. Generally, when there's a hemodynamic compromise or blood pressure drop, the reflex action we do is to give a fluid challenge. So what you normally do, you give fluid bolus. You can give about 500 ml of crystalloids over 20 to 30 minutes. But then again, it depends on your patient. If it's an elderly patient with borderline cardiac function, so you may give a smaller volume, maybe 250 ml over 15 to 20 minutes. So somehow you subject the heart to a different loading condition and you reassess your hemodynamic parameters, heart rate, blood pressure, peripheral perfusion, urine output, and so on. And so that is what we normally do. Now, passive leg raising, again, it's kind of an internal fluid challenge which you can perform at the bedside, where the pooled blood in our capacitant vessels of the lower limb is mobilized to the central circulation. As we know, 65% of our circulating blood are pooled in the capacitant vessels. So it delivers, it auto-transfers approximately about 500 ml of blood. And good thing is it is reversible at any point. And you can perform this repeatedly to assess the hemodynamics. How are you going to do that? So initially, patient in the semi-recumbent position, head up, tilt. You get the static parameters like your pulse rate, blood pressure, get an idea about the capillary refill, and then you lift the leg up to 45 degrees with the passive leg raise, and you reassess after 1 to 2 minutes the same parameter to see whether your tachycardia is improving, whether the blood pressure is going up, and you can get an idea whether it makes any difference. And to be precise, if we have a dynamic parameters like stroke volume variation, we have an arterial line to monitor need-to-be blood pressure variations, your assessment will be more precise, but in the absence, you still can work this out with your static parameters, which you normally do in day-to-day practice. Right. So what are we trying to achieve by giving a fluid bolus? This is the famous Frank-Starling curve, which we have learned in medical school. So what Frank Starling says is, greater the left ventricular end diastolic volume, greater the stroke volume would be. So the x-axis is the ventricular preload or the left ventricular end diastolic volume, and your y-axis is stroke volume or the cardiac output. And you can appreciate it's a hyperbolic curve. And it has two main segments. This light green bit, you can see there's a steep part of the curve, and this pink one, you have a flat part of the curve. So let's concentrate on this point. So you have certain left ventricular end diastolic volume and a corresponding stroke volume. So if you increase left ventricular end diastolic volume by delta V by giving a fluid challenge, now you have a different stroke volume for the new left ventricular end diastolic volume, and you can see there's a change in stroke volume cardiac output, which will be reflected on your clinical parameters. So you will see heart rate may improve, your blood pressure may go up, capillary refill time may be better than earlier, and so on. And when your ventricles are behaving in the flat part of the curve, things are different. Suppose now your starting point is this. So you have a certain left ventricular end diastolic volume and a corresponding stroke volume. And you do same fluid challenge to achieve the same change in left ventricular end diastolic volume. Now your left ventricular end diastolic volume is higher and you have a different stroke volume. But this difference is not very significant because now your ventricles are functioning in the preload independent zone. Your ventricles are no longer responsive to the fluid bolus. So by giving a fluid bolus, what you are assessing is whether your ventricles are functioning along the flat part of the curve or the steep part of the curve. If the ventricles are functioning along the steep part of the curve, you will see improvement in your hemodynamic parameters. If your ventricles are functioning along the flat part of the curve, there won't be any increase or improvement in the hemodynamic parameters. Right. So this is to further elaborate. This is the same Frank-Starling curve I explained to you earlier. And then there's another curve here you can see that reflects the left ventricle extravascular lung water. So initially, when you give fluid boluses, your cardiac, your stroke volume or the cardiac output increases, and afterwards it's flattened out. So extravascular lung water initially, the curve is flat, and beyond a certain critical point, you see extravascular lung water goes up. So after this point, there's no benefit in increasing the preload in terms of optimizing cardiac output, and in fact, it's harmful because now you will push the patient into pulmonary edema. Right. So then we move on to the non-invasive methods, other non-invasive methods of monitoring cardiac output. One thing is bedside ultrasound scan to assess the inferior vena cava diameter. Now, during the respiratory cycle, for example, if you are spontaneously breathing, your inspiratory effort causes increased intrathoracic volume and reduction in intrathoracic pressure, which facilitate venous return, result in IVC collapse. During expiration, your intrathoracic pressure increases due to the recoiling forces of the chest wall and the lung, and therefore venous return reduces, in turn causing distension of the IVC. So this can be quantified, get an IVC collapsibility index for a spontaneous breathing patient by assessing maximum diameter deducted with the minimum diameter, and when you divide it with the maximum diameter once again, you can get it as a percentage. So if the collapsibility is more than 40 to 50% during the respiratory cycle, it is considered significant and the patient is volume response. It's slightly different when it comes to patient on IPPV. So this is a diagram. You can see this is the right ventricle, and this one is the IVC. In a spontaneous breathing patient, this indicates expiration. And here you can see the wall is collapsed now. Drain into the right ventricle, it's collapsed. So in a mechanically ventilated patient, things are different. Now, intrathoracic pressure changes in the opposite way during respiratory cycle. So Inspiration, you give a positive pressure, so intrathoracic pressure is high, venous return reduces, and IVC distends. During expiration, you release the pressure so that the intrathoracic pressure reduces, which facilitates venous return and the IVC diameter reduces. So here we get IVC distensibility index rather than collapsibility. So percentage value quoted as 12 to 18% depending on the denominator. If you take average diameter, the cutoff is more than 12%. If you only get the minimum diameter, then you go for 18% cutoff. Right. So other non-invasive methods would be bedside echo. This is not a comprehensive cardiac assessment by any means, just a focused assessment for our clinical decision to give fluids, iron probes, or respirators. And there are certain focused views we go by, and depending on the echo findings, will correlate it with our clinical decision. And then we'll move on to the invasive methods. Basically, during invasive methods, we put a catheter into our circulation, either arterial system or venous system, for further analysis of the hemodynamics. So one thing is central venous pressure monitoring. You may all have seen, you can put a central line into one of the vessels. Main sites are internal jugular, subclavian, or the femoral. But to monitor central venous pressure, it has to be either subclavian or internal jugular, where tip of the catheter should be in the superior vena cava. And you have to get the 0 point at the right atrial level, so mid axillary line. Either you can get the central venous pressure with a CVP manometer, or where transducer, which will give feedback to the monitor and it will be depicted as a waveform. The important thing to remember is, good old days, we use central venous pressure as a monitor for volume status and to assess fluid responsiveness. But repeated studies have proven that it's not a reliable indicator in terms of volume status or fluid responsiveness. So nowadays, we hardly do CVP guided fluid management on its own. We can still use it in combination with other parameters, but not as the sole guide. Right. So in continuing with the invasive methods further, the thing is invasive blood pressure monitoring, where you put an arterial line into one of the arteries, which could be radial, brachial, dorsalis, pedis, or femoral, and you connect it to a transducer where a pressurized fluid column, and this transducer converts the pulsatile mechanical energy into an electrical signal, which will be depicted in your monitor. So good thing about this is it provides you beat-to-beat blood pressure monitoring. Right. So where would you consider invasive blood pressure monitoring? If you expect any rapid changes in hemodynamics, if the patient have extremes of blood pressure, severe hypertension or hypotension, unstable patients on vasoactive agents, multiple iron probes, vasodilators, vasopressors, depending on the clinical condition. So in this sort of situation, we may consider invasive blood pressure monitoring rather than non-invasive one, which is continuous. So this is one waveform of the arterial line. So this upstroke indicates the contractility. If it's a steep upstroke, contractility is good. If it's on incline, contractility is less. And this is the systolic phase, and this in diaphoretic notch indicates the aortic valve closure. So this bit is your systolic phase where ejection takes place, and then the diastolic phase where ventricular relaxes. So depending on where this diaphoretic notch located, we can get an idea about the afterload where aortic valve closure. If the afterload is high, aortic valve closure is earlier, so the diaphoretic notch is higher up. In a septic patient who's vasodilated, your systemic resistance is low, so ejection takes place until very late, so that the diacritic notch stays lower down. And depending on the number of complexes, you can get idea about the heart rate and rhythm and so on. Volume status, also you can get an idea if there's a swing in the arterial pressure waveform or the amplitude variation. Again, the same explanation as with the previous one with Franz-Starling curve. So during a respiratory cycle, there are heart-lung interactions. So inspiration for a spontaneous breathing patient, less intrathoracic pressure, more venous return. Expiration, high intrathoracic pressure, less venous return. So heart is subjected to two loading conditions in a cyclical manner during the respiratory cycle. So in a normal volemic patient, this change is not significant. This subtle volume change or the venous return is not significant. So you won't see an apparent change in arterial waveform amplitude. But if the patient's ventricles are functioning in the steep part of the curve, even this subtle volume change during the respiratory cycle causes apparent change in the stroke volume and cardiac output, and therefore you will see this amplitude variation. And using this plethysmography or the arterial waveform in cardiac output monitors, you can further quantify these values. Cardiac output, and when it taken considering the body index or the body surface area rather, you can get cardiac index. You can get idea about the systemic vascular resistance and the stroke volume variation during the cardiac cycle, which is an indicator of volume responsiveness. So likewise, the same waveform, you will be getting numerical values with quantification when you're using cardiac output monitors such as LIDCO, PICO, flow track, which all use pulse contour analysis, analyzing of the arterial wave. Right. So this is how you're going to assess hemodynamics. And not only that, pulse contour analysis, there are other ways of measuring cardiac output. Invasive methods would be to use pulmonary artery flotation catheter, where you have use thermodilution techniques, but because of the complications, we are not using it very often. And then you have ultrasound or Doppler-based techniques, esophageal, transesophageal Doppler, and then non-invasive ones such as thoracic bioimpedance. So there are various means of monitoring cardiac output, which may be helpful to get further information to support your patient's cardiovascular system. Now, the next question we have to answer is, are we actually meeting the demand at cellular level despite optimizing the blood pressure or the hemodynamics? For that, we have to get an idea about the return flow. So one thing is, we can get an idea about the serum lactate, which is the end product of anaerobic metabolism. If the lactate going up, we can get an idea whether metabolism has shifted from aerobic to anaerobic. So one cause of rising lactate is reduced clearance, which is mainly created in the liver. If there's a liver pathology, you may get reduced clearance. But predominant thing is increased production, which again due to inadequate supply of oxygen at tissue level. So at the very beginning, I explained that oxygen delivery depends on hemoglobin, the saturation, and the cardiac output. So compromise of any of these factors would lead to reduced oxygen delivery and anaerobic metabolism. And in this particular lecture, we are mainly concentrating on cardiac output and hemodynamics. And other thing is inability to utilize, such as a typical example would be cyanide poisoning, where there's a mitochondrial dysfunction. Similar thing could happen in sepsis as well. So despite adequate delivery, cells cannot utilize, and therefore you will get anaerobic metabolism. So various medications can be contributing, especially metformin, a commonly used drug in the presence of renal failure in particular, and various toxins, alcohols, malignancies, neurological malignancies, and ICU setup when CRRTs are being used with lactated buffer, still you can see elevated lactate level. So if you see a patient with high lactate, you should analyze what the underlying problem is. The other thing to see whether you are actually meeting the demand at tissue level is to look for central venous oxygen saturation. So you can see heart pumps blood along the arterial tree into various organ systems, and there are some degree of oxygen extraction by each of these organs, and the return will be there with the venous circulation. So when you analyze this return venous flow, you expect certain venous saturation after extraction. So in the when the upper part and the lower part of the body venous blood mix together from right ventricle upwards, if you take a sample, that will represent global oxygen supply demand balance of the body. But nowadays, since we don't use pulmonary artery flotation catheter, we can use a surrogate. That is central venous oxygen saturation. This graph indicates central venous oxygen saturation. This can be used as a surrogate for mixed venous oxygen saturation. So we use mixed venous oxygen, central venous oxygen saturation, therefore, to get an idea about the oxygen supply demand balance of the patient, which again, as I explained with the lactate, depend on your saturation, hemoglobin, as well as cardiac output. So it's not only depend on the cardiac output, you have to think about the other two factors as well, if there's any compromise. So you'd expect it to around 70-75%. And if there's any decrease, that indicates increased extraction at the cellular level, and there's some compromise in the supply. So this graph further explained to you what I was trying to discuss earlier. So this x-axis is tissue oxygen delivery, ml per minute, and here oxygen consumption at tissue cellular level. So you can see when the supply or the delivery comes down, cells still maintain oxygen consumption at a constant level until a critical point, beyond which when the supply cuts down, consumption also coming down. And this is the lactate graph. You can see lactate is stable up until this critical point, and when the oxygen consumption goes down, lactate starts to go down. And this interrupted line indicates the central venous saturation or saturation. Even before lactate going up, you can see reduction in mixed venous saturation because now the extraction is more. And then comes to the constant. So therefore, these two indicators, mixed venous saturation and the lactic acid, is a good provides you some idea about what actually happening at the cellular level. So to finish things off, get an idea where the problem is. It could be hypovolemic shock, where you may have to give fluid, blood products, depending on clinical context. If it's a cardiogenic shock, we may have to consider inotropes to enhance cardiac output. If it's a distributive shock like anaphylaxis, sepsis, we may have to consider vasopressors. And if it's obstructive shock, you have to relieve obstruction, for example, thrombolysis in PE. Right. So the take-home messages of my lecture will be: pressure is not equivalent to flow, even though we usually do pressure measurements instead of the flow measurement. But we are interested in cardiac output, the flow measurement, but you need sophisticated equipment for that. So we use blood pressure measurement. But blood pressure is cardiac output into systemic vascular resistance. If the systemic vascular resistance changes, for example, if someone on vasopressors, you can maintain blood pressure with a very high SVR at the expense of cardiac output. Second important thing is shock is not the same as hypotension. Shock usually associated with hypotension, but not necessarily. You still have a patient, for example, good example is class 2 hemorrhage, where compensatory mechanisms take place to maintain vital organ perfusion like heart and brain at the expense of peripheral perfusion and renal perfusion. There, your blood pressure is maintained with a narrowed pulse pressure, but you will see cold peripheries, prolonged capillary refill time, low volume pulse, and reduction in urine out. So it's a compensatory shock. And on the other hand, there may be young patient whose blood pressure may be 85/50 or 90/60, but conscious, walking around, good peripheral perfusion, no concerns about urine output, so he's not in shock. So shock is all about the inability to maintain tissue metabolic demands by the cardiovascular system. And other thing is different shock needs different treatment. All shock answer is not fluid. All shock answer is not noradrenaline. So it depends on your patient. And lastly, you have to have an individualized plan according to your clinical judgment, which is supplemented by various analytical tools, which we went through, depending on the availability and the clinician's familiarity. That's all I have to say. Thank you very much. Dr. Rashan, can you hear me?
Yes. Right, Dr. Ashwin Lena Kunwata, thank you very much for that lecture on hemodynamics. So if anyone's having questions, no question on chat box. So in that case, anyone's having questions, you can put on the chat box. Until that, we go to our next lecture by Dr. Asantha Arabe Pola, acting consultant anesthetist at DAGH Mana. Yeah, over to you, doctor.
Hello, good morning. Hello, good morning. Can you hear me?
Yes, can hear.
Today I'm going to talk about electrolyte imbalance. I know that you all have a good idea about electrolytes because in our medical career, so throughout the career we learn about the electrolyte imbalance, but this is a very important topic. Before going to the electrolyte imbalance, I would like to introduce body compartment. Okay, so what is the body compartment? So as we know, mainly body can be divided into extracellular and the intracellular compartment. So extracellular compartment can be divided into plasma and the interstitial fluids. Okay, right. So this distribution of the electrolytes throughout this compartment is different. It depends on the charge and the osmolality, rarity. So there are multifactorial based on the multifactors. So the distribution is different, right? So as we know that electrolytes mainly we can divide it to cation and the anion according to its charge. So I'm not going through these all cation and anions, but you have to have some idea about the figures of these electrolytes because it is very important to manage of these patients, right? Okay, so as you can see that sodium is 140 is in plasma, but in intracellular it is 12, right? So that the potassium it is 4 in the plasma, but in 160 in the intracellular. So there's the huge difference between each compartment, right? Right, let's jump into the sodium. So we know that sodium is one of the most important cation in the body because it always associated with water molecule. So water is the life. So because the sodium is very important cation. All right. So what is the normal level of the plasma level of concentration in sodium? That is 135 to 145. So less than 135 called hyponatremia, and the more than 145 called hypernatremia, right? Yeah. So what do you know about osmolality and larity? So osmolarity is a concentration of the substance in 1 liter of water divided by its molecular weight. So that means how amount of sodium including 1 liter of water. That is a rough idea. Okay, let's talk about hyponatremia. Hyponatremia can be divided to mild, moderate, and severe according to its concentration levels. And so let's talk about hyponatremia, the clinical importance, right? And the complications. So when you get the patient with hyponatremia, he or she may present with headache, nausea, malaise, lethargy, weakness, poor coordination, muscle cramps, the various symptoms. So which is very important. You have to identify this patient and you have to treat the patient. Otherwise, patient end up with the following complications like seizure, coma, permanent brain damage, respiratory arrest, brainstem herniation, as well as death. So then you have to identify this patient and you have to treat the patient. Oh, how are you going to manage this patient? Now the management basically depends on severity, duration, and the cost. Okay, now, so this algorithm is based on nice guideline, which is introduced in 2012, as I remember. So this is a hyponatremia algorithm. So please focus this because it is very important. Remember, the patient who is having low osmolality. So what is the normal osmolality? That is 285 to 295. If it is less than 285, there is low osmolality associated with hyponatremia called true hyponatremia. High osmolality, like more than 295 or normal osmolality, the between range associated with hyponatremia called pseudo hyponatremia. Okay, right. Let's talk about true hyponatremia. So if you have a patient with low osmolality and the low sodium, so those patients you have to assess its volume status. There are 3 volume statuses. You all know: hypovolemic, hypervolemic, and euvolemic. So hypovolemic is again, that means the total body water is reduced. So comparatively, total body sodium also reduced. They should be reduced so that otherwise it's not become too hyponatremic. So those patients is dehydrated hyponatremic patients. You have to check the urine sodium. Urine sodium less than 20 mean the sodium is lost not through the urine. It's extra losses like vomiting, diarrhea, burns, bowel obstruction, pancreatitis, or sweating, excessive sweating, anything. If the urine is more than 20, sodium more than 20% in urine, that means sodium lost through the renal pathway. So that, as example, due to diuretics, renal failure, neurocorticoid deficiencies, chronic nephritis. So those are the causes, right? Whatever the cause, then you have to correct. So treatment correction, again, that I told you, it's depend on the severity, the duration, and the cost now. So now the duration. If it is acute, so this develop within 48 hours, it is called acute. Which develop more than 40 hours, it is called chronic. If it is acute, so you have to act rapidly. So then you have to consider 3% sodium chloride and you have to treat the process. If it is more than 48 hours, you don't have to act that much fast. So then you have to consider 0.9 normal saline, right? So that is how to manage hypovolemic hyponatremia. Right, so let's talk about hypovolemic hyponatremia. So here the total body water is increased, definitely should, and the total body sodium also increased, but concentration is low. Right, this kind of patients like congestive cardiac failure, cirrhosis, nephrotic syndrome, those are the example. Right, let's talk about the treatment. Usually, which is chronic, right? It will take more than 48 hours unless patient get like MI and lead to cardiac failure, right? So this type of patient, first you have to do the fluid restriction. If it is acute, then you have to act fast Then consider hypertonic saline, loop diuretics, and you have to restrict fluids as well as water intake, right? All right. Then there is hypovolemic hyponatremia. Let's talk about euvolemia. Euvolemia is a total body water is increased or it's normal, and the total sodium is it's normally level. In that case, you have to check the urine osmolality. If it is less than 100 and the urine sodium is more than 20, so that means primary polydipsia. So that is inappropriate IVL. So iatrogenic, could be iatrogenic, low solute intake. Right. So other pathway is the urine osmolality more than 100 and the urine sodium more than 20. So that is inappropriate ADH. So the other causes are like hyperthyroidism, glucocorticoid deficiencies, and SIADH. So increased ADH that can cause to absorb more water. Right. Okay. In this treatment, the first thing is a fluid restriction, and so you have to treat the cause. Okay, I will jump into the case scenario now. So please go through this. This is a nice guideline. Okay, here you have a 57 years old gentleman, 60 kilos, who is presented with seizure. Oh, now this patient is having symptoms. Who had several vomiting episodes that were including associated diarrhea over the last 2 days. Oh, that means more than 48 hours. So upon examination revealed the patient is a hypovolemic, hypotension, and hyponatremia. Right. This looks like true hyponatremia. So serum sodium level is 100.07 and the urine sodium is less than 20. So that means this is an extra renal sodium loss because it is due to vomiting, it is due to diarrhea, and the patient is having symptoms. So it is less than 120. So you have to, it is it looks like over 2 days. And so we have to rapidly act on this patient and we have to treat vigorously. So how are you going to do this? First of all, you have to identify. So this is only I'm concerned about the sodium management. I'm not going to concern about other management, fluid restriction or anything. I mean, like other cause of treatment, of course, or anything. So this regarding the hyponatremia. So first you have to identify the sodium deficit. How to calculate it? Remember, you don't have to. So our desired sodium level is 120. As we know, that normal level is 135 to 145. But we are not correct up to 135. We are correct up to 120. That is our target because most symptoms occur at the level of 120. Okay. Now the patient level is 107. So this is the difference. So the sodium deficit is the difference of the sodium deficit into body water. Body water usually we are taking 60 kilos into multiplied by 0.6. So sometimes they are using 0.5. It's depend on the fat level. So now the sodium deficit is 468. Right. Our target is 120 or subside symptoms. So you can't give sodium like rashly because it can cause to osmotic myelitis, right? Because of that, you have to give it under supervision with safest rate. So safest correction rate is 1 to 2 millimoles per liter per hour. Therefore, 100 to 107, the difference is 13 millimoles per liter now. So which should achieved, our rate would be 2. If you think our rate would be 2, it should be achieved 7.5 hours. So that means 468 millimoles per liter, that sodium deficit we have to give over 7.5 hours. So that means in 1 hour, you have to do 62.4 millimoles per liter. So as we know that this patient is affected within 48 hours and the symptoms are there. So we have to give it some, not for the, we have to give some 3% sodium, not the 0.9 saline. So each 3% saline, 1 liter contains 530 millimoles. That means that 62.4 millimoles containing 121 milliliter. So in this patient, you have to give 121 milliliter per hour to correct hyponatremia. So you have to give till get the levels 120 or subside the symptoms. Okay. All right. Let's talk about hyponatremia. Hyponatremia again divided into mild, moderate, and severe. So remember, this hyponatremia always leads to cellular dehydration. Right. So these are the causes: sodium gain causes, or water deficit causes, or renal water loss through the renal. So those are the causes for hyponatremia. I'm not going to this all stuff. So these are the hyponatremia clinical features. So anorexia, vomiting, restless, twitching, hyperexia, ataxia, and the tremors and lethargy. So this these patients are like sometimes it's like we know that 135, 145 is the normal level, but if it is more than 160, maybe asymptomatic. But remember, you have to, this can cause to cellular dehydration. So we have to consider about concern about the consciousness of the patient, because consciousness is correlated with the severity. It can cause to brain shrinkage, which can lead to vascular rupture. Okay, how are we going to evaluate this hyponatremia? Always history, examination, investigation. You have to go through the history, examine, investigation, you identify the cause. Management of hyponatremia. So management, those are the principles. First, you have to stop ongoing losses. If there are any water loss, you have to stop it. And is there any, probably this patient is dehydrated, so then you have to correct the deficit and you have to treat the underlying cause. Right? So remember this equation. How to identify, how to measure the water deficit, total body water into serum sodium, the patient's serum sodium minus 140 divided by 140. So that is the equation. Is a simple equation. In this equation, you can get the water deficit. So you have to replace deficit, not enough only the replace deficit. You have to consider about the maintenance, as well as you have to consider about the ongoing doses. Because if your patient is having urine output like more than 300, 400, you have to definitely replace the ongoing doses as well. So how to replace? What are the fluids? What are the liquid that you are used to replace it? You can use oral free water, 5% dextrose. Again, you are not going to give it like a boluses, because patient may end up with fluid overload. Every time you have to correlate with the patient clinical symptoms. So usually we use it 24 to 48 hours to correct the deficit. In acute cases, you have to concern about rapid correction, but you have to have the proper monitoring system. Remember that corrects sodium slowly over 24 to 48 hours with reduction of sodium 0.5 to 1 millimoles per hour. So slow correction in chronic cases to avoid cerebral edema. Okay, let's talk about the case scenario. Again, 65 years old gentleman with 60 kilos, patient who was in ICU with unconscious following head injury. Now the day 5 patient developed meningoencephalopathy with polyuria. right? Now the sodium level is 174. Patient is having encephalopathy, patient is unconscious. Now the sodium is 174, and the urine sodium is 5, and the urine osmolality is less than 100. So how are you going to manage this patient? Right. These symptoms and sign more likely diabetes insipidus. So first, I told you first, but you have to stop ongoing losses. So correct volume and start IV vasopressin or puff. You can use it to stop the losses. Right? It's okay. You first have to treat the case, the cause, and then you have to calculate the water deficit. Right? This patient is 65 kilos and the sodium level is 174. So what is your desired level? 140. Right? So total body water into the difference of serum sodium and the 140 divided by 140. The water deficit is 8.5 liters. Then you have to replace 8.5 liters over 24 to 48 hours. Then you have to give a maintenance. Usually our maintenance would be 1.5 ml per kg per hour. So you have to add that volume also into this deficit, and you have to consider about the ongoing losses. The whole volume you have to replace over 1 or 2 days. All right. Now I'm going to talk about potassium. Potassium is one of the very important cation in the body. It is the prominent in the intracellular compartment. Okay, this is a potassium homeostasis. I'm not going through this. You all have 2 idea about this, right? So remember, so what are the things potassium shift into the intracellular, and what are the factors potassium shift outward from the intracellular, right? And what are the factors that help to excretion of the urine, right? Just go through. You can read it from the internet also. All right. So usually the normal plasma potassium level is 3.5 to 5 millimoles per liter. The hyperkalemia means more than 5.5, hypokalemia is less than 3.5. The potassium is killer, not like sodium, right? So those are the causes of hyperkalemia: increase intake, increased production, decreased excretion, and transcellular shift. So those are the clinical features. Patient may present with muscle weakness, lethargy, ascending paralysis, and respiratory failure. The serum potassium can divide at mild, moderate, and severe. So I think you all know about this. So those are in Ganon and all the physiology books. So it's mild, 5.5 to 6.5. So you can see tolerated T wave. Then next step, that loss P waves. Next step, the prolonged QRS, ST segment elevation. Ultimately, patient end up with sine wave and the axis deviation, but branch blocking and the BF, right? And the systole. So here's the ECG. You can see not that much of sine wave, but the tolerated T wave, ST elevation, QRS complex widening, no P wave, right? Typical hyperkalemic ECG. So actually, by seeing this, you can have some idea about the concentration of potassium. Okay, how are you going to manage this hyperkalemia? So management, again, it's depend on the cause and it's depend on the level of potassium levels. I mean, like use of, if the patient is presented with the clinical features with the ECG rhythm, there's any arrhythmia or any tolerated T wave or loss P with presented with ECG abnormalities, then you have to consider membrane stabilizer. Who is the membrane stabilizer? That is 10% calcium chloride 30 ml or 10% calcium gluconate 10 ml over 5 to 10 minutes. Okay. So it is very important to remember, very easy, 10, 10, 10, 10% calcium gluconate, 10 ml over 10 minutes. Okay. Okay, now you stabilize the membrane and you have to reduce the extracellular potassium. So you can use insulin, 10 to 15 units of soluble insulin with 50% dextrose 50 ml over 1 or 2 hours, right? As well as you can use salbutamol, which is beta agonist. You know that sodium potassium ATPase pump, this beta agonist act on this and sodium shift into the intracellular. As well as you can use the sodium bicarbonate, which can cause to change the environment as acidosis. So again, potassium shifting to the became more alkalosis and potassium shifting to the intracellular. Now, all are temporary measures, right? The membrane stabilizer, ECF shifting, all are temporary measures. So how are you going to remove of potassium from the body? One is the urine. If the patient is not on renal failure, you can use the furosemide. There's nothing. And you can use the resonium, which go through the feces and the blood. You can use the hemodialysis, you can use the CRRT, you can use the peritoneal dialysis to remove the potassium, right, from the blood. Okay. Again, here's the potassium homeostasis. Now I'm going to talk about causes of hypokalemia. So those are the causes. I'm not going through these causes. And those are the clinical features. So patient may present with fatigue, muscle cramp, weakness, constipation, asthenic paralysis, respiratory arrhythmias. And here the progressive hypokalemia can cause two ECG changes, that is inverted T wave and the prominent U wave and the PROM-Q TU intervals, right? So those are the features, and patient end up with ventricular fibrillation, bradycardia, and the arrhythmia. This is a typical ECG due to this hypokalemia. Okay, how are you going to manage this hypokalemic patient? Remember, hyperkalemia is a killer rather than hypokalemia. So be careful to give, be careful, very cautiously you have to give potassium replacement. You have to give the potassium replacements. So what are the management principles of hypokalemia? First, the replacement. In the life-threatening situation, you have to give 10 to 20 millimoles per liter over 1 hour. All right. So via in the central line, you can give 20 millimoles per liter via 1 hour. So usually we use 100 ml normal saline. And so in the non-acute situation, you can use again 10 to 20 millimoles over 1 hour via the central line. So if you are using peripheral, you have to use great veins, large veins, you have to dilute it, and not concentration more than 10. Right? So you have to consider about replace magnesium. Why? Because you all know that sodium potassium ATPase pump is helped to lower enough sodium potassium. Magnesium is a cofactor. So magnesium is the hidden electrolyte, can affect hypokalemia. So always you have to concern about magnesium. So replacement, and you have to treat the cause. Don't forget to treat the cause. Okay. Here, 70 years old gentleman presented with recurrent vomiting. Investigation revealed potassium 2.5. How are you going to manage this patient? So what is the deficit? What is your desired potassium? So normal level is 3.5 to 5. You don't have to correct up to 5. So 3.5 is adequate. And this patient's actual level is 2.5. So how to identify the potassium deficit? There are so many equations in the internet, so I'll go through this one. So this the deficit is the difference of desired and actual potassium levels into body weight, that is 60 kilos, into 0.3, that's factor. So according to this patient, 20 millimoles per liter. So I will go through the 20 millimoles per or 1 hour, and in the peripheral cannula, I will use 10 millimoles per liter per 1 hour. Make sure you have to establish the cardiac monitor. You have to do the electrolytes, and you have to do the consider about the magnesium as well. Okay, let's come into the magnesium. So this is a magnesium homeostasis. So magnesium is one of the major cation. It has several action in the several system in the body. It acts on neurotransmitter, neuromuscular excitability, cofactor for enzymes, ATP, DNA, RNA generator, and it's a membrane stabilizer, cardioprotective, neuroprotective, and the smooth cells, smooth muscles, dilators, a bronchodilator, right? Then spasm reliever. So can cause. It's not an antihypertensive agent, but it can cause some kind of antihypertension part also. So here's the homeostasis. I'm not going through this. Normal plasma level is 0.1212 millimoles per liter. So what are the indications for magnesium therapy? Pre-eclampsia, eclampsia, we have to be to basically protect the neonatal protection, neonatal cerebral protection. In asthma, we gave to which has action to prevent histamine release as well as to prevent as I call it release in excitatory nerves, as well as it's a bronchodilator. In the arrhythmia, it has especially the torsades point. It has a action of cardiac protective agent. So if the patient is magnesium deficient, you have to give, and it has a tocolytic agent. So preterm deliveries, again, we have to use for magnesium because it is antidote of calcium. So in SH management, which have to dilate the arteries and improve the blood supply, and the tetanus. So magnesium is very important, which is help to decrease the muscle spasm and the contraction. Okay, let's talk about magnesium therapy. So magnesium therapy is basically it's depend on the cause and the patient factors, but there's some principles you have to remember. Magnesium distribution to the tissue is very low. Okay, so when given rapid, 50% of it lost in urine. So that's why we have to give it 1 gram hourly. So magnesium level should not be checked immediately after bolus. Remember? Good. Right. This is a monitoring during magnesium therapy. The magnesium is a drug, right? It's not it's not only electrolyte, it's a drug. If you are give more, it can end up with toxicity. So then you have to, definitely you have to monitor the patient, you have to monitor the clinical features as well as the concentration of the magnesium. So how to treat this patient? First, you have to stop the treatment. If the patient is having toxic features, complete heart block, cardiac arrest, or whatever, loss of deep tendon reflexes, or bradycardic, or like low respiratory rate. So what you have to do? First, you have to stop giving magnesium. Give calcium chloride because calcium is antidote, and you have to adequate hydrate the patient. So you have to improve the furosemide and give to excessive increase the urine output. So if not controlled, you can consider about hemodialysis. So what are the causes of hypomagnesemia? Simply, it's increased magnesium load or increased renal magnesium absorption. So those are the causes. Let's talk about the hypomagnesemia. So in hypomagnesemia, it can cause inadequate intake or the excessive excretion, the renal loss, endocrine diseases, or the redistribution, burns, lactation. So those all are can cause to hypomagnesemia. So those are the clinical features. Neuromuscular patient will present with muscle tetanus tremors, sheath activity, ataxia, and the cardiac. You can see peak T waves, mild SD segment depression, and the VT, prostaglandin point. Right? So those are the features. Remember, I told that magnesium is more to act on the sodium potassium pump. So if the patient is having magnesium problem, may be associated with hypokalemia as well. Okay, let's move into the calcium. Right now, calcium is the most abundant mineral in the body. You all know. So it is 1.5% of body weight with good calcium. It's a very big level, right? The 99% in bone matrix as calcium phosphate. This calcium in the body, which is bound with, mainly it's bound with the albumin, that is 50%, and the 50% is ionized. So remember, this ionized calcium is pH dependent. I think you all know about this. I just want to brush up your knowledge. Okay, here's the calcium homeostasis. You can see what happens when the calcium levels is increased, which stimulate the thyroid gland, release calcitonin, which act on these bonds, and this osteogenesis started and reduced calcium uptake in the kidneys. So as a result, that calcium levels come down. What happens if it's low? If it is low, then which detected by the parathyroid gland, increased parathyroid hormone, which act on the osteoblast and can cause to release more calcium and increase calcium uptake by kidney, so activates vitamin B, that is 125 dihydroxy calciferol, which act on the bowels and improve the absorption. So ultimately, the final stage that increase the calcium level in the blood. So, okay, what are the causes of hypercalcemia? Please go through this vitamin D deficiencies, hypophosphatemia, precipitate of calcium, chelation of calcium. So those are the causes of hypercalcemia. What are the clinical features of hypercalcemia? The history. Please go through the history and examination. In history, you have to go through the clinical features of hypercalcemia. You all know that. Oral perioral numbness, paresthesia, muscle cramps, irritability, seizures, tetanic collapse, and vasospasm, Chomsky's sign, Clausius sign, the hypertension, arrhythmia, heart failures. So those are the examination features. So each and every patient with representative who is suspected of hypercalcemia, so you have to go through this. So these are the ECG changes you can see. So what are the investigations that you have to do in hypercalcemia patient? Not only the calcium, you have to check the albumin, because sometimes the malnutrition patients, they presented with low ionized calcium, maybe normal ionized calcium, but with hypocalcemia, normal ionized calcium, hypocalcemia. In that case, you don't have to give calcium. So you have to improve the malnutrition part. You have to give albumin, not the albumin. You have to improve the protein levels and albumin levels in the body. Right? So as well as you have to check the magnesium, because magnesium is antidote of this hypercalcemia, and you have to evaluate the hormonal level, as well as you have to check the phosphate, because phosphate always associated with hypocalcemia. So then you have to investigate phosphate as well. So management of hypercalcemia, how are you going to manage this patient? So what are the indications for what are the indications for management of hypercalcemia? So indication for hypercalcemia is symptomatic hypercalcemia, ionized calcium levels less than 0.8, and if the patient with calcium channel blockers, then you have to give calcium. Patient with hypermagnesemia or hypermagnetic toxicity, then you have to give it. And any massive transfusion or post cardiac pulmonary bypass, then you have to consider about calcium. So replace calcium is whether intravenous, oral, or oral. So you have to treat the cause. You have to consider the vitamin D as well. That's it. Do you have any question? Hello. Hello.
Yes, Dr. Sandra. Thank you for that lecture on electrolyte imbalances. Right. So we are going to get no questions. Yeah. So we're going to take a tea break until 10:40. So join by 10:40. Right.
So thing is,
there's a question, Dr. Asanta, how to correct hypophosphatemia.
Yeah, hypophosphatemia, actually, the levels are usually in Sri Lanka, we are the measures very rarely. So this solution of phosphate solution, which basically is present in the LRH, and it's not the phosphate solutions are not, I mean, commonly present in the hospitals. So we have to I mean, like the formulated one are not available, right? We have to consider about according to the patient's clinical levels, right? So I don't have any idea about the equation. So usually we are giving it's like 10 to 20 hectares. It's according to the body weight. So I don't have idea about the equation. So I will let you know in the next lecture, right? Next lecture mean tomorrow. So next question is in hyperkalemia management. Do we always have to follow an insulin dextrose bolus with an insulin dextrose infusion? Do we always have to follow an insulin dextrose bolus with an insulin dextrose infusion? No, you don't have to always go through this. So because there are several ways to manage these patients, because I mean, like you can use beta-adrenergic and you can use calcium resonium, and there are several ways. So always you don't have to do that. Is that clear? Is that you ask? What is the maximum amount of KCl that can be used per day for hyperkalemic and hypokalemia? And what is the place for oral KCl? The usually amount of potassium intake, daily intake is 1 to 2 millimoles per kg. Right? You ask about maximum amount of KCl that can be used per day for hyperkalemia, the correction. I think I have seen once it says 100 to 200, right? 100 to 200 is the maximum level. The oral KCL, yes, there's a place, but it's only the maintenance. But if you want to rapid correction, then definitely you have to consider about IV KCL. In hyperkalemia, don't we have to administer calcium chloride in the absence of ECG? Yes, because if the patient is hyperkalemia, because the potassium chloride is the the KCl calcium is the membrane stabilizer. If the patient doesn't have any ECG changes, you don't have to consider about this calcium, right? So can't we administer it is a prophylaxis of cardiac protection? Yes, you can, because in cardiac protection, definitely we use it's very good question because we are using this calcium chloride or the calcium gluconate in the as a prophylaxis of cardiac in the especially the CPR. So it is important. That's true. The most hospitals set up in urine sodium is absent, but in that case, you have to consider about the clinical scenarios and history investigation and examination. In Sri Lanka, we don't have this hi-fi investigation in all over the country. So in that case, you have to consider the clinical scenarios. So what is the calcium chloride dose? Yes, actually, usually we are using the 10% calcium gluconate 10 ml. Actually, correct dose is 10% calcium gluconate 30 ml. So 10% calcium chloride 10 ml. But in our setup, I don't know, it's like so generation to generation, now we are using 10% calcium gluconate 10 ml. But is other way around is correct. Yes, usually in anesthetics we follow that nice guideline. So if you have, I think you can get it from the internet. Please go through that. No, there is no guideline because the guidelines are formulated because they formulated in the ideal setup now. So they always consider about the absence. They always think about urine sodium as well. Okay, so again, this question, do we always have to follow an insulin dextrose bolus with an insulin dextrose? No, dear. So here, you don't have to give, here's the regime. Just remember this, right? 10 to 15 units of soluble insulin with 50% dextrose, right? 50 ml. So 50% dextrose, 50 ml, and the 10 to 15 unit of soluble insulin. There are two cannulae. Don't use it one. Two cannulae, you have to give it 1 to about over 1 hour, right? So there is no bolus management. Do we always have to follow the insulin dextrose bolus with an insulin dextrose infusion? No, there's no boluses. You have to give over 1 hour, right? Am I correct? Did you get it? In bowel obstruction patient, usually they go into hypokalemic state once kept nearby mouth for a few days. So what is the place in giving ringalactate for correction of hyperkalemia together with an oral IV KCl? Here, so remember ringalactate, which include potassium, it's usually 8 in 1 liter. And the patient with bowel obstruction, yes, you can use Hartmann's or the ringalactate, except to sodium, except to 0.9 normal saline. And you asked the question. So to correction of it is not enough, because I said that 1 to 2 millimoles per liter per kilogram. That means like 50 kilo person need 100, at least 100 or 120 millimoles per day. So we can't, so then we have to give liter of liters hardly. So in that case, definitely you have to start some maintenance of IV potassium chloride. Can we give in peripheral cannula for 50% dextrose? It's questionable because you have to dilute it. Otherwise you can't, because it can cause to stick the veins. You can't give. Yes, definitely. We can give peripheral line. So because we don't have CV line for the all patients, no, definitely we have to give. Then we have to dilute this 50% dextrose and we have to give. Yeah. Okay, I think enough question. No? Thank you very much. How long after correcting hyponatremia do we repeat investigation? Hyponatremia, like they say 2 to 4 hours. But it's in our setup, you don't have to do that much earlier. I think 8 hours is enough, like TDS is enough. Thank you. I don't have any idea about that, because maximum dose of IV calcium, extremely sorry, I don't have that idea, because anyway, because again it's a drug now, so you have to consider about the level of the, it's a depend on the patient. We don't know the deficit of the patient. If the patients, we have to correct the deficit. They have to correct the deficit, because if we are giving more calcium, so that the patient end up with hypercalcemia, right? So then, because of that, there's no maximum level. It's based on the patient's concentration, patient's deficit level. Okay. I think now all questions are finished, right?
Right. Thank you, Dr. Asantha, for that lecture on this electrolyte imbalances. So we'll start the lecture on ICU general management by consultant anesthetist Dr. Pandula Jayatilaka at DGH Matale. Over to you, sir.
Okay. Okay. Thank you, Dr. Roshan. Okay. Good morning, everybody. Give me a few seconds to share my screen. Right. Can you see my screen?
Yes. Yes.
Okay. I'll make it full screen. Right. So this lecture, we are going to talk about general management of an ICU patient. Another important topic in intensive care. So in this lecture, I'm going to talk to you about basically 4 of the 5 main areas of general management of an ICU patient. So those areas are nutrition, physiotherapy, DVT prophylaxis, prevention of bed sores, and also stress ulcer prophylaxis. And in this lecture series, actually, we discuss about how it relevant in especially COVID-19 patients. So I will be briefly touching about how different it is from the normal patient and compared with the COVID-19 patient. So starting with nutrition. So nutrition is important in any patient. So if you take an intensive care patient who is critically ill, it is more important than any other patients, because now critical illness is there is increased energy utilization, and also there is increased catabolism because of illness. So because of this critical illness, there are a lot of adverse effects like muscle wasting, weakness, and patient is at risk of infections, and wound heal is impaired, and patients will take prolonged time to recover, and prolonged mechanical ventilation and long ICU stay and also increase ICU death. So if patient has not met with adequate nutrition, you might expect these all complications in critically ill patients. Now, when we should consider medical nutrition therapy. Now, medical nutrition therapy, it's all the nutrition that is enteral or parenteral. So we have to consider in all patients according to the ESPN guidelines. If patient is going to stay more than 48 hours, we have to consider starting nutrition. Either it could be enteral or parenteral. But enteral feeding or nutrition is always preferred because it has a lot of advantages over parenteral nutrition. So the enteral nutrition is that you are feeding through the patient's GI tract. So it could be oral, nasogastric, nasojejunal, or even directly to the jejunal. So oral intake, if not possible, we usually go for nasogastric or nasojejunal feeding. And also the continuous feeds are preferred over intermittent feeding. Now, if there are contraindications to enteral feeding, the parenteral nutrition, that is nutrition given via intravenous access, has to be implemented within 3 to 7 days. Now, the feeds should consist of all the nutrients that required by any person. So it should include carbohydrate, proteins, lipids, as well as vitamin and minerals. Now, the type and amount depend on the patient's nutritional status as well as the patient's other existing medical conditions, such as whether the patient is having liver failure, renal failure. And nowadays, we get the input to the intensive care from the specially trained doctors in nutrition, nutritionists who are holding MAC or the MD in medical nutrition. So we get the input from the doctors in specialized in nutrition, and they are looking after the patient regularly, and we get the input. So what are the adverse effects of nutrition therapy? Now, aspiration and the fluid overload could be a problem with especially aspiration can result if patient is having reduced level of consciousness, as well as if patient is having bowel obstruction, and if there's delayed gastric emptying. And also overload, if you don't calculate the amount of fluid intake required by the patient, fluid overload will be a problem. The refeeding syndrome is when you given the patient's nutrition, and when the patient when the patient is having some degree of malnutrition, and if you are going to start with the normal nutrition therapy, there you going to result electrolyte imbalances, especially hyperkalemia, hypophosphatemia. So this is called a refeeding syndrome. And also, if you don't provide adequate glucose energy, patient might result with either hyper or hypoglycemia, depending on the patient's other existing medical conditions such as diabetes. And dehydration, if you don't give enough fluids, and electrolyte abnormalities if your nutrition therapy included too much of electrolytes or less amount of electrolytes. So patient has to be monitored regularly, especially with the intake output and the blood sugar levels, and also with electrolyte levels when you have started nutrition therapy. Now, our preferred route would be enteral feeding, but if patient is having intolerance to gastric feeding, usually we start with metoclopramide. So you can give metoclopramide 10 milligram TDS IV dose, and if you need another prokinetic, we usually go for erythromycin. Erythromycin, usually IV or oral would be preferred. So the dose would be 250 3 times a day. Now, we have to consider delaying of enteral feeding in certain conditions, such as if patient's gastric aspirate volume is more than 500 ml per 6 hours, and if patient is having upper GI bleeding and high output intestinal fistula, bowel ischemia, and abdominal compartment syndrome. So most of the GI conditions you have to think whether patient will tolerate enteral feeding. And also uncontrolled shock, like if patient is on multiple iron probes and still blood pressure is not picking up, then we might not thinking of giving enteral feeding. Now, this is an algorithm recently published in British Journal of Anesthesia on deciding on how to go for enteral or either parenteral nutrition. So when you look at this, you might confuse and it looks complicated. But if you clearly study, you can understand what are the routes you can select. Now, first we have to ask the question: should the patient fed via stomach? Yes, yes. If patient is at high nutrition risk and cardiovascular stable, you can select yes. If patient can take orally by themselves, yes, then you can ask the patient to take volitional. If patient if you patient cannot feed themselves, then if they can take within 48 hours, then you can go for enteral feeding, right, in this arm, and that is NG or either other nasojejunal feeding. Now, if a patient is having a relative contraindication, and if it's going to subside within 48 hours, if you can wait for 48 hours, then you can wait 48 hours and think of starting enteral feeding. Now, when we start enteral feeding, that is, we usually start with a small amount of energy as well as other nutrition, which is called trophic enteral feeding. And sometimes, most of the time, we start with prokinetics, and if patient is tolerating, we go for full enteral feeding. Now, the trophic enteral feeding is considered because when a patient, most of the time with malnutrition, they are giving a full enteral feeding, they are going to result with various like electrolyte abnormalities, like pre-feeding syndrome, as well as hyperglycemia. So we start with trophic enteral feeding. And if patient is having absolute contraindication, or if patient is not tolerating the enteral feeding, like a patient is having gastric residual volume more than 500 ml for 6 hours, and vomiting and diarrhea and any other contraindications, yes, then we direct the nutrition therapy towards the parenteral nutrition. Yes. So when we go for the enteral feeding, usual patients, if they cannot take an orally, we go for nasogastric feeding. Nasogastric tube has to be inserted. I think you know how to insert it. You have to take the appropriate length, and you have to confirm it in the stomach. So the gold standard way of confirming the NG tube placement is by the chest X-ray. But it is not a routine practice in our setup, taking chest X-rays for each and every patient to confirm the NG tube. So other methods we use would be aspiration for the stomach contents and the Bush test. So you probably have done this. And what you do is you give some air, inject some air through the NG tube with a large syringe like 20 cc and auscultate over the stomach. So if you hear the sound, you take it as in the stomach. And also using pH strips to confirm gastric pH also is another method. So, but the gold standard, I would like to repeat, is the chest X-ray. So what are safety practices in NG feeding? So confirming the position is very important. Even patient is intubated, still you have to confirm the tube is in the stomach because sometimes the tube might be coiled in the throat or even the esophagus, so better you have to each time when you feed the patient, confirm the NG posture in the stomach. And keeping the patient tilt, head up tilt of 30 to 40 degrees will help, especially it will minimize the microaspiration. Then if patient is intubated or with the tracheostomy tube, check the cuff inflation, which prevent the aspiration of the gastric content. And every 6 hours, we have to aspirate NG tube, NG feeding, and then look for the residual volume and look for the feed intolerance. And the aspirate less than this amount, less than 500, we have to return back to the NG and to prevent the electrolyte losses. And usually it is the continuous drip feeding is recommended nowadays rather than intermittent NG feeding. Yeah, so the parenteral nutrition, we have to have a venous access. So it could be either peripheral or central venous access. Now, total parenteral nutrition, if you are administering through a central venous access, you have to have a dedicated separate line for that, because if you don't have dedicated line in the central venous line, then it will predispose to infections, especially long-term IV parenteral nutrition through central line can result especially fungal infection. So because of that, nowadays nutrition medical therapy is preferred for if it is for shorter time nutrition therapy, parenteral nutrition. Peripheral access would be preferred over central venous access. Especially nowadays we have preparations which are prepared for peripherally administration, like Cabivan is one of that those preparation which can administer via a peripheral cannula. But earlier days we had to have actually a central venous line to administer total parenteral nutrition, because most of these solutions are hyposmolar solutions like 50% dextrose, then the aminoplasmin. Those are actually hyposmolar preparations. So we have to have central venous lines. So these central venous line have to keep kept clean and covered, and have to use only for nutrition therapy. And before administration of these nutrition preparations, we have to look for any discoloration and change in the consistency, and because otherwise this might be contaminated or damaged. So we have to be careful with that. And hand hygiene and sterility is very important. Right. So in COVID patients, we usually start air nutrition therapy, especially enteral nutrition. If patient is having any contraindication, we go for parenteral nutrition. Moving to the second aspect, that is deep vein thrombosis prophylaxis. Now, deep vein thrombosis is a formation of deep clots in the deep veins in the lower limbs. The incidence is about 0.5 to 1%, 1 per 1,000 population. Especially patients who are immobilized, as well as patients with trauma and patients with indwelling intravascular catheters, which having very sluggish blood flow in deep vessels in the lower limbs will result these deep vein thrombosis. So what happens is these blood clots which are formed in the deep veins will break through and can travel to the heart, right side of the heart, and to the lungs, can result pulmonary embolism. And if it is a large embolus, can result life-threatening embolism and instability, cardiovascular instability, and death. So patient has to be identified actually before coming to the intensive care unit. When the patient is admitted to the hospital itself, at the first instance, we have to identify the patient risk at developing DV. So what are the risk factors? Indwelling venous devices, CV lines, vascular catheters, and surgeries involving abdomen, pelvis, and orthopedic surgeries, especially in the lower limbs. Major trauma, patient with malignancies, pregnant patients, and any patient with history of deep vein thrombosis, and also obese patients. These patients groups are considered risk for developing DVT. So how to prevent DVT? So prevention is very important. So early mobilization and physiotherapy important, and keeping adequate hydration will keep the blood viscosity in optimum condition. And the commonly used methods, mechanical and pharmacological methods, are two methods. So the mechanical methods are pneumatic compression stockings and the DVT pumps. And then the pharmacological methods, we have several categories of drugs. So pharmacological agents, we have mainly heparins, two types of heparin, unfractionated heparin and the low molecular weight heparin. So when you take these two types, nowadays more preferred category or type is low molecular weight heparin. The low molecular weight heparin, the DVT prophylactic dose, we have the commonly available one is enoxaparin. The recommended dose would be 0.5 milligram subcutaneously once a daily dose. And usually 30 or 40 milligram would be adequate for an average patient. And if you are using unfractionated heparin, it will be 5,000 units, but we have to use more frequently. That is the disadvantage of heparin, unfractionated heparin over low molecular weight heparin. You have to give twice or thrice a day. But low molecular weight heparin, single daily dose is adequate. So and then you don't need to monitor if you are giving low molecular weight heparin. But low molecular weight heparin also now can result like unfractionated heparin bleeding, but you don't need to monitor regularly. And if you are going to treat with DVT, treat the DVT with these the dose, you have to give a higher dose. And other newer anticoagulants are fondaparinux and rivaroxaban, but not widely available in our setup. And there are some contraindications for DVT pharmacological prophylaxis. Now, absolute, if patient is already anticoagulated, don't need to contraindicated. If patient is having active major bleeding, and if any recent clinically significant bleeding within last 48 hours, and patient with thrombocytopenia, platelet count less than 50,000, and if patient is having any acquired or inherited bleeding disorders. And the contraindication, the relative contraindications are surgical procedures with high bleeding risk, recent gastrointestinal genital bleeding, central nervous system bleeding, and intracranial spinal lesion, right? Yeah, sorry about the interruption. And there are certain relative contraindications as well. Right, so when you move to mechanical methods, we have two main methods. The commonly used method is graded compression stockings. So we use stockings which are specially designed for DVT prophylaxis. And you have two types, it's up to the thigh level and the below knee level. But up to the thigh level ones are much preferred. So the physiological or physical principle behind this is when you apply these stockings, it created graded pressure along the lower limbs. So more pressure towards the ankle at the ankle level and less pressure towards the body. So what happens is when there is higher pressure from the foot and it will support, augment the blood flow from the foot to the thigh level. And so then when you select these stockings, you have to select the appropriate size, because if you select too large or too small stockings, your desired effect won't be there. That means because we have to have that pressure gradients along the lower limbs towards the body. But if you don't have the appropriate size stockings, you don't get the desired effect. So, but the problem is now we don't have these in the hospitals, not provided by the hospital. So we have to get down from the outside, from private sector. So whenever patient comes to the hospital, you have to give the prescription for the DVT stockings if patient is at risk of getting DVT. So then the mechanical method, second method is the intermittent pneumatic compression pump. So this is not widely available. Even in the intensive care units, we don't have these compression devices for each and every patient, because the pumps and these cuffs are not available for each and every patient. Especially these cuffs are consumables, and so when we purchase the pump, and we will be getting few cups. We are left with the these compression pump only. But these are very effective, because if you take the mechanism, now you have two bladders for the calf level and the thigh level, and these bladders are inflating intermittently. So when at first the bladders at the calf level will be inflating, and then the blood will be pumped towards the thigh, and when after that is inflated, next moment the cuff at the thigh will be inflated. It will be squeezing the venous blood towards the body. So it's very effective, but only problem is the availability for all the patients. So if patient is at very high risk of DVT, like patient with 2 or more conditions, risk factors for DVT, especially with the past history of DVT, yes, this method would be better method than the stockings. So there are certain contraindications, like if there are local problems in the lower limbs, like peripheral arterial diseases, ulcers, recent skin graft, and peripheral arterial bypass grafting, and severe leg edema, pulmonary edema, and these are several contraindications for the mechanical DVT prophylaxis. Right, so the COVID-19 patients, yes, because we know they are at the risk of thrombosis, especially microvascular thrombosis. So DVT prophylaxis, especially pharmacological prophylaxis, are started as early as possible. So moving to the physiotherapy, physiotherapy is very important aspect in the intensive care unit, because especially patients who are immobilized, like patients who are intubated on ventilation, and patients who are having major trauma, they are at risk of problems of immobilization and resulting respiratory, musculoskeletal, and neurological complications. So the objective of physiotherapy in the intensive care unit is to prevent mainly respiratory complications, like such as clear the respiratory complications and improve oxygenation. Like now, what happens is if patient is immobilized, and when patient cannot breathe normally, what happens is clearance of secretion from the lungs will be affected. So what happens is these secretion will accumulate in the alveoli, and will result the collapse of the these airways and the alveoli. What happens is then it will affect the gas exchange, and so we have to inflate these collapsed alveoli, and also we have to remove the secretions which are collected in the alveoli, and then to improve the ventilation. So the physiotherapy will improve the clearance of the secretion, and also the recruitment maneuvers with the ventilation will help to bring back the collapsed alveoli into the normal level. And so this physiotherapy is very important who patients who are on ventilatory support and to wean from the ventilation. And the musculoskeletal physiotherapy will prevent and help to manage the intensive care acquired weaknesses, especially if patient is on the bed for longer time. A patient will result with especially myopathy, and then the neuropathy, and especially joint stiffness. So these complications can be prevented with the physiotherapy. And also we have mentioned immobility is a risk factor for DVT. So physiotherapy will help to prevent DVT. And the procedures that we used in physiotherapy, especially the physiotherapies, the intubated patient, we use manual hyperinflation, ventilator hyperinflation, positioning, and percussion, vibration, and suction. And in non-intubated patient, we use mobilization and periodic application of non-invasive ventilation and deep breathing exercises and incentive spirometry are used in non-intubated patient. So in COVID-19 patient, we have to give physiotherapy, especially when we give the respiratory physiotherapy, we have to be careful with the aerosol generation. When physiotherapy is given, we have to, anyway, we are wearing the full PPE, and but have to be very careful with your personal protective equipment. And also in an intubated patient, it's very important to use closed suction method. That is, the closed suction unit has to be used than open suction, because the suctioning will anyway result aerosolization, but if it is closed suction, the risk is very minimum, which is or the pathogens or the virus particles won't go to the surrounding environment. So extreme caution has to be practiced to avoid unintentional disconnection of the ventilator circuits. Then moving to the fourth area, that is the prevention of bed sores. So what is a bed sore? It is resulted because of localized injury to the skin and then to the underlying tissue. Usually it's over a bony prominence as a result of pressure or pressure in combination with shear forces. Now what happens is, when there is compression of soft tissues or the bony prominence, and there will be interruption of blood supply because there will be compression, and then the supply of nutrition and the oxygen to the capillaries at these tissue will be limited, and then can result with tissue ischemia. And then the tissue ischemia and then the edema all will resulting tissue death, and so then it results with the bed sore. So what are the most vulnerable locations? Sacrum, coccyx, heels, and the ear. And so if it's prolonged pressure over these areas, tissue death will be the result. So you can see various degrees of bed sores in these pictures, right? So we'll be coming into details of degrees of bed sores. So what are the implications of bed sores in the intensive care unit? So it's obvious patient will be having a prolonged hospital stay and increased cost for the healthcare, increased mortality, and the indicator of quality nursing and supportive care in the health system. Yeah. So in the prevention and management of bed sore, we have several steps. That is risk assessment, then we have to assess the skin, and then various supportive methods. In the risk assessment, there are several scales available, like Norton scale, Waterloo scale, and several other scales, but we are not commonly used these scales. But to highlight the important risk factors in the ulcer prevention treatment policy, we have to use various scores in the assessment of the DVT prophylaxis, and in the bed ulcer prevention. So the BMI is another important aspect of risk assessment, and the skin type, and then the sex, and also the malnutrition, and the weight loss, and also the continence, mobility. We have to assess during the risk assessment of the bedsore risk assessment scores. Now, depending on the scores, we can categorize whether patient is at risk of high risk, low risk, or very high risk patients. Now, in the skin assessment, we have several grades of skin, that is grade 1, 2, and grade 3, and grade 4. And so grade 1 is non-blanchable erythema of intact skin, discoloration, and there will be skin warmth, edema, induration, and there may be a hardness of the skin. In the grade 2, there will be skin loss, that could be partial loss and involving the epidermis, dermis, and pore. And in the grade 3, full thickness skin loss involving the damage or necrosis of the subcutaneous tissue that may be extended down to the underlying fascia. And in the grade 4, there will be extensive tissue destruction, tissue necrosis, and damage to muscles, bone, and supporting structures. Then, what are the supportive measures we can do to avoid bed sores? So we have to avoid hard surfaces, and especially any wires, bed railings under the patient's skin, and with the direct contact for long period. And also, when we prepare the linen, we have to avoid creases, and also air or water mattresses in high-risk patients. And then also avoid skin soiling with stool and also with urine is important. And also, we have to turn the patient from side to side supine every 2 hours. And also, we have to offload skin wherever the integrity is compromised. And also, we need to have surgical debridement, especially if the bedsore is stage 3 or grade 3 or grade 4. And also, we have to have wound cleaning regularly to support the wound healing. So, in COVID-19 patient, we have to think of avoiding development of bed sores, especially if patients are immobilized who are on ventilator support. It has to be considered. So in the 5th area, we are going to discuss about the peptic ulcer prevention. Now, peptic ulcer prevention is very important because all the patients are in a stress condition, and so they are at risk of developing stress-related mucosal injury. And most of these stress ulcers, peptic ulcers, are superficial and asymptomatic, but rarely it can progress into large significant GI bleeding. But you can see in these pictures the types of peptic or the gastric ulcers. Initially, there would be erosions, and then it can lead to an ulcer. And then, why they are at risk of developing these ulcers, erosion? Because they have a mucosal blood flow which is reduced, and then it will result in the lost integrity of the mucosa, and then these ulcers can erode into the submucosa and muscle layer, and then it can result bleeding, and erosion can result significant bleeding from the blood vessels. So what are the risk factors? Especially patients who are on mechanical ventilation for longer time, sepsis, major surgery, severe burns, and myocardial infarction, And patients who are on high dose corticosteroids, any patient following major trauma, hypotension, these all now, if you take intensive care units, most of the patients are having one of these risk factors. So routinely, we are giving peptic ulcer prophylactic patient for all the intensive care patients. So what are the common pharmacological agents we use? It is H2 receptor blockers or proton pump inhibitors. So we use either ranitidine or famotidine, and proton pump inhibitors we are using either omeprazole or pantoprazole. And the other drug medication classes are sucralfate and the antacid. And so we mentioned earlier in enteral feeding that it protects you against peptic ulcer formation. So peptic ulcer prophylaxis also considered in all the patients with COVID-19 who are treated in the intensive care unit. Right, so that's all for today on this topic. Right, I think I saw one question about the Bush test, why it is considered the Bush test is not reliable yet. Because now, even if the now sometime when your NG tube is in the lungs, it also can result a positive Bush test. Or if it is in the esophagus, it also can result positive Bush test. So we need to confirm that the NG tube is in the stomach. So the X-ray would be confirmative whether NG tube is in the stomach or not. But the Bush test would be 100% confirmative of it's in the stomach. Yeah. Another question is what is the place for nebulization other than chest physiotherapy in ventilated patients? Yeah, so the nebulization actually we are using several pharmacological agents like either salbutamol or ipraven. It will improve the ways the bronchodilation. So the dilated small airways bronchioles will support the flow of mucus in the ventilated patients. And also the nebulization with saline will also support the loosening of the thick secretion. So one of the problems with ventilation will be the secretion will be very thick, and then it is very difficult to remove the secretion from the physiotherapy alone. So the secretion will be loosened when you nebulize with the saline, as well as NAC, N-acetylcysteine also will support the loosening of the secretion from the lungs. So that is also used commonly in chest physiotherapy with the nebulization to loosen the secretion from the smaller airways. Yeah, in ventilator-associated pneumonia, chlorhexidine mouthwash can be used. Is it for all ICU patients or ventilator? I think you can use for any patients because usually used for the ventilated patients because to prevent ventilator-associated pneumonia. But you can now, usually we don't use for all and every patient, but it's mainly reserved for the ventilated patients. So what is the place for GTS? I don't know about the GTS. What is the yeah, I think this is for the protection of eyes. Yes. So yeah, the protection of eyes, definitely you have to use natural yes, natural tears will be very helpful to prevent ulceration of the eyes. So we have to always keep the eyes closed, and also otherwise, if it gets open, it can result with exposure keratitis. So application of natural tears will make the eyes. It will prevent the formation of exposure keratitis, right? Yeah, now for nebulization of ICU patient, is it usually we use normal saline, but if you want to if patient is having very loose secretion, yes, you can use sometime hypertonic saline, and it will prevent the too much of secretion formation, and then the you can use hypertonic saline both, right? Either normal saline or hypertonic saline can be used for nebulization. Right. So what else question? Yeah, I think we can move to the next lecture. Right. Right. Yeah, I think micronutrients is also included in the parenteral or even enteral nutrition therapy, because not major nutrients only, but micronutrients also included in the nutrition therapy. Yes. I think next lecture is scheduled will be done by Dr. Malaka Munasinghe, consultant anesthetist from DGH MENA. I think is Malaka ready?
Yeah, I'm ready, Dr.
Right. Okay. Over to you, Malaka then.
Thank you, Dr. Mandula. Is my screen visible in the PowerPoint full screen mode? Dr. Madhushan? Is my screen visible in the full screen mode? Can everybody hear me and see me? And my screen as well? Okay. All right, then I'll start. Right. Okay, good morning, everybody. So this is the second day of this very important workshop on critical care medicine, conducted by the College of Faculty of Critical Care Medicine and the College of Anaesthesiologists. So I think you have had very interesting and very informative lectures, and not only in critical care, but as in general, as doctors, the cardiopulmonary resuscitation is very important. So this next 40 to 45 minutes, we'll be discussing about the adult cardiopulmonary resuscitation and the basics of the adult cardiopulmonary resuscitation. So if you have any questions, you can ask the questions at the end, or if we don't have enough time, I'll be answering them So you can put them on the chat box. So I'll be answering, provided the time is not adequate, in the chat as well. Right. So the learning objectives, we'll be discussing about the basic and the advanced life support, their algorithms. So we'll be discussing about these algorithms. So these algorithms, there are different algorithms, but what we follow in Sri Lankan Anesthesia College is following the European Resuscitation Council guidelines. So there was an update on 2021. So we'll be discussing about this update as well. So we'll be talking about the shockable and unshockable rhythms during the advanced life support. So I'll explain it in the coming slides, and the reversible causes of cardiac arrest, and what are the changes that should be done for the basic and the advanced life support in a patient with suspected or confirmed cases of COVID-19. Right. So why the cardiac pulmonary resuscitation is important? Because now around 40% of the deaths under the age of 75 years are due to cardiovascular disease, and around 60% of the adult patients who have coronary artery disease can have sudden cardiac arrest. So it is quite common to have cardiac arrest in cardiovascular patients, which is like a very common and worsening non-communicable disease at present. So importantly, 1/3 of the patients developing myocardial infarction, they will die before reaching the hospital. So it is very important to see this, to develop how to diagnose cardiac arrest early and to resuscitate these patients and to have good outcomes. So in cardiac arrest, as you all know, the brain and the vital organs will not have adequate perfusion. So unless you restore the circulation very quickly, so ideally within minutes, there will be permanent end organ involvement, and at worst case scenario, you will not be able to resuscitate the patient. So they have shown that with each minute that passes, the likelihood of survival following cardiac arrest decreases by 7 to 10%. So each minute, so remember that. So in cardiac arrest, we call this chain of survival. So basically, there are 4 steps. So most important thing is to identify the cardiac arrest before it occurs. So it is the early recognition, call for help if you are not able to manage the patient then and there, and if you don't have the expertise, better to have senior help or any experienced help at hand to prevent cardiac arrest. So what we will be talking about in this lecture is the administration of cardiopulmonary resuscitation. So it should be very, very early, and if the patient has a rhythm which needs shock or which is suitable for shock, we go for early defibrillation or early shock. And at the end, if you are fortunate enough and if you have been successful in attaining this what we call as return of spontaneous circulation, or if you have been successful in getting the patient revived, we go for post-resuscitation care as well. So we'll talk about the post-resuscitation care at the end of the lecture as well. So this is the guidelines. We'll be talking about this in detail in the next coming slides. So there are basically 2 types of life support when it comes to cardiopulmonary resuscitation. That is the basic life support and the advanced life support. So the name itself says the basic life support means that you will not have some of the equipment, the drugs, or even the expertise. So in the basic life support, the first thing what you should do is to confirm the cardiac arrest. So how do you confirm the cardiac arrest? So you go to the patient and make sure that you and the patient are safe. So what you can do is you can check whether the patient is responding or not. So this you can do by either calling the patients by name. If you know the name, or you can gently tap on the shoulder or gently shake the patient to check for his responsiveness. So if the patient is not responsive, highly likely that patient is either in cardiac arrest or some sort of a reversible cause for this unresponsiveness. So you can use better check you should open the patient's airway and check if the patient is breathing normally or not. So this lady, you can see she has looked for responsiveness. Now she's looking if the patient is breathing or not after opening the airway. Is it necessary to check the pulse or the circulate pulse during the this confirming cardiac test? Actually, you don't have to check the pulse if you're not confident enough or if you're not skilled enough to check. So basically, what you have to do is you have to check the patient responsiveness. If the patient is not responding, you should open up the airway and check whether the patient is breathing normally or not. Because sometimes there can be abnormal types of which you will like falsely assume that patient is breathing, but some type of breathing like agonal type of breathing, the gaspy type of breathing, which are also like features of cardiac arrest. So remember that. So opening up the airway, you can check whether the patient's airway is obstructed by secretions and whether there are foreign bodies, blood, or even the tongue has fallen back and obstructing the airway. So in cases of secretions, you can suck out the secretions, and only under direct vision you should remove the foreign bodies. So remember that, because otherwise you can further advance the foreign body further into the airway and make a complete obstruction. And you can make the airway patent by doing the triple maneuver. So basically, you should remove any foreign bodies, and you can do the triple maneuver, or unless contraindicated, the jaw thrust in opening up the airway. So this, you can see this. Basically, the triple maneuver consists of chin lift, head tilt, and jaw thrust. I think it has already been taught you in the previous lectures. So unless if the patient is having a suspected cervical spine injury, you are basically only performing a jaw thrust or a sort of modified jaw thrust, because otherwise you can worsen the cervical spine injury by doing a head tilt. Right. So how do you check for normal breathing? So you should basically look for breathing and chest movements. You should listen for breath sounds, and you should feel for expired air. So this lady, she's performing the looking, listening, and feeling. Sorry for that. So next, if you are confident enough and you are confident, you can check for pulse, but it is not essential. So basically for adults, you should check for carotid pulse. So that you just place your fingers just inferior to the angle of the mandible. Then you should be able to feel carotid pulse. But this is not quite practical unless you are if you have done a lot of pulse checks in cardiac arrest. It will not be very feasible and practical. So you should not spend a lot of time checking for pulse. So what the guideline says that you should not waste more than 10 seconds to check for pulse. So remember that. So basically, if the patient is unresponsive and not breathing normally, plus or minus absence of pulse, you should call for resuscitation team. So in other hospitals, and especially in other countries, developed countries, there are established resuscitation teams which consist of anesthetists, maybe emergency physicians or physicians, and rest of the supporting staff. But if you don't have a resuscitation team, what you can do is you can call the anesthetic team or the medical team, depending on the availability of your hospital. But after calling the resuscitation team, the most important thing is to start cardiopulmonary resuscitation quickly without delay. So in adult cardiopulmonary resuscitation, what we do is we give cardiac compressions followed by ventilatory breaths. So basically, the ratio is the 30-to-2 ratio. That is, you give 30 cardiac compressions followed by 2 ventilatory breaths, and this will be continued in cycles. So remember that to minimize interruption, it is very important, because as we already discussed, with each time and seconds pass, the ability for you to revive the patient is reduced. So base idea is by cardiac compressions is to maintain the perfusion to the vital organs as much as possible. So what the guidelines says is that you have to continue the compressions 100 to 120 per minute. So basically, these 32 compression cycle, 30 compressions, 2 ventily breath cycles, around 3 to 4 cycles you should be completed within the minute. So basically we are talking about a rate of around 10 breaths per minute. So remember that. So you make sure that you don't compress too slow or too high, too fast, and you give the ventilator breaths as well. So what the guidelines is says that until you establish a definitive airway or a laryngeal mask airway, the compressions should be halted for these 2 ventilatory breaths. So basically you give 30 compressions, stop it, and we give 2 ventilatory breaths using the amp bag or whatever you can have, even if the pocket mask is also available at the moment, especially if you are doing the compressions in outside of the hospital, you can use it and you can relate it then. Right. So cardiac compressions, how do we do it? So basically you have to place your hands at the mid of the lower half of the sternum. That is mid of the lower half of the sternum, and these should be uninterrupted chest compressions. So as I already mentioned, you should stop these only for ventilated breaths, and especially we'll be talking about these rhythm checks and defibrillation in the next coming slides. So during the rhythm checks and defibrillation also, you should stop the cardiac compressions, but remember that these should be good quality chest compressions, ideally at least 5 to 6 centimeters in depth, and you should make sure that you allow for recoil. That means the idea of the compressions is to squeeze the heart, so get a cardiac output out of the cardiac output, and to get for the venous return to come back, there should be a reduced, like you should make sure that the negative intrinsic pressure should be negative, so there will be like sucking of blood into the heart. So that is why you allow for recoil, to allow for negative intrinsic pressure and to get the heart filled with blood. So remember that usually if we take the more normal cardiac output as 100% in a normal patient, even with very good quality chest compressions, you can achieve a cardiac output of around 30 to 40% of that. So you should make sure that you are like allowing good compressions. Excuse me. Give me a minute. Finally, can you ask everybody to be like silent during lecture there? Right, sorry for that. Right. Now here you can see that in the uppermost corner, you can see that in the lower half of the middle of the sternum, these hands are placed, and the in the lowermost. Sorry for that. In this picture, you can see this lady is performing a cardiopulmonary sedation. So she has her interlocked fingers, so which means the fingers of the hands are like wrapped on each other, and her wrists and the elbow are straight. Elbow is straight, and she is like putting her all the weight towards the patients, so that this is a correct sort of compression. Assume, let's say in a ward setup, you can't like have this, you can't like make your body weight get onto the patient's chest. So in that case, what you can do is you can like get on the bed, or in other instances you can put, if you're short, if you're not tall enough, you can like get on a pedestal or a stand, and you can deliver the chest compressions. So this basic life support basically consists of cardiac compressions and ventilatory breaths. So the basic life support should be continued until the patient recovers hopefully, or you get exhausted, or if the resuscitation team comes. So I'm sorry, I am facing a few technical difficulties. Sorry about that. Right. So the resuscitation team will consist of skilled people, skilled personnel, who will have different roles during cardiopulmonary resuscitation, and they will come with drugs and certain equipment. So we'll move on to the advanced life support in the next coming slides. So now when the resuscitation team comes, they will take some equipment with you, especially a defibrillator. So in case if you have a defibrillator in your ward, then they will take the defibrillator and they will connect the patients to the defibrillator. So the idea of connecting the defibrillator to the patient is to check the rhythm of the patient. So depending on the rhythm, there will be different right. So this is the way how you connect the defibrillator pads. Basically, there are 3 electrodes, ECG electrodes. So you should know the different colors, because there can be several changes to the colors of the electrodes. But basically, there will be 3 to 5 electrodes, and we'll check the rhythm. So before checking the rhythm, you have to basically briefly discontinue the cardiopulmonary cardiac compressions, because otherwise you will falsely get into a conclusion that the rhythm generated by the cardiac compressions is the rhythm which the patient is inherently having. So idea is to discontinue the cardiac compression briefly to check the inherent rhythm of the patient during the cardiac arrest. So basically, there are 2 types of rhythms: shockable and non-shockable type of rhythm. So shockable rhythms means that patient is suitable for defibrillator shocks, and non-shockable rhythms are is that patient's rhythm is not suitable for defibrillator shocks. So we'll be talking about in the next slides. So idea is to connect the ECG leads, assess the rhythm. So what they say is not to waste more than 5 seconds to check the rhythm. So after checking the rhythm with the shockable and non-shockable, the management is different. So one thing is pulseless ventricular tachycardia, and the other thing is the ventricular fibrillation. So these 2 rhythms are suitable for shocks. Right. So we'll talk about the ventricular tachycardia. This ECG, you can see it's like a regular, very fast rhythm, and you can see these are the QRS complexes. These complexes are usually broader than normal, but it is in a rapid rate. So these are called as a monomorphic ventricular tachycardia, and there's a different type that is called polymorphic ventricular tachycardia, where as those are so the management is a bit different. But anyway, if the patient is having the ventricular tachycardia as the initial rhythm, you don't have to check the pulse, because you assume that the patient is in cardiac arrest. So you take it as a pulseless ventricular tachycardia if the ventricular tachycardia is the first rhythm, right? So in that case, you give a shock and right. So unfortunately, there was a clarification. I don't have it, some issue with these things. Sorry about that. So idea is to check the rhythm. You decide whether the shockable or non-shockable, and as we have already discussed, to minimize the interruptions to cardiac compressions, and as it will take some time for the energy to be delivered, which means there are several steps before you deliver the energy. There are several things that you have to do, so it will take some time. So because of that, until you get all this sorted out, you need to restart the CPR after assessing and confirming the rhythm. So remember that. So you don't wait until you give the shock. So you assess the rhythm, immediately restart CPR. Then meanwhile you select the energy. You have to select the energy for the defibrillator shock. Then you have to charge the defibrillator, and then only you have to deliver the shock. Because as this takes time, you will immediately restart CPR after checking the rhythm and assessing the rhythm. So while now we have to check, select an energy, and I'll talk about the energy in the next slides. Then you have to charge the defibrillator. So during this selection of energy defibrillator, you should keep the free flowing oxygen away. So because as the oxygen is like, it will aid the burning process, you are giving a safe shock or the safe defibrillator. So make sure the free flow oxygen is kept away. So what you can do is you can like take the ambu bag and hold stuff at least 1 meter away from the patient, and you can switch off the oxygen, but make sure that you are again switching back the oxygen and you are again giving the related beds to the patient, because what will happen is you stop. Right, sorry for that. So what will happen is, if you switch off and you forget to like switch back the oxygen, then the ventilator vest will not be effective, right? So make sure that you keep the free flow oxygen away, and except for the person who is continuing giving the compressions, rest of the people should stand away. So we'll be talking about who are these other people who will be helping you during the cardiac compressions and the advanced life support. And you should apply gel on the patient to prevent burns, as a high energy electric shock will be delivered to the patient, and it can cause burns to the patient, and also to make sure that the electric shock is effectively dissipated onto the patient's chest. Right, you deliver then what you do is, when everything is ready, you stop the cardiac compressions and you deliver the shock, and you immediately restart CPR. So idea is basically, the whole idea to minimize the interruptions to the cardiac compressions. Right, so in the cardiac advanced life support, there will be 2-minute cycles. So basically what you do is you assess the rhythm, give the shock, then you continue the cardiopulmonary cardiac compressions for 2 minutes without interruptions. So basically the idea is that, so you give cardiac compressions for 2 minutes, then stop cardiac compressions, assess the rhythm, then again restart cardiac compressions. If an energy is indicated, you give the energy, or unless you continue the compressions in non-shockable rhythms, which we will discuss in the future slides, and like that. So it will be sort of a 2-minute cycles, and somebody should be noting down the time. So the person who is noting down the time is called as the scriber. So there should be a person for that as well. So these are the energies that usually we use. So initially, there are 2 types of defibrillators at the moment. Monophasic one was the older version, and biphasic one is current. So monophasic one, only one phase of current energy is delivered. So they have found that it is the damage to the cardiac myocytes are comparatively higher compared to defibrillators. So they now most of the us we are using the biphasic these defibrillators. So the amount of energy in the biphasic defibrillator is quite less compared to monophasic ones. But unfortunately, if you have monophasic defibrillator, the first energy, if energy shock is indicated, let's say in a VF or a VT, the first shock will be a 270. If it is monophasic one. If it is a biphasic one, it will be roughly half of that, around 150. It is 150 joules. So if you are not not sure about the amount of energy to be delivered, or let's say if it's an older version of a defibrillator, what you can do is you can dial. There's a dial. You can set the dial to highest available energy, and you can deliver the shock. So rather than not delivering the shock, early delivering of shock or early fibrillation is what is indicated. So you can do that. Make sure that you don't delay the shock. Right. So these are the places where you can place your defibrillator pedals. There are two pedals. One is under the right clavicle, and the other thing is in the apical region. So these are basically in the anterior chest, but in some instances, some are using anterior and posterior defibrillator pedals as well. But commonly, this is the normal pedal placement. And idea is to deliver the shock, deliver amount of electric energy through the heart to revive the heart. Right. So let's assume that the subsequent cycles also, the rhythm that we have checked is a shockable rhythm. So in that case, you can deliver further shocks as indicated, but remember to increase the amount of energy. So the guideline says if the subsequent shocks are indicated, if you have a biphasic defibrillator, the energy should be 2 joules, and if it's a monobasic defibrillator, it's 360 joules. So basically, these are the highest amount of energy which will be available in these defibrillators. So subsequent shocks, you can set it for the highest energy, and you can deliver the shocks. But in a case of a ventricular tachycardia, as I mentioned, that there's a pulseless variant is suitable for shocks. It's better to check the pulse, and if there is a pulse, then a shock is not indicated, right? So that is important as well. But if you have any doubts, better to contact your seniors or the anesthetic people or the emergency physician to clarify those doubts. So in shockable rhythms, if the three successive shocks are, or if three successive or three cumulative shocks are indicated, now in the patient's rhythm, this inherent rhythm is like refractory or resistant to shocks. So what you can do is you can give some drugs to make the heart permissive or more receptive to this next shocks. So the drugs they have indicated is IV Adaline or amiodarone. So the doses I'll be talking later. But in the 2021 guidelines, if you don't have amiodarone, they recommend to give lignocaine with Adaline. So basically, it is Adaline with amiodarone or Adaline with lignocaine after the third shock. So basically, after the third shock, you give this as intravenous or intraosseous if you don't have the intravenous access. So the doses are Adaline. Usually, it comes in 1 milligram per milliliter or 1 in 1,000 concentration. So you can make it. You can dilute it into 10 milliliters and make it 1 in 10,000, and you can give the whole 10 ml. So remember that. So idea is to give it as a flush. So amiodarone, it is given as a 300 milligram bolus, and if amiodarone is not available, you can give IV lignocaine 100 milligrams. Right. So after the third shock, you can give IV Adaline 1 in 10,000 10 ml. IV amiodarone, IV or intraosseous amiodarone 300 milligrams, or IV or intraosseous lignocaine 100 milligrams, right? Like that. Right. We talked about the shockable rhythms. Now we'll move on to the non-shockable rhythms. So basically, there are two non-shockable rhythms we talk about during cardiopulmonary station. Those are pulseless electrical activity and asystole, right? So the most common type of rhythm we see even in critical care and even in ward setups is the asystolic type of shocks. So in those type of shocks, shocks are not, or the defibrillator shocks are not indicated. Remember that, right? So this is an asystolic type of rhythm. So usually it is this sort of rhythm. It is not a straight line. It's not a straight line. It's sort of this sort of a rhythm where there are no ventricular activity without. So there will be no QRS activity, but there can be sometimes there can be like hazard P wave activity, or P waves can be present. But if it is less a sort of straight line, make sure that the ECG or the electrodes of the defibrillator are connected correctly. Otherwise, sometimes what will happen is there can be disconnections, and there will be gel will be applied, or there will be sweating. Then because of that, electrodes can get dislodged easily, and you will falsely come into the conclusion that patients is in the asystole, and then you will not. Then you will manage like. So this is a pulse electrical activity. So what you can basically can you see the slides now? Getting that the slides are not visible. Dr. Madhushankar, can you see the slides? Slides are visible or not? Right. Okay. Thank you. Right. So these are the, sorry for this technical, just the signal strength is right. So what you can see is it's basically it's usually sort of a the sinus rhythm, but the difference is, even though the electricity can be like, so it can be normal sinus rhythm, there will be no detectable pulse. So that is why it's called as a pulseless electrical activity. So sometimes there can be either reduced to the heart and obstruction to the heart output, or in cases this contractility will be very poor. So what basically due to like and then it can lead to obstruction of the cardiac output as well, and severe aortic stenosis. This thing can lead to this pulse electrical activity of arrest, and also in the so if there are electrolyte sodium or magnesium, so it can lead to reduced contractility of the heart, and it can lead to this pulse cardiac arrest with sinus rhythm. Always check the pulse, because they can have fully rupture and tension in the. So there's a uncommon. So the management is for early adrenaline. So adrenaline is the status in 10,000, and the same percentage volume. So it is 1 in 10,000, 10 ml, either intravenous or intraosseous. So the what is the recommendation is give adrenaline. You have to give adrenaline as early as possible. You check the rhythm. You have to repeat adrenaline every 3 to 5 minute interval. So as the adrenaline's half-life is around 2 minutes, that is why you wait for 3 to 5 minutes, or basically for 4 minutes. So remember that once you start adrenaline at any point of the cardiac compressions, you have to repeat the adrenaline in every other cycle or every 4-minute interval. So remember that. Right. So, and make sure that you give uninterrupted cardiac compressions in non-shockable rhythms. So during cardiac pulmonary resuscitation, high chest compression should be continued, and there should be minimal interruptions to chest compressions, and you should give oxygen, oxygen. And if you have a capnography or a capnometer, you can make use of the capnometer as well. So in a case, if you have an advanced care in place, let's say you have LMA or ET tube, what you can do is you can continue the compressions asynchronous to the ventilator breast. So in other words, initially I told you that you have to give 30 compressions, hold the compressions for compressions for after 30 and give breast and again restart the compressions. So in case where you have a LMA inserted or a ET tube inserted during the cardiac compressions, what you can do is you can continue the compressions 100 to 120 per minute and asynchronously without in relationship to the cardiac compressions you can give. You are 10 ventilated breaths simultaneous, right? So in vascular, if you don't have intravenous access achieved, you can go for intraosseous access. But remember that in adult patients, it's not very feasible to go for intraosseous access. And at least should be given as early as possible in non-shockable rhythms and should be repeated every 4-minute interval or every other cycle. And as indicated, amiodarone can be given. Right, capnography in advanced life support capnography. You can see that next slide I'll show you a capnography. So it is a validated tool in advanced life support. So this is a capnography. This is called a side stream capnometer, and this is called a mainstream capnometer. Anyhow, if you have a capnometer connected to your LMA at the end of LMA or ET tube, you can get a trace like this. So in the monitor, you can get a trace like this. So this y-axis will show the value and x-axis it will be the time. So basically, depending on the value and the trend of the capnometer or the capnography trace also, you can have an idea about the patient, whether the patient cardiac compressions are adequate or whether the patients are getting return of spontaneous circulation. Right, we talked about the reversible causes of cardiac arrest. So during the cardiopulmonary resuscitation, you should look for these reversible causes of cardiac arrest. So basically, we call it as 4Hs and 4Ts. I think you already know this because you have completed your internship, and most of the people have done medicine appointments. So even in the pediatrics, these 4Hs and 4Ts have been taught to you several times. So we will quickly go through the 4Hs and 4Ts. 4Hs are basically the hypoxia, hypothermia, any electrolyte abnormality, not necessarily the high potassium abnormalities, can be magnesium or calcium abnormalities as well. And look for especially importantly hypovolemia, especially if the patients are surgical or obstetric or gynecological or surgical patients, other surgical patients. And 4Ts are basically tension pneumothorax, tamponade, thrombin, thrombosis, and the toxins. So hypoxia, you should make sure that you address hypoxia by giving high flow oxygen, supplemental oxygen through bag and mask ventilation or LMA. So ET tube insertion is a must during cardiopulmonary resuscitation. I think some of you have witnessed that in a cardiac arrest, immediately anesthetist will be informed to come and intubate the patients. So remember that intubation during when the cardiac compressions are continued is not very practical, and it will take some time. So as we discussed that these interruptions to the cardiac compression should be minimal. So what you can do is, rather than going for ET tube insertion, endotracheal intubation, you can go for LMA insertion. It's very easy. Even a lay person can they can learn this. So you can insert LMA, then you can catch the capnometer and check for the capnometer value. But earlier endotracheal intubation is indicated in pregnancy and patients with drowning to make as oxygen delivery and the demand is high in these patients. By hypovolemia, we have already talked about hypovolemia, especially in surgical patients. You should especially look for any bleeding outside, and especially if the patients are having drains, look for surgical drains, because surgical drains are usually the things which are like so commonly, not commonly, things which will be missed or forgotten by us, because those will sometimes they'll be like concealed under the curtains, or maybe you will not be able to will not be visible. So in this case, always look for surgical drains and also intercostal drains to look for continuous bleeding and hemorrhage to optimize the ongoing bleeding. Electrolyte abilities can be by doing urgent electrolyte, and if there's a patient available in the ICU or ETU, you can quickly do either a venous blood gas or an arterial blood gas, especially in a cardiac arrest. You can go for a venous blood gas as it is practical, and make sure that you check the random blood sugar levels and correct it as well. Hypothermia is not common in our setup, but can be common in Western countries. But especially in drowning patients, make sure that patient check the temperature and make the patient rebound the patient. Since we have talked about it, so you all know the features of pneumothorax. You can check, like inspect, palpate, percuss, and look for thorax. So initial management will be to go for knee decompression, but ideally it should be the definitive intercostal drainage inserted by right. Sorry for that. Right, toxins quite common, especially in medical patients. Patients can come with self-injection of toxins or accidental injection of toxins, especially like OB, carbamate poisoning, and paracetamol are quite common in Sri Lanka. So, and also sometimes some patients can have overdose of already taking medications, like psychiatric patients. So always make sure that you check the drug chart, or you go through the all medical records or the clinic records of the patients, and make sure that patients have not taken overdose or have not taken any other toxins by going through. So thrombosis is not uncommon, especially the myocardial infarctions due to coronary thrombosis and pulmonary embolisms due to like DVT is not uncommon, especially in obese patients, surgical, post-surgical orthopedic patients. So remember that thrombosis should also be looked at. So if thrombosis is indicated, you can go for fibrinolytic therapy to lyse the thrombus, but better to get a cardiological opinion with this thing. So ultrasound is also indicated. You can use ultrasound during this cardiopulmonary station because it is a novel and upcoming tool which is used nowadays, especially in Western countries. So if you are skilled enough, you can use those to check for reversible causes like tension pneumothorax, even tamponade, and you can even check for this cardiac contractility and volume status of the status, even if you are suspecting hypovolemia. Right. So we talked about the return of spontaneous circulation. So if you have done job efficiently and correctly, you will be fortunate enough to get the patient's circulation, spontaneous circulation back. Have a perfusing rhythm, or the vital organs now will be perfusing by the inherent action of the patient's heart itself. So patient can rarely can become conscious and they can start breathing spontaneously. Some patients can cough and do purposeful movements, and it will become palpable. So in that cardiopulmonary station, and you can move on to the next stage of the cardiopulmonary station, that is the post cardiac arrest treatment. Basically, it consists of several steps. So I'll briefly go through. So after the station of the patient, you go through the ABCD approach. So basically, you check the airway. So assume that patient is being ventilated with the laryngeal mask airway. Now is the time to go for a elective for a endotracheal intubation if the patient is not breathing spontaneously, or if you think patient is not conscious and you want to secure the airway, you can go for endotracheal intubation. Now you can give oxygen to target for a saturation of 94 to 98%. Then you check the breathing. So you check the circulation. You check the utility. That means you can check the ECS score and check the patient's, expose the patient, check the saturation, check the temperature, check the random blood sugar levels. Then if there's underlying cause, you can treat the underlying cause, and better to check a readily DCG because sometimes the underlying cause may be a massive myocardial event like massive myocardial infarction. So you can diagnose it early, and then and there you can treat and go for specialized intervention like percutaneous coronary interventions. So change is very important thing. The last few slides of the lecture is to have an idea about the changes which have been done to the basic life support and the advanced life support in a patient who is suspected of or diagnosed of having COVID-19. So basically now you already know that COVID-19 spreads by basically the aerosols and droplets. So the procedures which will make you exposed to aerosols and the droplets during the BLS, basic life support, and the ALS. These are the procedures that carry a high risk of exposing you for these aerosols. So these are called as aerosol generating procedures. So listening and feeling for breathing by going close to the patient, suctioning, ventilation, cardiac compression, and intubation all are considered as aerosol generating procedures. So you should take precautions before performing these aerosol generating procedures. But initial assessment of patient for responsiveness and looking and for breathing and confirming cardiac arrest and defibrillation are unlikely to generate aerosols. So the recommendation is that these mentioned procedures can be performed by wearing a simple face visor, surgical mask, gown, and gloves. So these are adequate enough to confirm the cardiac arrest and to perform the defibrillation. But rest of the procedures usually are full personal protective equipment. We call it as PPE. So this will, in addition to the previous attire, this will consist of N95 or N99 or N95 masks or FFP masks and the complete personal protective equipment kit. So these are the procedures needing full PPE, the ventilation, cardiac compressions, and intubation of the patients. Right. During ventilation, make sure that you have a good seal. You should make sure so this picture shows that it's a two-hand technique. So basically, you should go for V and E technique. This is a C and E technique, but in how it is the V and E technique. And also you can usually insert a HME or a HEPA filter in between the ambu bag and the patient's airway to make sure that the aerosols, most of the aerosols are, at least a fraction of the aerosols are filtered. So safe coughing is also important after CPR to make sure that you and your colleagues and even the family members are safe. Station team will consist of different members. So team member, there is a team leader headed by anesthetist or experienced advanced life support provider, and there will be a person for defibrillation. There will be one for cardiac compressions. One should be taking care of the airway. Basically, this is the anesthetist, and there one should be for drug administration, and one should be there for the time, the time or the striver. So basically, 6 people should be available for this. Should be available in proper registration team. But if you don't have enough number of patients, number of staff, you can like delegate roles, several roles to one person, and to continue this thing. And make sure that cardiac compressions are like switched in between every 2 minutes, because it will be like physically exhausting if you perform efficient cardiac compressions. So your role in BLS and ALS is very important. So you can diagnose cardiac arrest, you can inform the cardiac arrest team, you can commence basic life support, you can contribute cardiac compressions, ambu ventilation, defibrillation. You can manage the airway. If you are familiar enough, you can go for LMA insertion, even drugs administration, preparations, driving. Every role you can contribute. So it is very important for you to get familiar with these. So if you want to get yourself trained, and if you want to get trained as a trainer as well, there are ALS courses, advanced life support courses conducted by the College of Anaesthesiologists and Intensivists of Sri Lanka. So local courses will be a 1 full day, and the European Dissertation Council courses are there also there. Those are 2 full day courses. So once you successfully complete these courses, then you will be awarded the ALS provider certificate. And if you perform exceptionally, then you can get trained as a trainer as well. So remember that for your clinical practice, and even for your postgraduate studies, these will be required. So make sure that you can get involved in these courses, and make sure that you get trained yourself and try to train others as well. So it's very important. So neonatal and pediatric situation, we have not discussed, better to get yourself familiar with this, because courses are conducted by these particular colleges. Obstetric, important things are, you should make sure that you try to deliver the child decide on the delivery of the child, or we call it as perimortem section, by 4 minutes if the compressions are not successful, and to deliver the child by 7 minutes, and to make sure that the mother's inferior vena cava is not compressed by left lateral tilt and putting a wedge. Drowning, you can do 5 rescue breaths initially to correct hypothermia. So these are not very important, but important stuff we have already discussed. So last slide, when to stop CPR. If the patients have do not resuscitate orders, so that is called DNR orders, you can abstain from CPR. But remember, in Sri Lanka, the DNR orders are still not legal. So in other words, if the surgical or if the managing team have decided that if the patient is having a poor prognosis, even if you give CPR and resuscitate, in that case you can abstain from CPR. And also in cases where you start CPR, after 20 minutes, the team leader or the most senior person can decide whether to discontinue the CPR by discussing with the whole team. And if considering the comorbidities of the patient, say elderly patients with a lot of comorbidities, highly unlikely to have survived from the cardiopulmonary resuscitation and will have a poor outcome. So you can decide discontinuation of the CPR. And if reversible cause like maybe like pulmonary embolism or myocardial infarction, so in those type of instances, you can decide whether to go for prolonged cardiopulmonary resuscitation as well. So basically, that is the end of the lecture. If you have any questions, you can put in the chat box, and I can answer because 5 minutes are remaining. Right. So one doctor has asked that is there any place for local so calgluconate during resuscitation? Yes, so calgluconate, if the patient's VBG or the ABG shows hypocalcemia, obviously you can go for IV or intravenous calcium gluconate during sedation. So the dose is 10%, 10 ml. It should be given as a bolus. Remember that in cardiac arrest, every drug should be given as boluses, not as over 10 minutes or half an hour. And also in cases where this tricyclic antidepressant toxicity is suspected, or in cases where hyperkalemia, severe hyperkalemia leading to cardiac arrest is suspected also, you can calcium is indicated in cardiac arrest. But remember, it should be a fast bolus followed by a flush, not as over 10 minutes. Are we supposed to be competent in external pacing? No. So it's a good question because external pacing is basically done by the cardiologist and sometimes very rarely by the emergency physicians. So external pacing will be done in cases of severe bradycardia, but not in arrest patient. So in external pacing can be indicated in patients who have a higher risk of getting cardiac arrest with severe bradycardia. It will be performed by the specialized teams. Right. So the presentation will continue at the end of the whole session. So sorry for the technical glitches. So I'll be finishing my lecture. Thank you very much, everybody.
Right. That's Dr. Malaka Monasinghe, acting consultant at DGH Manor on cardiopulmonary resuscitation basics. So next up is Dr. Tushir Jayatilaka, shock and inotropes, consultant anesthetist at LRH. Over to you, sir.
Thank you, Dr. Shan.
Yes, you're welcome. Dr. Tushir, can you hear? Let's see.
Recording stopped.
Hello again. I think I was not able to unmute myself.
All right.
That
Now
was
you
the reason
can.
for the delay. Yeah. So, everybody, without any more time, so my topic here is shock and inotropes. So I'm going to share my screen with you. Can you see my screen?
No, no, sir. Yeah.
Okay. Can you see my screen?
Not yet.
Not yet.
We can't see it.
Okay. I'm trying to share my screen.
We not yet. We can't see the screen yet.
Okay, okay. I don't know why can't I share my screen? I'm still trying. Can you see my screen now?
We can, but it's very, can you make it full screen? Too small.
Yeah, okay.
No, it's on
How about
landscape.
now?
Yeah, better. Yes.
Recording in progress.
Sorry for the delay. Again, I am Dr. Tusita Jayatilaka from Lady Ridgeway Hospital for Children. So today we are going about shock and ionotropes. So first we'll concentrate on shock. So as you heard already in your medical school days, the shock is considered as inadequate tissue perfusion, which is obviously in the scale of life-threatening, with that life-threatening capacity. And it can be divided into 4 categories. The hypolimic shock, for example, in hemorrhage and diarrhea, the volume status is less in the body and you can develop hypovolemic shock. And the second type is cardiogenic shock, where there's a problem with the pumping action of the heart. For example, in myocardial infarctions, myocarditis, and any cardiomyopathies, or even in valve regurgitation, like in mitral regurgitation or aortic regurgitation. So altogether, we call them cardiogenic shock because the pumping action of the heart is suboptimal. The third type is obstructive type of shock. That means there's an obstruction to the flow of the cardiac output or the return of the cardiac output, that is the venous return. So things like pulmonary embolism, massive pulmonary embolisms, tamponade due to the pneumothorax, tension pneumothorax, and valve stenosis. So all these obstructive problems can lead to obstructive type of shock. And finally, the distributive type of shock is also there, which is mainly due to vasodilatation. So, for example, in sepsis, you will get a vasodilatory type of shock, as well as in anaphylaxis, you will get acute vasodilatation that will lead to low blood pressure and shock. And neurogenic shock, where there's a damage to the spinal cord, will reduce the sympathetic tone to the blood vessels, and the blood vessels will lost its tone, and then it will lead to vasodilatation. That will lead to vasodilatation and again shock. So there are 4 types of shock: hypolimic, cardiogenic, obstructive, and distributive types of shocks. Here I have highlighted 2 of these categories in red color. The reason is, in these 2 situations only, we tend to use ionotropes. I'll tell you why later. So those type of shocks are the cardiogenic shock and distributive shock. So keep this equation in your mind. It will be useful in your career. The blood pressure is equal to cardiac output multiplied by systemic vascular resistance. So blood pressure is a product of cardiac output into systemic vascular resistance. That means blood pressure will depend on cardiac output and systemic vascular resistance. When the cardiac output increases, the blood pressure will increase. And when the systemic vascular resistance increases, again, the blood pressure will increase. So it will depend on these, the blood pressure will depend on these 2 factors. So we are jumping into ionotropes. I'm sure that you have already know something about ionotropes. Ionotropes are a drug or a chemical agent that will alter the force of contraction of the heart or else the myocardium. So given that principle of definition, we can divide inotropes into two categories. The first category is the positive inotropes that will increase the contraction, the force of contraction of the myocardium. And the other one are the negative inotropes that will reduce the force of contraction of the inotropes. So generally, when somebody tells you about an inotrope, that is almost always meaning a positive inotrope. The positive inotrope will increase the contraction of the heart. For example, drugs like dobutamine or adrenaline. The negative inotropes like beta blockers will reduce the contraction of the myocardium. So those are the inotropes. So how inotropes will increase the blood pressure? So blood pressure, as I told you before, will depend on two factors: the cardiac output and the systemic vascular resistance. So when the inotropes increase the contractility of heart, it will increase the stroke volume. That will lead to increased cardiac output. So when the cardiac output is more, obviously the blood pressure will go up. So that's how the drugs, the positive inotropes, will increase the blood pressure. Examples again are drugs like dobutamine, adrenaline, and dopamine. So there's another category of drugs which are actually not inotropes. Inotropes, now you already know, are the drugs that will increase or reduce the contractility of the heart. But vasopressor has nothing to do with the contractility of the heart. As its name implies, the vasopressors will squeeze or press the blood vessels. It will reduce the diameter of the blood vessels. It will increase the vascular resistance. It will increase the afterload. So those drugs we call vasopressors. So if we go back to that formula again, since the blood pressure is a product of cardiac output and systemic vascular resistance, the vasopressors will increase the systemic vascular resistance. Hence, it will increase the blood pressure. So what are these vasopressors? What are the examples? The noradrenaline is the most commonly used vasopressor, but mind that it's not an inotrope. It has nothing to do with the cardiac contractility. So it's a pure vasopressor. Vasopressin, also known as ADH or antidiuretic hormone, is another vasopressor that is less commonly used. So what will these inotropes and vasopressors will do to our body? They will go into our bloodstream and will eventually be bound to places called receptors. So where these receptors are? They are within the blood vessels and they are within the myocardium. So they are basically in the cardiovascular system. Sometimes they are out of the cardiovascular system as well. For example, some of these receptors are in the bronchi. The beta 2 receptor, we know that salbutamol will go and act on the bronchi and sometimes in the brain as well. So what are these receptors? Just to increase your knowledge, alpha 1, alpha 2, beta 1 and beta 2, and V1 receptors, that is for the vasopressin in the blood vessels. So alpha 1, alpha 2 receptors are positioned in the first one, the alpha 1 receptors in the blood vessels. Sorry for the mistake, it should be blood, not blood, it should be blood vessels. The alpha 2 receptors are there in the brain. The beta 1 receptors in the heart, the beta 2 receptors in the heart, bronchi, and again in the blood vessels. So more or less, they are basically positioned in the cardiovascular system. So how to choose a correct inotrope or the vasopressors? Because we are using these inotropes and vasopressors in different clinical scenarios, and you should be able to think about physiology and your pharmacology, and then apply that knowledge to choose the correct inotrope depending on the clinical scenario. So we'll go for a scenario. So I'll read that for you. So that is a 25-year-old boy without any significant past medical history is now admitted to the accident and emergency service after a road traffic accident. Now he's having cold, clammy pulses. The pulse rate is raising to 120 per minute, and blood pressure is quite low, 82 or 68. And when they have performed ultrasound scan of the abdomen, they have found there's a liver laceration. So it's obviously due to the bleeding. So how do you manage? How do you use your knowledge on shock and inotrope to manage this patient? So obviously the patient is in a shock. So this is an emergency situation. So you have to follow the ABCD approach. It is a very famous approach of managing emergency type of patients. So ABCD stands for airway, breathing, circulation, dysfunction, and the other things. So when you go by airway, breathing, and circulation, you know the problem is at the circulation. So what is the problem at the circulation? This patient has lost most of the blood out of the blood vessels. Now he is in hypolemia. So this patient is in hypovolemic shock. Now it's life-threatening. So how to manage? You have to resuscitate with fluids. You have to fill the fluid compartment. You have to fill the vascular compartment which is depleted with fluids, with some fluids. So try to first give ample amount of crystalloids, normal saline or heart pump. Once the blood and blood products is available, you have to fill the volume. So is there a place for an inotrope or a vasopressors? Probably yes or not. But here you have to understand the basic problem is not with the inotropes or the vasopressors, because there's nothing wrong with heart contraction. Heart is contracting well. There's nothing wrong with the vascular tone. The vascular tone is very high in this type of hypovolemic shock because body is trying to compensate with increased vascular resistance to keep the blood pressure in a higher level. So probably you might not need to use any vasopressors or inotropes. You have to fill the volume with first with crystalloids and then with blood and blood products. But until such time, until the blood and blood products are available, if the blood pressure is still low, probably you can use a vasopressor. So depending on your clinical scenario and the facilities that you're having. But mind that basically it's a volume depletion and you have to fill it with volume. So not only in this type of clinical scenario, the other conditions of hypolemia may be happening in obstetric wards where there can be postpartum hemorrhages, and in medical wards when the patients are having severe diarrhea and vomiting. So let's go for another clinical scenario, scenario number 2. Where there's a 64-year-old smoker with a past history of hypertension presented to the cardiology unit with tightening left-sided chest pain. The pulse is 92. The blood pressure is quite low again, 74 or 46. mercury millimeters. And the ECG is showing a ST elevation of 9. So where it has gone wrong. So again, it's an emergency situation. So you have to call for help. You have to follow the airway breathing circulation algorithm. And when you at the number 3 or the A, B, C, the number C, the C or the circulation, you find that the blood pressure is low and the problem is with the circulation. So the patient is in a shock, blood pressure is low, the problem is identified, the problem is pump is failed, the heart is failed, so it's a cardiogenic shock. For how to deal, now it's clearly we need some inotropes. You have to pick the heart up again. You have to increase its contractility. So you have to increase the contractility of the heart by using an inotrope. So probably the dobutamine is the best here. But mind that there may be a chance of using a bit of fluids carefully, because this patient may be in heart failure already, in pulmonary edema. So just before starting your inotrope, you can use a fluid bolus, maybe 150 ml or 200 ml or 250 ml. You can use a fluid bolus. So not only in MIs, you get pump failure or the cardiogenic shock, but also in cardiomyopathies and myocarditis, you will get this kind of situation. So we'll talk about this medicine now. The dobutamine is a synthetic inotrope. That means it is not made inside our bodies. Mind that some of the inotropes like adrenaline, noradrenaline, and dopamine are made in our body, in the adrenal medulla. But this particular one is a synthetic one. It's made out in a factory. So it will stimulate mainly the beta-1 receptors in the cardiac muscles. So you can see the bottle nicely. It comes in a vial. And you can give it up to 20 mics per kilogram per minute with an IV infusion. So you have to prepare that into 50 ml syringe. You have to dilute that with normal saline, and you have to use a syringe pump. So these inotrope this for the disturbance. So mainly you have to use a central venous catheter for all these inotropes and vasopressors. So you have to have that, and then only you can start your vasopressors or inotropes. But before the central venous line in place, you cannot keep the patient in danger. Probably you can start the vasopressors and inotropes in a peripheral cannula until the central line is stabilized. So yeah, sorry for the delay. I had a call. Yeah, so until the central line is available, you can start this medicine through a good peripheral line. As any other drug, this can cause side effects like systemic vasodilatation, reduced diastolic pressure, tachycardia, and arrhythmias can be. So this is basically metabolized in two systems. One is called monoamine oxidase, and the other one is COMT systems. it can be metabolized. Okay. We'll move to the next slide. We are going to the scenario number 3. There is a 72-year-old lady with a history of diabetes admitted to the medical ward with fever, cough, and altered level of consciousness. Pulse rate is 104 high, and blood pressure is again low, 76/32. Mind how low the diastolic blood pressure is, very low. The pulse pressure, the difference of systolic and diastolic blood pressure are high. So the patient will get a bounding pulse in spite of having a low blood pressure. So when they have done a chest X-ray, they have found the patient is having a pneumonia with sepsis. So this patient is having low blood pressure, and the reason for the low blood pressure is obviously is sepsis. So the patient is in septic shock. So this is an emergency situation. So go by ABCD approach. And when you add number 3 at circulation, we have identified the patient is having low blood pressure. The problem is sepsis with septic shock. The reason for the septic shock is the reduced systemic vascular resistance. So here again, we have to give, in this particular type of shock, you have to give ample amount of fluid, up to 30 ml per kilogram. That means nearly 2 liters or nearly more than 2 liters, like 2.1 liters in a normal average adult of 70 kilograms. So before the vasopressor start, you have to give fluids. Sometimes with fluids only you can resuscitate, but even after giving this amount of fluid, if the blood pressure is not adequate, then you have to use a vasopressor. So preferable vasopressors are noradrenaline and vasopressor. Number 1 is noradrenaline. So the basic reason here is vasodilatation or a distributive type of shock. The other similar scenarios are seen in anaphylactic shock as well as in neurogenic shock, which I have mentioned earlier. So noradrenaline is a endogenous vasopressor made in the adrenal medulla. So it's a pure vasopressor. It stimulates only alpha-1 receptors in the blood vessels, so it will lead to severe vasoconstriction. Sometimes the vasoconstriction is severe that patient can get necrosis in the distal areas, like in fingers and toes. So that means the patient is having too much of noradrenaline. So it will increase the SVR, or the systemic vascular resistance. It's again prepared in normal saline, diluted in normal saline with a 50 ml syringe. You can go up to 0.6 mics per kilogram per minute. Side effects are, as I mentioned, peripheral tissue necrosis, bradycardia, reflex bradycardia, and other arrhythmias. It's again metabolized in NA or monoamine oxidase or catechol-methyltransferase system. So since this is causing a severe vasoconstriction, better not to start even with a peripheral vein, but it's again a subjective statement. If you're struggling with the central line, probably you can start that with a good large bore cannula, in a very good large peripheral vein. So noradrenaline comes as ampule, look like this. It mentioned it has 4 milligrams, but it is actually only 2 milligrams. When you take an as noradrenaline tartrate, it is 4 milligrams, but actually the noradrenaline part is only 2 milligrams. So mind that. So we are moving to vasopressin. It's not a catecholamine. That means it's not produced in the adrenal medulla. So it is actually secreted in the pituitary gland, and it is produced in the hypothalamus and stored in the pituitary gland, also called ADH. But as the name implies, it will press the vessels. That's why it's called vasopressin. So naturally occurring hormone, vasoconstrictor, and actually it's second line to the noradrenaline in sepsis. So if you say there's something wrong with noradrenaline, then you can stop giving noradrenaline and give vasopressin instead of noradrenaline. So you can give it up to 0.04 per minute. It's not a per kilogram based medicine. So for an adult, you can give it up to 0.04 per minute IV infusion. It comes in international units, not as milligrams, since it's a hormone. It's again diluted in normal saline. The side effects, it can cause hyponatremia due to fluid retention, bradycardia. It's metabolized in a different mechanism in proteases in liver. You can start that in a peripheral vein until the central line is available. So it comes as a vial. You can see the vial contains 20 units per ml. So we are going to the last scenario. It's a 32-year-old lady admitted following dog bite. And she was given ARS, and after a couple of minutes, she's complaining of faintishness. The pulse rate is 92, bit high. Blood pressure is very, very low, 72 over 36, and has got erythematous generalized rash. At this point, you should auscultate as well. Probably you may hear some bronchi as well. All these are the features of anaphylactic shock. So once you have identified, you have gone through the ABCD, emergency situation, call for help, and you find the problem is the circulation, blood pressure is low, acute vasodilatation, reduced SVR, low blood pressure. Again, you have to give some fluids, and like half a liter to 1 liter. And here, the particular drug or the drug of choice is adrenaline. You can give it if you have an IV cannula. If you are monitoring, you can give it 1 mic per kilogram. Usually, we can give 50 micrograms. Mind that while 1 ampule of adrenaline has 1 milligram, and you have to dilute it and take like 50 micrograms of adrenaline. If you don't have an IV cannula, then you can give it IM, like at a time. And then something about adrenaline, it's a naturally occurring catecholamine. It's produced in the adrenal medulla. It's very cheap drug and very popular. It stimulates all the receptors, alpha 1, alpha 2, beta 1 and beta 2. And you can give it up to 1 mic per kilogram per minute. And in anaphylaxis, you can give it like 50 mics at a time. So at a lower dose, when you're running infusion at a lower dose up to 1 mic, up to 0.1 mic per kilogram per minute, it will cause vasodilatation. So then you can start that even via a peripheral vein until the central line is available. But at a higher dose, it will cause vasoconstriction. So again, prepared in normal saline in a 50 ml syringe. Side effects, you can get any arrhythmia, tachycardia, palpitation, tremors, high lactates can be there. So again, metabolized in the monoamine oxidase pathway or else catecholamine methyl transferase systems. So I'm sure that you have already seen this. It's freely available even in the wards. It's 1 milligram in 1 ml, or we call it 1 in 1000. Then dopamine is coming as a vial. It's another positive inotrope. I have not fit this drug into any clinical scenario because it is not a first line medicine to start with. It can cause tachycardia and arrhythmias. Usually it's not a first line drug, but keep in your mind there's a drug called dopamine. So before I wind up, some rules when you are using inotropes or vasopressors. Keep these rules as a take-home message in your mind. So you have to match your inotrope or the vasopressor to the type of shock. And the second one, before you try with your inotrope or vasopressor, use some fluids, especially in sepsis and anaphylaxis. But in heart failure or in cardiogenic shock, be very careful. Probably you may not, there's no need to give. But probably if the child, if the patient is, there's a bit of hypolemia as well. So probably you can give a little bit of fluids very carefully. So you need a central line to start any of these inotropes, but don't wait until central line is available. You can start your vasopressor or inotrope through a good peripheral line, through a large vein, but don't forget about central line. You have to plan the central line. At some point, you need that. You cannot give inotropes or vasopressor hours without having a central line. So when you are starting a vasopressor or an inotrope, you have to escalate your monitoring. You have to connect the patient into multi-monitor. You have to monitor the pulse. You have to monitor the saturation, respiratory rate, central venous pressure, preferably intra-arterial blood pressure monitoring, urine output, and blood gases to be monitored. And you need a syringe pump to run the vasopressors and inotropes. If you don't have one, then for temporarily you can give it through add that to a normal saline drip and titrate your dip rate until you achieve your desired dose. But preferably you must have a syringe pump. So these inotropes and vasopressors are drugs with a lot of side effects. Some of these side effects may be life-threatening as well. So anticipate arrhythmias, myocardial ischemia, peripheral tissue necrosis, electrolyte imbalances. So you have to anticipate them. That's all about my presentation. If you have any questions, if time permits, I can answer them.
There are some questions on the chat box. Dr. Twitter.
Are we running behind? We do
Sorry?
have time for.
It's a lunch break, so we can answer those questions. Those who are interested in listening to the questions can say others. Otherwise, those who take the lunch break can take the lunch break and come back at. So it's lunch break officially. So those who want to take lunch break, yeah.
I'll answer one by one.
Sure.
One of the question is for sepsis, what is the order of starting inotropes? So the sepsis is basically dilation. So before starting any inotrope fluids, and then the drug of choice is noradrenaline. If you can't find noradrenaline, or if there's a patient having a lot of defective noradrenaline, then next option is vasopressor. So you have to squeeze your blood vessels in sepsis. So adrenaline, and then if that does not suit, then you have to go for vasopressor. You can add adrenaline later on if your desired blood pressure is not achieved. Another question is, what are the effects of inotropes and vasopressors given via peripheral line for a long time? The effects will be the vein will be damaged. Vein can go into spasms. The diameter of the vein will be less, and it can cause thrombosis. It can cause necrosis as well. So it's not a good idea to continue the inotropes or vasopressors through a peripheral line. Another question: how to choose between dobutamine and dopamine? Dobutamine definitely for in cardiogenic shock, you have to start dobutamine. Dopamine is not mentioned anywhere as the first line of inotrope in any of clinical scenarios. So it's always a second line medicine. But dobutamine in cardiogenic shock is the number one. Then another question for cardiogenic shock, what is the order of starting anatropes? So again, cardiogenic shock, probably you can give fluids like 200, 250 ml very carefully. Patient is not in failure. Then you have to start again, as I mentioned, dopamine is the number one. And if the dopamine is not adequate, probably you can go for noradrenaline or adrenaline. But number one is dobutamine. The next order, I cannot say a specific answer. You have to match the anatropes in that particular clinical situation. Is there a place for noradrenaline cardiogenic shock? Not as the first line, but after you are starting dobutamine, you know that dobutamine will cause vasodilatation. To negate that, probably you can start a small dose of norad. But again, as I mentioned before, you have to start before you start in norad. Another question, can two vasopressors be given at the same time? Yes, some severely vasoplegic patients, if the NORAD, once you achieve the maximum dose of NORAD, still if you cannot achieve your target, then probably you can go for vasopressor. Now, question, can we use NORAD up to 1 mic per kilogram per minute? I think that's a too high dose. The maximum dose mentioned differs in book to book, but what I practice is 0.6 mics per kilogram per minute. But if I see the patient will develop tissue necrosis, peripheral tissue necrosis, even at a lower dose, then I will hesitate to increase the dose further. Then in that case, I will not go even up to 0.6. So again, I mentioned maximum dose of dobutamine is 30 mics per kilogram per minute. But what I have seen and what I practice is 20. The NORAD again, that person is asking, can we go up to 0.8 mics per kilogram per minute? Again, my practice is 0.6. Different book says different things, but look for the side effects. And if you see the peripheral vasoconstriction, severe vasoconstriction and necrosis in the toes and fingers, then don't increase the dose further. I think I have answered almost all the question. Another one question, I have encountered situation of severe sepsis with the blood pressure has not picked up even after 300. Yeah, sometimes even we do our maximum, still we cannot catch it up. So what to do? So we have to do our maximum, try to understand the physiology. I have seen more than 3 anatropes in sepsis sometimes. Adrenaline, vasopressin, noradrenaline, dopamine, dobutamine. But mind that all these anatropes sometimes going and act on the same receptors. So we are flooding different chemicals which are going to the same receptors. So once you pass a certain limits, you have to understand your limitations. Sometimes rather than adding inotrope on top of the other one, try to identify your limitations as well. Another question, for sepsis, there's a place for low dose dobutamine before the adrenaline, after noradrenaline. I'm not sure about that. Recently, they have changed the the sepsis guidelines, the surveying sepsis guideline. I have not gone through yet, so I cannot answer the question at this point. Thank you so much for your attendance and attention. Hope you had a good career ahead. Thank you so much. Thank you, Roshan.
Right. Thank you very much, sir, for that informative lecture on shock and inotropes. So lunch break, we'll meet at 1:30. Right. Thank you.
Recording stopped.
Hello, Roshan, can you hear me? Hello.
Yes, madam. Yes.
All right. So, can I start now, Roshan, then?
Yes. Yes.
Okay.
Right. Next lecture is on sepsis by Dr. Lakshmini Pereira, consultant anesthetist at TH Anuradhapura. Over to you, madam. Yes.
Thank you, Roshan. Okay. I can share my.
Yeah, you are given the access. You can share now.
Yeah. Can you all see?
We can hear and see. Yes, you can proceed.
Okay, good afternoon, everyone. So during next half an hour to 45 minutes, 40 minutes like, we are going to talk about sepsis. Right. So why we need to talk about sepsis? So why we need to learn about sepsis is because of the scale of this problem. The gravity of this problem is huge because if it takes to the family, it take deaths, you can count on deaths and the cost. Because the sepsis related mortality is very high. So we don't have the Sri Lankan data or Asian data most of the time. But if you take European countries, the mortality related to sepsis is something which carries a very high mortality rate, especially in ICUs. Even though we don't have Sri Lankan data, we have a prospective cohort study in which contains 16 Asian countries, where it says the hospital mortality related to sepsis is around 45%. But we have something related to Sri Lanka. If we take the causes of sepsis, what are the causes of sepsis? Most of the time, it is pneumonia-related deaths. Then you have meningitis or CNS-related infections, and then leptospirosis. It is because I think this study was done in an area where leptospirosis exists most. So wherever you do the study, most of the time it is pneumonia-related or CNS-related infections. But depending on the demographic factor, so it could be dengue, leptospirosis. In a dengue epidemic, the mortality will be higher with dengue. So what I wanted to highlight was the highest mortality is related to pneumonia. So we'll go through the rest of the lecture with a case presentation. So we'll take a 63-year-old man. One second. So we'll take a 63-year-old man who was admitted to the surgical casualty ward with a history of prick injury to his left foot 2 days ago. He complains of fever, general feeling of unwell. He has a background history of diabetes and hypertension. On examination, he's febrile, he's tachycardic, he's marginally maintaining his blood pressure with a blood pressure of 100 to 50, respiratory rate of 20, saturation 95 on room air. He's drowsy but arousable. On his limb examination, it shows aggressive looking, warm and tender, edematous limb with blisters from ankle to calf. His urine output has reduced to 220 ml for last 18 hours, but we have to keep that in mind. His intake was so low during this 18 hours. So what we are going to do, what you are going to do, if you were the house officer, so you are to your house officer period. So if you were the house officer for this patient in the surgical casualty ward, this is what you normally do. After your history and examination, you do basic investigations, like for everything, full blood count, blood urea, creatinine, electrolytes, coagulation, CRP, what is it? You may take culture and ABST. And so finishing that, you will put an IV cannula, started on fluid because he's marginally with low blood pressure, started on antibiotics. If he's in pain, you may start him on analgesics and antiemetics. This is what you all normally do as house officers in the ward. So is that all that we have to do? What we normally do in a situation like this? Right. So you do this, what I have mentioned in the previous slide, and what are we going to do? Are we going to like just wait for the investigations, or are we going to do something else? Yeah. Here comes the early warning score. There's something called early warning score, which is definition wise, it says it is a score where we use abnormalities in our routine observations to identify patients at risk of critical illness. Because now when you clerk this patient, you may realize, okay, he is not normal. He's not normal. There's something wrong with him, sorry. Something wrong with him. So because of that feeling, you can't forget this patient. After starting fluid or after taking cultures, you can't wait. So you need to monitor this. How you are going to monitor this patient is with vital signs. So what are the vital signs that we are going to use? We use very commonly used 6 parameters, 1, 2, 3, 4, 5, 6, to monitor 3 main vital organs: respiratory, cardiovascular, and CNS. So by doing that, you monitor whether this patient is improving or deteriorating. This is what we are going to do with early warning score. Now we'll see how we are going to do this. So you give a 0 value, 0 mark to all normal physiological parameters. For an example, if the patient's heart rate is remaining in the normal value, you give a 0 because you don't want to score it. He's normal. Blood pressure, normal value gets 0. Respiratory rate, oxygen saturation, temperature, and if the patient is alert, you give a 0. Any deviation, ups or down, any deviation from the normal, you give a mark according to the chart. So normally this early warning score is being printed and kept, should be printed and kept in the ward, especially in casualty wards. So you give a mark. So likewise, we'll give a mark to our patient here. So you all can also do with me here. So the temperature of this patient is 38. Heart rate is 100. Blood pressure is 100/50. Respiratory rate 20. Saturation 95. He is drowsy but arousable. Now we'll see what is the score he is going to get. Right. So his heart rate is 50 to 100. So his heart rate is, so you can like score it 0 or 1. We'll score it as 0 because it's touching the higher normal. Right. Blood pressure is, systolic blood pressure is 100 again. So it's dropping side. So you can score another 1 for systolic blood pressure. Respiratory rate 20. So again, you can put it as 0. We'll take it as 0. Oxygen saturation 95, 0. He's alert because he's drowsy but arousable, and say it's 0. So his early warning score at this point varies between 1 to 2. If you put like 100 heart rate to 0, yeah, we'll put it 0. Its warning score is 1. Now you know what is the warning score of this patient. Now, the importance of this early warning score is, this is a very objective way of assessing the patient. So if you put this score to the this patient, or your SHO or your senior registrar, same score will come. So it doesn't depend on the clinical experience or the knowledge or whatever, the subjective factors. It doesn't depend on the person who is assessing the patient. So if you assess the patient and call me and tells me, okay, madam, I have a patient who comes to the ward in this picture and the early warning score is 1 still, so I know he is kind of a stable patient, but can go into either side depending on your management, right? So that is one advantage of this early warning score. So that gives an objective assessment. Second thing of this advantage of this early warning score is you can repeat this. So how frequently you are going to repeat this? That depends on your score. So if your score is 1, our patient, you can wait for 4 hours and then reassess the patient. If your score is 2, you can't wait for 4 hours. You have to do the reassessment within 1 hour, within 2 hours, 1 to 2 hours. If your score is 3 to 5, you have to assess him before 1 hour. If it is more than 5, or your score, if the patient scores 3 for one single parameter, you have to call the outreach team. That means the ICU people. So that is how this early warning score guides you for the frequency of monitoring. And the next thing, the next advantage of this early warning score, that will tells you to whom you have to inform about the patient. Okay, so likewise, like I told you previously, if your patient scores 1, you don't have to call your consultant at the very point. Okay, you can tell your nurses, okay, this patient needs early warnings to be put in and assess him in next 4 hours. So the patient will, nurse will assess the patient in next 4th hour and tells you the score. If the score is rising, if the score is going 2, 3 wise, like upside, so you have to inform accordingly your SHOs, your registrar, your senior registrar, and to the consultant, and then to the ICU team. So that is a very useful tool in assessment of the critically ill patients. That is one thing you can identify whether the patient is improving or deteriorating with what you have done. So in the initial management, you have given a fluid bolus here. You have started a fluid, IV fluid 100 ml power. You have given an antibiotic. So after 4 hours, after assessment, you can see what is happening with your early warning score. Right. So while we are waiting for this 4 hours, according to the Muse chart, you need to you can wait for 4 hours for the next assessment. During that 4 hours, you got your investigations. So these are the investigation results, which proves that you have a suspicion about this patient. Yeah, the investigations are not normal. The WBC count has risen up. CRP has gone up. UFR shows 3 pluses of pus cells. Creatinine, liver function, coagulation, relatively okay. So you have a suspicion, okay, is this patient is having a urine infection? Then you do a blood gas. pH is 7.1, is acidotic, but the CO2 is normal. So the carbon dioxide is not responsible for the acidosis. So you look at the bicarbonate. Yes, bicarbonate is low. So this is going to be a metabolic acidosis. He's oxygenating 5. Right. Now you have something. So at the end of 3 hours, now you can wait. So you have started a fluid bolus, you have taken cultures, you have given antibiotics. Now we are waiting to see what is wrong, what is going to happen in next 4 hours. So at the end of your 3 to 4 hours, you do the assessment again. Then we'll see what is the score now. Now his blood pressure has dropped to 80. Heart rate has gone up to 120. Temperature has gone up to 38.3. And respiratory rate is 30 now. Now he is on oxygen, so he needs oxygen. And we'll take his alert and alert still. Now we'll put the marks again. Yeah. So heart rate now is 120. So he is moving to 2. So he scores 2 there. Systolic blood pressure is 80. So he scores again another 2 there. And his temperature is 38.3. So he scores 1 there. And he's now requiring oxygen. So definitely he scores more than 2. So we'll put it as 2. And we'll put him as alert still. So 0. So 2, 4, 6, 7. Now he has deteriorated. Despite what you have done, he deteriorated over these 4 hours. Now you have to act immediately, because when you assess, his score was like between 1 to 2. After 4 hours, his score has moved to 6 to 7. So he is deteriorating. Why is that? So your investigation gives you a clue. He's having an infection. So we call it sepsis. So what is sepsis? Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. It's life-threatening. It's life-threatening to your cardiovascular, respiratory, and CNS, probably for renal next time. And it is because of the dysregulated host immune response. That is the definition. Initially, if you can go through, if you can Google, so this definition was different in early 2020s. So it was like, there was like 3 categories: SIRS, sepsis, severe sepsis, and septic shock. But we are not using those definitions at the moment. So we have taken all these away, and currently the definition for sepsis is dysregulated, life-threatening organ dysfunction resulting from dysregulated host immune response. So there are a couple of words here that we need to like focus on. Right. Why we need to learn about sepsis? Because it is very difficult to spot. So when you get this pen for the first time, he was on very early stage of his illness. So you may like feel like doing some interventions and keeping him. You can like call it sepsis at the very moment. So the clinical spectrum of sepsis is lengthy. So you may encounter patients at any point on this line. So if you encounter the patient on the very end of the line, so you can easily diagnose sepsis. But if you get the patient on the very early stage of sepsis, you may miss it. So it's very, so most of the time it will be underdiagnosed. So if you don't have this way of like identifying deteriorating patients, you may miss it till it comes to the severe sepsis part. So early recognition is very important, and early resuscitation is very important, and early referral to the ICU is very, very important. Otherwise, the mortality with sepsis will remain very high. That is why this early warning score is very important. This part actually I told why it is difficult to spot, because it has a number of phases along the clinical line. So because hypotension, temperature, low urine output, these clinical signs and symptoms are associated with many other conditions. So especially if the patient is following a trauma or hypertension with the sepsis, so you may like miss this. So none of these clinical findings are specific, so you may miss it early. So why this is happening? So I said in definition, they said dysregulated host immune response. So if you take the pathophysiology, sorry about this spelling mistake here. If you take the pathophysiology, the inflammatory, normally when you get an injury, your body itself gives an inflammatory response. The inflammatory response mounted against the toxins from microbes and initial injury, that is happening in everybody. So, so there's a complex interaction between the pathogen and the host immune response. So normally, what will happen with this normal host immune response, that will localize the infection and like try to remove it from the body. So that will activate the host defense mechanism. That is what is happening on the normal physiological response. But with sepsis, what is happening? With the gram-negative, the three most common triggering factors are the gram-negative bacteria, gram-positive bacteria, and fungus. So what will happen with sepsis is this normal physiological inflammatory response is dysregulated. So that will activate, that will trigger the production of pro-inflammatory mediator cytokines, especially TNF1, TNF and interleukin-1. So, and also it will trigger other inflammatory mediators too. These pro-inflammatory cytokines will cause a negative feedback mechanism, and they will activate the release of anti-inflammatory mediators too, which will activate, and they also at the same time, they will activate the clotting mechanism. So there will be, because of this dysregulated response, there will be releasing of pro-inflammatory cytokines, anti-inflammatory cytokines, and activation of the clotting mechanism. Ultimately resulting vasodilatation, vascular leakage, and microinfarction. So host response will release pro-inflammatory cytokines, anti-inflammatory cytokines, and coagulation, which will result further damage of the tissue and organ dysfunction through dilatation. Vasodilatation will cause hypertension. That is why septic patients are hypotensive. And with the vasodilatation, they will go into leakage and tissue edema and hypovolemia. And with the activation of coagulation system, that will result microinfarctions. So this vascular leakage is currently explained with this glycocalyx theory, or we call it vascular glycocalyx theory. Glycocalyx is a matrix lining endothelial cell serving as a barrier opposing the vascular permeability and limits transvascular movement of the fluid. With sepsis, this glycocalyx is going to be damaged with sepsis itself, with the inflammatory cytokines. So that will result more fluid leakage. Otherwise, what is governed by the leakage? The leakage is controlled by the osmotic and hydrostatic pressure gradient, which cannot be explained purely. The leakage in the sepsis purely cannot be explained in this pressure theory. So there the glycocalyx theory comes, and that results the clinical picture of the sepsis. So actually this part we went through, we don't have to go through. Right. So the definition of sepsis. So definition of sepsis comes from the pathophysiology of sepsis. It is a life-threatening organ dysfunction activated by the dysregulated host immune response. So now, how you are going to diagnose sepsis? So for that, we have QSOFA. You all may have heard about SOFA score, which is a very combustion, like very complex diagnostic tool from sequential organ functional assessment. So from that, we have taken QSOFA, very simple way of diagnosing, bedhead diagnostic tool of sepsis. So you have 3 parameters, one for each 3 main vital organs. You take respiratory rate, you take altered mental state, you take systolic blood pressure less than 100. So you give 1 mark to each of these. If your respiratory rate is more than 22, if your mental state is altered, and if the patient is hypotensive where the systolic blood pressure is less than 100, so totally you get 3 marks. So 2 or more, 2 or above will diagnose sepsis. So it is very easy to remember: hypertension, altered mental state, tachycardia. So you call it HAT. If your score is more than 2, which is a diagnosis of sepsis, your mortality rate for the patient starts from 10%. So you diagnose it. So you use this tool to diagnose sepsis very early. So score is 0 or 1, patient has no risk of going into sepsis, but the continuous monitoring with your Muse chart is important and the management. And if the score is 2 or more, there's a very high chance of the patient is having a very poor outcome. So you need a patient admitted into the ICU. Right. So if you take SOFA score for the completion's sake, it is a very complex score, and you monitor all your main systems, respiratory, cardiovascular, CNS, and renal here. And you take a couple of the parameter that you are going to take from each system, you give a mark and you calculate it. This is not what we are using for sepsis diagnosis. Then that is sepsis. The definition we have given, and we have diagnosed sepsis. Then the other entity of sepsis is septic shock. So your septic patient, if the patient needs vasopressors to maintain the MAP more than 65, despite your volume resuscitation, plus if the serum lactate is more than 2, you call it as septic shock. The definition for septic shock is patients with sepsis, despite the adequate volume resuscitation, if they require vasopressors to maintain MAP more than 65 and serum lactate is more than 2, you define it as septic shock. Are you all clear with me up to so far? Anybody can respond? Is it clear so far? Everyone is muted here. Okay, fine. So I hope you all can hear and you all understood what I said so far. Right. So then, if in the definition we said it is mainly this life-threatening organ dysfunction. So almost all the organs in the body can go into like failure with sepsis. So this is what will happen if you take cardiovascular system, hypertension, or microcirculation, increased lactic levels, hepatic system will fail, renal failure, neurological, altered mental stage, confusion and disorientation, respiration, and hematology. So your almost all the body systems will go into sepsis. Right. So this is our patient where we stopped, where he scored Muse score is 6 to 7. Right. Then what we are going to do now? Now we know our patient is not responding what we are doing, and what we have to do, the management of sepsis. The best evidence-based management set of management for sepsis is given by the Surviving Sepsis campaign. Right. So reducing what? So this the best management given by the Surviving Sepsis campaign. It is very important because that has like evidently it has reduced the mortality, and it is a very organized process, a very organized method of assessing the patient. Right. So we call this management tool given by the Surviving Sepsis campaign is a septic bundle or the bundle care. So what do we mean by the bundle? Bundle is a group of intervention where you implement them together over a given specific time period. So all three components has to be there to complete a bundle. So it's a set of well-defined interventions with goals implementing together over a specific time period. Right. So when are we to begin this bundle? Where is the time 0? If it is over a specific time period, we have to specify where are we going to start this. So as soon as your Muse score is going up, and then your Q-SOFA diagnose your sepsis, and if you feel like if the patient is encountering approaching the criteria for severe sepsis, you have to take actions immediately. You have to implement the Surviving Sepsis campaign guideline first hour bundle. So what are the components of the first hour bundle? That means what are we have to do as soon as you diagnose sepsis. As the previous HO did, you have to immediately obtain the blood cultures plus whatever the cultures need to be taken. Time came on phone. And then as soon as you took the blood cultures, you have to give antibiotics. It has to be broad spectrum antibiotics. Then you do a blood gas and measure lactate, third bundle. Fourth thing, you start volume resuscitating the patient. So it has to be 30 ml per kg. The choice of fluid is crystalloid. And then your target has to be maintain the MAP more than 65. So your 30 ml per kg fluid resuscitation, following the fluid resuscitation, if the MAP is not maintaining, you can start on inotropes. So this is what we have talked so far. So 30 ml per kg within first 3 hours. Crystalloids preferred. Normally in sepsis, normally you don't use albumin, but if it is very refractory, you can consider, but it is crystalloid and albumin. Normally you don't use colloids. Antibiotics. So as soon as you took cultures, you have to start the patient on antibiotics. So it has to be early, appropriate, empirical antibiotics. So what does those words mean? So the blood cultures, as soon as you have a suspicion, you have to take cultures. Ideally, blood cultures has to be like 2 cultures from 2 different sites in 2 different times. And other samples, if it is indicated, like in our patient, the UFR shows 3 pluses of pus cells. So better to send urine culture. So if anything other than blood cultures indicated, you need to take. Taking all the cultures, you start broad spectrum empirical antibiotics. So you need a loading dose. So the way of giving it. So sometimes we have like 2 types of antibiotics: concentration dependent antibiotics and time dependent killing antibiotics. So this is the concentration dependent antibiotics are the commonest one. So you need a loading, time dependent antibiotics is the commonest one, where you need to infuse the antibiotic over a time period, because the majority you can have the very good effect if your antibiotic is there in the bloodstream for longer time. So normally the antibiotics are piperacillin tazobactams, meropenems. So normally we infuse these antibiotics. Concentration dependent antibiotics means you need to give a bigger dose of antibiotic to the blood to achieve the desired target. The commonest example is the aminoglycosides. Normally these antibiotics, you give a loading dose and then you go for a daily dose. Right. So I said the empirical antibiotics. So you start an antibiotics where you think, okay, if it is a bowel involvement, you straight away start on meropenem. Forgive me for using these terms. So if it is if you have a suspicion of anaerobic, you start something better on anaerobic. So you start something you think will be, depending on the evidence and the practice, this is the ideal antibiotic for this thing. So you can continue this antibiotic, empirical antibiotic, for 3 to 5 days till you get your culture reports. And then you have to de-escalate it according to your culture reports. Normally, empirical antibiotic should not be continued more than 3 to 5 days. You have to tailor it to the culture, according to the culture reports. And there's an important thing with guiding the antibiotic therapy with procalcitonin. Sometimes your hospital may not have procalcitonin. Normally, procalcitonin will guide you when to stop your empirical antibiotics and to guide you the duration of the antibiotic therapy. Okay, so now we know what to do as soon as you diagnose a septic patient or septic patient. So since because our patient's new score has gone up to 6-7, they have informed our ICU team, started oxygen on non-rebreathing bag and mask, obtained cultures, started on empirical antibiotics. Lactate was measured and it came as 8.3. So rapid fluid resuscitation has started and 2 liters was given over 1 hour. And after 1 hour, even with the fluid resuscitation, lactate is 6.7, still high. So the patient was taken into the ICU and the blood pressure remains, MAP remains less than 65. So the lactate is high. After fluid resuscitation, MAP is less than 65. So the definition or the diagnosis of septic shock was made and the patient was started on noradrenaline, which is the drug or inotrope of choice in sepsis. And all the organs were monitored. And on respiratory monitoring, it was noticed that the bibasal air entry was low and saturating 90% with high flow oxygen. So the decision was taken to intubate the patient. And now keeping the patient there, we'll move on to the vasopressor therapy. So in sepsis, you have vasopressors and inotropes. So vasopressors, common vasopressors we are using are the noradrenaline, adrenaline, and the vasopressin. So noradrenaline is the first choice in sepsis. The dose is, this dose is wrong, 0.05 to 0.5. Adrenaline, same dosage. Vasopressin, you take it as units. So it is starting from 1 unit per hour, you can go up to 4 to 5 units. So from the inotropes, you can use dopamine and dobutamine. Normally we avoid dopamine, or we keep dopamine to the last resort. Dobutamine, depending on the patient's clinical condition. If your septic patient is a patient with ischemic heart disease and cardiomyopathy or some cardiac involvement, you tend to start dobutamine little earlier along with the noradrenaline to maintain the blood pressure. Otherwise, your first choices would be noradrenaline and the vasopressin in sepsis. So with fluid with the inotropes, you have to continue to clinical evaluation of the patient. Your blood pressure, heart rate, oxygen saturation, respiratory rate, temperature, and the output. So how do you reassess your volume statement? So you know, with the pathophysiology, patients' vessel dilate, so they massively dilate. So they go into relative hypovolemia, and you load the patient with fluid. And with the pathophysiology, these fluid, because of the damage of the glycocalyx, these fluid tend to leak. So whatever you give may leak into the interstitium. So how do you think, how do you know that my volume resuscitation is enough? So you need to monitor it. So you can use clinical monitoring with blood pressure, urine output, capillary refilling, oxygen saturation, or you can use dynamic measures like your trend of your CVP, if you have the cardiac output, monitoring cardiac output and measuring the mixed venous oxygen saturation. And if you know how to do these things with your ultrasound scan and cardiac output monitoring, there are various ways of monitoring the fluid responsiveness in a septic patient. The important important clinical method of monitoring the volume responsiveness is the leg raise test, straight leg raise test. So how do you normally do? You need to have an arterial line for monitoring. So you keep the patient on lying flat or baseline normally as you keep the patient in the ICU, and you look at the arterial line, the blood pressure variation and the heart rate, and you do passive leg raising. You raise the patient's leg and keep it raised for 2 minutes. And then you look at the variation of the blood pressure and the heart rate. The physiology behind it is your lower limbs normally contains roughly around 500 ml fluid. So once you raise the legs, it is like you are auto-infusing that 500 ml to your heart. So if the patient is volume responding, your heart rate will go down, your blood pressure will go up. As soon as you put the patient's leg down, again, your blood pressure will drop and the patient will go into tachycardia. So the importance of this passive leg raising test is you don't infuse anything from outside. So if the patient's is a patient is a cardiac patient, cardiomyopathic patient, or with any type of cardiac involvement, you are not overloading the patient. You just auto-infuse what is inside the body and you can see the response. So once you know the response, you can treat the patient with volume. So that is the fluid resuscitation and assessment of the volume resuscitation in sepsis. Then this is what I said, like vasoactives and inotropes. So your first choice is noradrenaline. From inotropes, your first choice is dobutamine. And you normally don't keep your dopamine to the last resort. So when you keep on doing this, you need to measure your lactates frequently to see whether there's continuity of tissue hypoperfusion. So if the patient's blood pressure is restoring back, if the microcirculation is restarting, the lactate has to be cleared. The lactate levels has a very linear and proportional correlation with the mortality. If the lactate level is going up, despite your resuscitation, where the rate of chance of mortality is very high. So early clearance of lactate with your volume resuscitation and restoration of the blood pressure, the outcome would be better. Right, okay. I said, when I talked about the bundle, so bundle is group of intervention. Now we know what are the group of interventions. So we have 6 interventions there, implementing with targets. So there's no point of doing these things without knowing what you are going to achieve. So what are the targets of these implementations? So with your fluid resuscitation, at the end of 6 hours, you see whether there is an improvement with the volume status. What is the CVP? What is the MAP? What is the urine output? And what is the mixed venous oxygen saturation? And you have these targets. So if you are unable to meet these targets at the end of your 6 hours with the initial resuscitation, there's something wrong there where you are failing with your sepsis management. Have we missed anything in the bundle? Yes. If it is indicated, source control is very important. There's no point of keep on resuscitating the patient if the source, which is the culprit for this clinical condition, continue to be there. For an example, in our patient, he has a cellulitic infected wound, limb. So there should be a surgical clearance for that. So the source control in early stage, they are in the bundle, is very important. When you are going for a source control, it is very important to go for a minimally invasive way. If you can do it with the percutaneous way rather than opening method, so that is the minimal invasive way of surgical control is very important. Right. That is the basic components of sepsis resuscitation initial 6 hours. Apart from that major basic components, there are some supportive therapy. Steroids. What is the place of steroids in sepsis? So if the patient requires more than 2 inotropes, the guideline recommends to start on steroid. It could be hydrocortisone 50 milligram 6 hourly, or if you have the facilities, you can send it as 200 milligram per day. Corticosteroids are not administered for the treatment of sepsis in the absence of shock. That is why I said hydrocortisone or the steroids are indicated if the patients require more than 2 inotropes to maintain the MAP more than 65. And when the inotropic requirement goes down, you need to take it off. That's the first one. Secondly, what's the place of blood and blood product transfusion? If the patient is not a cardiac patient, you can wait, the hemoglobin concentration drops to 7. So if it drops to more than 7, the blood is indicated, otherwise not. But if the patient is a cardiac patient, your target is slightly higher than that. FFP. You are not supposed to give FFP to correct the lab reports. If the patient is clinically bleeding and plus your lab reports are high, you can consider FFP. Platelets. You are not giving FFP to platelets to platelet count in the report. But if the patient is going for a surgical, required surgery or line intervention or some surgical intervention, your marginal count is 50,000. And you can wait up to 20,000 if the patient is not bleeding. And if the patient is not bleeding, and you can wait up to 10,000, but if it drops below 10,000, the guideline says you have to infuse, give platelets regardless of bleeding. Then the sugar. It should not be hypoglycemia. It should not be hypoglycemia. So you have to avoid both entities. So you need septic patients, because of the steroids and the catecholamine stress response, they tend to be with high blood sugars normally. So it is very important to monitor the blood pressure at frequent intervals. Normally, the target blood sugar is like 110 to 180. So you have to maintain it with glycemic control need to be achieved. So like in our patient, if the patient was intubated, so it's very important to sedate the patient for the tube tolerance and for the comfort. But normally we don't paralyze the patient unless it is essential. Right. So if the patient goes into ARDS or the respiration is going to be deteriorated, you have another set of ARDSNet guidelines. So according to that, you go for permissive hypercapnia and you target your oxygenation with PaO2 to FiO2 ratio. So if the patient goes into renal involvement, you have to consider CRRT or the renal replacement therapy, whether it's CRRT or hemodialysis. You have to think of nutrition. You have to think of deep vein prophylaxis, deep vein thromboprophylaxis, and stress ulcer prophylaxis. So that is the general ICU management of a septic patient, apart from the septic resuscitation. So what is the place of bicarbonate? We tend to give bicarbonate because these patients are acidotic patients. But the recommendation is, unless the patient's pH is less than 7.1, you don't have to give bicarbonate, especially if the patient is on spontaneous breathing, because that can cause refractory intracellular acidemia. So bicarbonate is indicated if the patient's acidosis is pH is less than 7.1. The newer things are the hydrocortisone, vitamin C, thiamine are in the guidelines, but it's not very much commonly practiced. Right, that is a septic management. So septic management has two parts, your basic resuscitation and your general supportive organ care. Right. So with all these things, now our patient is gradually improving. He's picking up with his blood pressure with noradrenaline. Volume resuscitation done, and he was put on to maintenance fluid. Despite all these things, the only thing that here noticed is he's not producing good amount of urine, despite the blood pressure. So and his lactate is, his lactate is 6.6, he's persistently acidotic, and his renal functions are going up. So he was started on CRRT, and he's responding to that on the 5th day of admission. Source control was done. Metabolic acidosis is now resolving. Cultures revealed an extended spectrum of beta-lactamase producing enterobacteria due to meropenem, so antibiotics were changed. So supportive care was thought of. Vasopressor requirement is coming down now. He is producing urine, so the renal replacement therapy was stopped. On day 10, patient was going into a sedation hold and extubated accordingly. And day 12, all the supports were removed and he was discharged following day to the ward. Right, that is sepsis. So in summary, right, okay. Any questions so far? So there are a lot of questions here in the chat box. We'll go through at the end of the lecture. Right, okay. So basically, you need to know how to identify the deteriorating patient, the early warning score, and how to do it, and at what frequency, and to whom you have to inform. So depending on the clinical deterioration of the patient, what is sepsis and how to diagnose it. So the definition of sepsis and the diagnosis of sepsis. And what is septic shock? The definition of septic shock, And if you once you diagnose your sepsis and septic shock, how to manage it? It has two main parts: septic resuscitation with surviving sepsis guideline campaign resuscitation bundle, and the supportive care. Right. So the most important thing is the early recognition. That is the most important thing, because with delayed recognition, you won't be able to resuscitate the patient adequately. Right. So forget about these parts. Right. So it's very important to recognize it early, to resuscitate it early, and to refer early. Okay. Shall we go through a few questions here? Roshan, am I exceeding my time?
Yes, bit exceeding. Because Dr. Gayatri is there. So we can answer the question on the chat box while the lecture is going.
Yeah, I'll do that. So
Yeah.
I'll try to do the answering onto the chat box, and you all can go through. And thank you very much for your kind attention and the patience. Thank you.
Right. That's Dr. Lakmini Perera, consultant anesthetist at Anuradhapura Hospital on sepsis. So next up is acute kidney injuries by Dr. Gayatri Shamila at DGS Norelia, consultant anesthetist. Over to you.
Thank you, Dr. Roshan.
Yeah.
I just want to know whether you can see me. And
We can see you. The slides are coming up, I guess.
So welcome all of you to this is acute kidney injury presentation. This is another important topic. And firstly, we will go through the objectives. So firstly, we have to know why we should learn about acute kidney injury. Then there are various definitions. I'm going to take you through some of the definitions. Then risk factors of AKI, and following that causes for AKI, and then how we are going to identify acute kidney injury, and how you are going to classify the severity. Lastly, I'm going to discuss about the management of AKI. So why it is important? Because it increases hospital mortality and morbidity. Not only just ward admission, it increased ICU admissions as well. It account like 40 to 60% of ICU admission. So it is important. As a consequence of that, it increases hospital costs. Indirectly, it is a burden to the country. So you have to know about acute kidney injury. So as I said, there are various definitions. So I'm going to take you through some of them. This is the simplest way of defining AKI. So you know what are the functions of AKI. So usually renal excretory and maintaining the homeostatic functions. So there will be an abrupt decline of those functions. As a result of that, there will be accumulation of the waste products, especially nitrogenous waste. And body fluid balance also maintained by the kidney. So it plays a major role. So it is failed, and there will be electrolyte imbalance and acid-base imbalance. So that is the simple way to define acute kidney injury. However, we need a better way of defining. So I think some of you are aware there's a KDIGO, that is an international body which produce renal pathology related guideline, and they update regularly. So it defined in 3 ways. Defined with the serum creatinine value. So if it is increased by 0.3 milligram per deciliter within 2 days. That means within 48 hours. So you can say patient is having AKI. There's another way. If it is increased by 1.5 times the baseline within 7 days or from patient's baseline value, then again you can say that. Having said that, initial part of acute kidney injury, serum creatinine is maybe normal. So it is a downside of serum creatinine. Now there are novel biomarkers also, but those are not freely available. I prefer to go by urine output. So normally urine output in adult, it is 0.5 ml per kg per hour. So if it is less than that for continuous consecutive 6 hours, then you can take that patient is kidney already damaged. And so it is you can see like within hours you can detect it, and so it is alarming and you can diagnose. So it is a better way of defining acute kidney injury. Then you can start your treatment early rather than just waiting days. And then we'll consider about the risk factors. There are some non-modifiable risk factors like gender and age you can't change. Usually, in general, female at high risk. But in like perioperative period, male are prone to get AKI, so it changes. Age, especially elderly patients who are having less organ reservoirs, so they are high risk. Another one important thing is comorbidities. So most of the comorbidities, but I'm going to concern common one like hypertension and diabetes. So if they have those conditions for a long time without good control, then they can have those condition related
Recording in progress.
And then malignancies. So the malignancy itself, right? It may present in the kidney, and then it is a risk factor. It is not only because of that. Sometimes other pelvic tumors which compress in the urinary tract, causing make them risk. And we have to use a lot of cytotoxic drugs, which are nephrotoxic as well. And they undergo major and emergency surgeries for malignancy. Then again, that also makes them their kidney vulnerable. The next one is infection. So any sepsis, or especially if they have urinary tract infection, so kidney become vulnerable organ. So as I mentioned earlier also, so if patient is undergoing emergency and major surgeries, they may be critically ill, lot of issue, blood pressure fluctuation, blood loss. So all these things make the kidney vulnerable organ to get damaged, right? Then blood and blood product transfusion itself cause make a kidney a risk factor. So blood transfusion is a risk factor. And medications, there are a lot of medications, like there will be like 100 of drugs. But common drugs like non-steroid anti-inflammatory drugs, furosemide, aminoglycosides. So you have to be very careful and go through the drug chart or get the drug history to exclude those kind of medications, right? So those are some of the risk factors for AKI. Then we'll consider about the causes of AKI. That is pre-renal, renal, and post-renal. So there are overlap between risk factors and causes. Just concentrate on this figure. So I just want to highlight that before the kidney, that means the blood supply to the kidney, we have renal veins and artery. If any problem related to systemic blood flow or the local blood flow, that means the renal circulation can get affected. That's how pre-renal renal impairment happens. And then the kidney. So kidney contains a lot of tissues, like it has glomeruli, nephrons, so it contains tubules. Then interstitium, there are blood vessels inside the kidney. So any pathology related to those renal tissue make renal cause, it become a renal cause to cause AKI. So then post-renal means, so it is behind, like below the distal to the kidney, that means the urinary tract. So usually it is mainly because of the obstruction of that urinary tract. It can be like internally, any pathology related to or external compression. So we'll go through in details. So pre-renal, I said, can be like systemic blood flow reduction, something related to the systemic blood flow. So hypovolemia, that is one of the commonest causes for AKI. So how does hypovolemia occur? Maybe bleeding, maybe trauma, then dehydration. Patient may be having vomiting, diarrhea, lead to dehydration or septic shock. Then extravasation of intravascular fluid and hypertension due to any cause. Or maybe cardiac related, especially low cardiac output status, acute or chronic heart disease, or severe cardiac pathology, which reduce the circulatory blood volume. Then local impairment of renal circulation. Some of the medications that can reduce the local blood flow, like in stressful situation, non-steroid inflammatory drugs can reduce the local blood flow. And renovascular disease, for example, renal artery stenosis, and maybe CKD related, that is chronic kidney disease. So they have less renal reservoirs, and their pathology can change the renal blood flow also. And chronic liver disease, it also impairs the renal blood flow. Sometimes there's some organ crosstalk which lead to affect the kidney. And abdominal compartment syndrome, that is increase in intra-abdominal pressure more than 20 millimeters of mercury. How does it happen? Maybe with the pelvic masses, severe ascites. Likewise, those conditions reduce the renal blood flow. Maybe so it may be with the direct compression, direct effect of that. So those are the local impairment. Those are the causes of local impairment of renal circulation. So then renal causes. So as I mentioned previously with that figure, so tubules can get damaged with the drugs or contrast. We are using for contrast-induced images. So it is called a contrast-induced nephropathy can happen. Then inflammation or infection can affect the tubules. Rhabdomyolysis is another common cause which can occur in, especially in trauma, burns, Yeah, so in those conditions. Then metabolic syndromes, especially, famous, like common one is diabetes mellitus, which damage the kidney tissue. Then autoimmune and inflammatory conditions like glomerulonephritis, Goodpasture syndrome, vasculitis. So those conditions, they have auto antibody immune system get activated, and their kidney get damaged, and so those are the causes, renal causes to cause AKI. So post-renal, it is mainly because of obstruction distal to the kidney. The common causes like prostatic hyperplasia, so with especially in elderly population. Then calculi is common in Sri Lanka. So maybe urinary bladder, but it doesn't cause much obstruction. Yeah, so calculi, then bladder tumors. So those things can cause back pressure and damage the kidney. So those are kind of internal, but externally also urinary tract can get compressed with the pelvic masses, retroperitoneal fibrosis. So those are the causes. So first we discuss the risk factors for AKI. This is the causes for AKI. So those things are important to know because you have to know the cause to treat the patient. So from history, examination, and investigation. So you need to identify the cause and treat the cause. So that's why it is very important. Otherwise, patient won't recover. So this slide, so I want to discuss about the risk factors for AKI. So sorry, I'm really sorry. This is how you're going to assess the severity of AKI. So this is well-known criteria. So rifle, you must have heard. So there are criteria, either GFR or serum creatinine value or urine output. I'm not going to in detail of each stage, but one thing, so I wanted to highlight this. So you are not going to wait until patient is going into the failure stage in your ward or ICU. You have to detect it early as possible. Then it is easy to recover the patient, maybe up to back to normal. Otherwise, they will have residual damage, and they may go into you are losing that kidney, and it will go to end-stage kidney disease. You are, as a doctor, they are to like wait until failure stage and then detect it. You have to detect it early, unless they so at home they are at the stage of failure and admitted to the hospital. Then you can't help. But if the patient is in the hospital and patient is deteriorating, you have to detect early as possible and assume that is a medical emergency, like some guideline. So the AKI, they mark it as a medical emergency, same as a septic shock. Now it is well known, it is a medical emergency. So I also agree this is a kind of medical emergency. So you have to act then and there and avoid all the risk factors and save the patient. So with the creatinine and urine output, you can calculate the GFR and so assess the severity and then treat quickly, right? Otherwise, you are going to lose the patient's kidney and they will end up in end-stage kidney disease, so on regular dialysis or need renal transplantation, right? So you should not send the patient to that level. So detect it early. So that is the take-home message from this severity classification of the severity slide, right? So how you are going to identify AKI? So from your medical school knowledge, you know you have to take a thorough history and examination, and then you have to do relevant monitoring and investigation. So I'm not going to go in detail about the history and examination, but so it is the thorough history and examination to purpose is to identify the risk factors, and then find out causes, maybe single or multiple causes for AKI in that particular person, and identify the features of complication of AKI. Then order relevant investigations and start managing patients. So we'll see what you can monitor in acute kidney injury patient. Obviously, urine output. If you can measure it accurately, maybe catheterize, so it is important. Then heart rate, capillary refill time, those things like vital sign assessment, blood pressure, saturation, and better to have dynamic monitor. That means the continuous monitoring with mostly with invasive monitoring, like intra-arterial blood pressure monitoring. If the patient is critically with multi-organ failure, even cardiac output monitoring. The one more thing to highlight, monitoring, you're not just getting one reading and you're going to, so everything is normal, but patient is having risk factors and causes, so you're not going to enjoy your tea, alarming that patient is going to have AKI. So you have to be with the patient, get trends of parameters, because patient can get deteriorate. So then you get overall picture on patient, right? Then relevant investigations, urine albumin, and then then investigations like blood investigation, blood urea, serum creatinine, then electrolytes especially. So blood urea and creatinine, they are always high. As I mentioned, the creatinine can be initially normal. Then electrolytes, sodium and potassium. Potassium, there will be hyperkalemia. So it is a life-threatening emergency. So you have to check potassium. Then those investigation, blood investigation, it will take some time to appear. So good bedside test is arterial blood gas analysis. So in general, they get metabolic acidosis there. Other things you can gather from the blood gas is lactate level, potassium electrolytes. So that is a good investigation you can do. Then some of the images depend on patient condition. So chest X-ray, if there's a features of fluid overload, pulmonary edema, pleural effusion, so you can detect them. And if indicated any obstruction to the urinary tract, if there's any calculi, you can do X-ray KUB. So ultrasound scan, again, if it is relevant, to find out hydronephrosis, any features of AKI in kidney, and then intra-abdominal pathology which affect the kidney, you can detect those things. ECG, especially if they have cardiac pathology and hyperkalemic features, you can detect. Likewise, you can do more investigation relevant to the patient, right? So then you have to know what are the complications of AKI. Obviously, there will be a low urine output. And there will be metabolic acidosis, as I mentioned previously. Bicarb will be low, H+ will increase. There will be fluid overload features because kidney take out excess fluid and maintain the fluid balance. So you had to auscultate the lung, any fine crepes, generalized edema, look for those things. Electrolyte imbalances, again, I want to highlight the hyperkalemia. If potassium is 6 or 6.5, you are just not base the investigation on BHD and just leave. You have to be with patient and treat it. Otherwise, patient may go into cardiac arrest with increasing potassium. Then uremic features like encephalopathy may be altered, conscious level behavior, restless. And pericarditis. Obviously, patients' mortality and morbidity increase if there are complications of AKI. These are some of the common complications of AKI. So you can see, like, if there are like kidney get damaged, it is not going to be like just a kidney get damage. There are always organ crosstalk and it affect the other organs as well. So then so this is the last part of the presentation, management. So the most important thing, it is a kind of medical rule. You have to identify the cause and treat the cause, right? So that is the main thing. Then common thing is pre-renal renal impairment. There you have to depend on the cause. Most of the time you have to hydrate the patient. There you can use fluid resuscitation with the normal saline, or initial part you can use albumin as well. Avoid starches because it itself cause acute kidney injury. So, and I read some articles that they say like they force water staff to prescribe water. You feel it is a foolish thing, but sometimes I also noted, so at home patient takes some amount of water, but from admission to the ward, you stop giving any fluid, any food, and so the hypovolemia increases, right? So the severity of hypovolemia increases. So maintaining their fluid balance is important, right? Then blood pressure, again, fluid and relevant in inotrope depend on the condition. Then you have to monitor the blood pressure continuously. And sometimes you may like hyper enthusiastic and start higher dose of inotropes and blood pressure shoot up, then you reduce the inotrope, then it goes down, right? There will be a lot of fluctuation. So you have to smoothly control it because researchers have proven that even increase in one blood pressure or one severe hypertensive episode can damage the kidney. So it is important to maintain the blood pressure. Then nephrotoxic drugs. You have to go through the drug chart and see any nephrotoxic drugs. Avoid them if it is not possible. You have to give renal adjusted doses of drugs. So aminoglycoside, if you really want to give, there's no alternative. Give it as a single dose than multiple doses. Then contrast. So where the risk and benefit, whether it's really indicated to do contrast induced, contrast mediated images. So KDIGO, they recommended to give sodium, so normal saline or sodium bicarbonate prior to the contrast and continue afterward also. I usually use normal saline 1 hour prior, and just after contrast images done, then I ask my juniors to just start normal saline from so radiology suit itself start normal saline. So that is the one way to prevent, right? Not 100%. Then general management. So this is common to any organ damage, like so any organ made up of cells. So you can give glucose. So any cell required to survive with the glucose and oxygen. So glucose, so the guideline is to maintain it between 110 to 149 milligram per deciliter. Anemia, so of course the hemoglobin is required to carry oxygen, take out some of the carbon dioxide, and other function as well. So avoid anemia and give nutrition to these damaged cells. So a recommendation is to give 20 to 30 kilocalorie kg per day. So that should include protein as well. You are not, you have to give some protein, right? Not like totally cut off protein. So again and again, I want to highlight correct serum potassium. So it has to be correct. Then if indicated, consider about the renal replacement therapy. There are some myths about AKI management, furosemide. You are not going to give furosemide to correct AKI. You all know that is a nephrotoxic drug and still giving to damage kidney. So if there's a fluidol, or you can try with furosemide, but not for other things. Dopamine, small dose, it doesn't improve renal function. Protein, you have to give protein, right? So indications, even though there are like various indications, but sometimes patients are having some of these. So take cumulatively everything and then decide whether patient required renal replacement therapy. So the refractory hypokalemia and metabolic acidosis, which are unable to correct with medical treatment, and uremic features or obvious fluid overload. Then I'm not going to in detail about the renal replacement therapy, but common things like peritoneal dialysis, hemodialysis, and CRRT available in Sri Lanka. Preparation, even though you are RHOs, there are like things you have to yourself or you have to advise your juniors. Usually the decision is taken by physician, and so communicate with the dialysis unit, visit hemodialysis. Then you have to insert an invasive line, vascato PD. So there you had a concern about the coagulation of the patient. So any bleeding manifestation, platelet count, INR, and antiplatelet and anticoagulation drugs. Right. Then transportation of the patient. Sometimes patients need monitoring if they are unstable. So especially with hemodialysis, they can get unstable. Then prepare any inotropic support. If they need inotropic support, prepare for that. This is, I want to just to show you, this is a critical care session. We commonly use CRRT in critical ill patients. So VASCAT has two lines, one acts as a vein, the other one as an artery, and filter, it is mimicking the kidney. So yeah, so CRRT is better than hemodialysis because it maintains the hemodynamic stability. Fluid balance management wise, it is superior, and septic shock, brain injury, hepatic failure. So CRRT is better than hemodialysis. Post dialysis, you have to do investigation, assess whether the patient again required renal replacement therapy, take care about the invasive line. So this is the last two slides I want to show. Like so I want to summarize everything. There are care pathways. So it is the kind of bundles we use. So it is called ACPEAT, AKI. So all the things I have told so far. So it is a summary in these 2 pages. Keep this in your ward or ICU setting also. Then you are not going to miss anything, so you will save the patient. So A is assessment, C is, so all the things I have mentioned, risk factors and causes are there. Then confirm the staging, so creatinine value and urine output. T is treat underlying cause and complications. Then B is the blood investigation and ABG findings. Examination of urine, that is to check any albumin, any abnormalities. Alter the drugs, as I mentioned, nephrotoxic drugs, avoid them. Fluids, treat with IV fluids, avoid contrast, kidney screening, images. So if there's obstruction, you have to do relevant images within 24 hours of admission and try to correct because it is important. Then refer the patient to relevant unit, critical care, nephrology, urology, right? So it is important. So this is the summary of everything. So you have to follow. So take home message, it is important because increase the mortality and morbidity. So you have to, the main thing is you have to identify the underlying causes, maybe cause or causes, risk factors, assess the severity and identify the complication. Treat the underlying cause, that is the key thing. Sometimes you expose again patient to the risk factors, so you should not. And prepare and manage with renal replacement therapy if indicated. So thank you, that is all. These are my main reference, but I prefer a lot of things. Right? Thank you.
Right. Thank you, Dr. Gayatri Shamila, consultant anesthetist, Norelia District General Hospital on AKI. There are some questions on the chat box, madam. If you could answer them, it should be great. So we go to the next lecture by prone positioning by Dr. Dushant Atapattu, consultant anesthetist as DDH Chilao. Over to you, Dr. Dushant. So, Dr. Gayatri, there's some questions on the chat box.
Yeah, I can answer. Can I answer or just?
Dr. Dushant is supposed. Yeah.
Okay, so I'll answer them. Yeah.
Yeah, until she starts. She starts. Yeah. Are you there, Dr. Dushant?
Yeah. Hang on.
So.
Yeah. Yeah, okay. Can you all see? Hello, can you hear me?
Can hear, yeah.
Then can I start or Gayatri is continuing?
Yeah, Dr. Gayatri can stop sharing, then. Right.
Okay, y'all can see my screen, right?
Yes.
Okay, it's yeah, right. It's prone position ventilation. So this is a bit of a hot topic for the last 1.5 years. You may be, so you know that with COVID pneumonia and COVID pneumonia complicated with ARDS, we are talking more about this prone position ventilation in the critical care setting. Right, so it's a rescue therapy in ARDS mainly because of the so if you identify what is prone position is prone ventilation in ventilation that is delivered with the patient on the line lying on the on his chest, you know, the on prone position, right? So the evidence is yeah, especially during this especially in severe ARDS patients, there are many studies, multi-centered randomized control trials were done and have shown there is a significant benefit, mortality benefit in prone position ventilation, especially in the patients who are having severe ARDS. So one of those studies is ProSiva, that was a multi-centered randomized control trial conducted in Europe, where they have shown a significant mortality benefit. That is, after 28 days, mortality has reduced from 38 to 16%, and 90 days mortality has dropped from 43% to 22%. So it's half the mortality of the mortality. So that there is a significant benefit have shown in prone position ventilation in these patients with severe ARDS. Right. So when to do the prone position ventilation? So the patient, so when do we say, so this is something, I mean, ARDS criteria. When it comes to ARDS, we categorize the PF ratio, that is partial pressure of arterial oxygen into FiO2 ratio. So it is, if it is more than 200, so like 200, 300, we say it's mild ARDS, and if it is between 100 to 200, so it's moderate, and if it is less than 100, it's severe ARDS. So it's more benefited in patients with moderate to severe ARDS, where PF ratio is less than 150, and has to be started at the initial stages of the disease rather than waiting until the last moment. So the duration, again, they have recommended is 16 to 24 hours. And then, so what are the mechanics which involves in this ARD, I mean, in prone position ventilation? So it improves the oxygenation in patients by shifting the blood flow to regions of the lungs that are better ventilated. You know, when you know that in upright position in a normal person, our bases are better ventilated and better perfused, so that the VQ, that is perfusion and the ventilation coupling, is ideal in low, I mean, the bases of the lungs rather than the apex. So that is in upright position. So and in, you know, in ARDS patients, these are, it's kind of a super inflamed lungs where there are a lot of dead space, the VQ mismatch and shunts occurring. So that by doing the prone position, we try to improve the oxygenation by shifting the blood flow to a better aerated or better ventilated areas. And also it also, by doing the prone positioning, it facilitates better movement of the diaphragm, so that it allows again the abdomen to expand more fully, so without compressing on the without the abdominal contents compressing on the diaphragm, and thereby reducing the lung expansion. So what are the criteria? So if you take the criteria to identify to categorize the ARDS, so it's acute onset of respiratory failure, and it's hypoxemia as we go by the PF ratios, and there is radiological evidence of diffuse bilateral pneumonia, pneumonic infiltrations in the X-rays. So the therapy for refractory hypoxemia with conventional mechanical ventilation is not adequate in patients with severe ARDS. So once they come to a moderate to severe ARDS, whatever the conventional mechanical ventilation is not adequate, so that this prone position ventilation comes as a rescue therapy. So what are the contraindications? So even though if we talk about this process, there are some contraindications as well. The spinal cord instability and unstable fracture, especially involving in facial and pelvis, and also the open abdomens. You know, sometimes after the trauma and some abdominal intra-abdominal operations, they tend to keep the abdomen open, especially during this damage control surgery. So where it's again a contraindications for prone position. And also the patients with increased intra-abdominal pressures, and also the patients with elevated ICP, intracranial pressure, where head injury patient, and intestinal ischemia. So these are some of the contraindications for for prone position ventilation. So yeah, but saying that there are some complications as well associated with this prone position. So name to few are the prone position that you can I mean, they can become hemodynamically unstable, and also dislodgement of the central venous access. So not only the central venous access, but other invasive lines and other IV access especially can get dislodged. And then transient arrhythmias, these patients are critically ill. So there are many factors which trigger the patients going to AF and atrial fibrillation and other arrhythmias. So you have to be cautious by doing this procedure, that you may worsen the condition of the patient. So not to do in those patients. So these are the possible complications, and also reversible dependent edema of the face and the anterior chest wall, and the contractures. So the contractures, especially when you are in prone position, it's difficult to do this limb physio and so on, so that there is a possibility of contractures. And then enteral feeding intolerance and aspiration of enteral feeding when this reposition, and also the eyes due to the pressure effect, that it can get corneal ulcerations. Let's talk a bit about the physiological effects. How does it affect the oxygenation? So if you take the patient on the supine position, so that your chest is, the anterior chest wall is the ventral surface, and then the back is the dorsum, so that the weight of the lung is more compressed and compressed on the lung, so that it doesn't allow the lung to expand fully. And the other factor is the heart. The heart is more compressing when you are in the supine position. The heart is more compressed on the lung tissue. So there's only about there is a diagram as you go on. Yeah, I'll show you. So that there the about 50% of the lung tissue is compressed by the heart, whereas only about 20 to 30% is there for the ventilation, for the gas exchange in when the patient is in supine position. And the other factor is the GI contents, the intestine and the stomach, all this compress on the diaphragm, so that it pushes on the so so when it is pushing, it doesn't allow again the lung to expand fully. So what will happen when the patient put on the prone position? So there will be much more uniform expansion of the alveoli, more from the dorsum. Now the dorsum is on the up, right, so that your spine is on the up, so it allows more uniform alveolar ventilation in prone position. And also the heart is now more dependent on the sternum rather than on the lung tissue. It's more dependent on the sternum, so that again improves the oxygenation and the perfusion as well. And the other thing is your GI contents. Now it's on the when the patient is on the prone position, we allow the abdomen to move freely, so it's not compressing, so that your anterior abdominal wall is freely moving. So the GI contents is it's not further, compressing on the lungs, so that the lungs not on the diaphragm, so that the lungs can expand expand freely than in supine position. So and also with the more blood flow is occurring from when the patient is in the prone position, because that it take off the pressure of the lung, so that your hemodynamics improves, so that the better perfusion. And so if you go on to the slides, yeah, its heart is more depend on the sternum rather than on the lung tissue in supine position. And so the smaller volume of the depends, so the lungs are so the more part of the lung is there which is not compressed by the heart, so that larger part of the lung is involved in gas exchange. So this homogeneous so that will cause homogeneous pleural pressure gradient in the ventrodorsal as well as the cephalocaudal plane, so that improves the oxygenation and it reduces the shunt. And also, so as I said, the abdomen is unsupported, so as it freely moves. Now it's not compressing for anymore on the diaphragm. So the secretions are more mobilized, so that it's easy to get rid of the secretions by physiotherapy and other measures, so that again improves the oxygenation with better ventilation. And also, improves aerosol delivery. So if you are, when you are nebulizing and so on, so again it's easy to it's quickly and it's easily distributed to the lungs, right? And then so more homogeneous perfusion. Yes, it's more now as I said, the heart is not more dependent on the lung as it is in the supine position. Now you are in your prone position, it's more dependent on the sternum. So the weight of the lung, weight of the heart on the lung is now minimized. So again improves the ventilation, the perfusion, and so the VQ matching with there's no less VQ mismatch. So all these slides describe the same thing. So the shunt is perfusion is there, but no ventilation. So with redistribution of ventilation, perfusion causes to the more aerated parts of the lung, and there's also redistribution of ventilation to better perfused areas of the lung. So by all these mechanisms, it increases the oxygenation ultimately. So this is just a slide to show, this is of course in the upright position, the hypothetical zones of the lung. So that is zone 1, 2, 3. And then yes, so this is the slide I told you, so that they have shown, this was one of the studies which was conducted some years ago. So again, it shows that the heart is compressed more, the fairly a large part of the lungs is compressed by the heart when the patient is in the supine position. As you can see now, this is in the prone position. So the area of the lung which is compressed by the heart is very much less when you compare with the supine position. That's a bit about the physiology and the mechanical effects of prone position. So what do you need? What are the equipments you need to do this prone position? So proning bed or other prone positioning device. So but in our setup, of course, we do in our ICUs, the same bed we do proning, and then gloves and and other equipments. Never forget your PPE. So you wear as appropriate, because in today's situation, all the ARDS or severe pneumonia, you have to consider as COVID unless proven otherwise. So you have to protect yourself as well as the other staff. So so don't forget your PPE, and then draw a sheet and small towel. So these are some of the equipments that you need: suctioning equipment, oral care supplies, eye lubricants, so on. And then preparation. So how will you do this? So you need adequate staff to continue on to implement this one, because it's not easy, you know, to turn the patient, especially a paralyzed ventilate patient, to turn on the back. So it's not easy, right? So you need adequate staff. So at least 4-6 nurses and the airway doctor, usually an anesthetist or a medic or a doctor who is in the ICU. Should take care of the airway, because so there are many incidents where the airway or the ET tube or whatever, ET tube has come out with your prone position. So you have to make sure it's secured, and whoever the doctor who is in the head end of the patient taking care of the airway, you only focus on the airway, right? And then ensure patient is well sedated and paralyzed. Yes, these patients are critically ill, and sometimes they are with multi-organ failure, with many multiple inotropes. So we tend to paralyze and ventilate these patients. So not only the paralysis, you have to sedate them once you have started paralyzed, and then ensure ET tube is well secured and no cuff leaks, and ensure all the lines are secured, especially your central venous line. If there is a VASCAT, again those things, and the other, if the patient is on parenteral nutrition, and make sure everything is, all these lines are well secured before you start the procedure. And also the protecting of the eye with the eye pads important, and ensure all medication for resuscitation is ready and it's by hand. So the patient can become unstable at any moment. So you have to make sure that your resuscitation trolley is ready, and then disconnect all the equipments that are, I mean, if the patient that the patient can stay without. So hardly we have any, because most of the equipments attached to the patients are really necessary. But of course, yeah, if you don't need any sort of thing, you think, okay, you can just disconnect it. And then reposition of the ECG leads before and after proning of the patient. So the prior to turn, again, this is here, I mean, over and over again, this is discussed, because to show you all the importance of securing the lines and other equipments when you are before doing this procedure. So ensure emergency equipment is available, correctly position all tubes and invasive lines. Electrodes for cardiac monitoring, move to the back. Yes, put them, the ECG leads on the back, and then always turn the patient in the direction of the mechanical ventilator. Yeah, so it's more easy access. So, and make sure the patient's tongue is inside the mouth. So because these things can happen, you know, these patients are paralyzed and sedated, they can't move not even a finger, so that their tongue, I mean, tends to bite the tongue. So there are massive blood loss. Sometimes you won't notice. So these things can happen. So make sure that the tongue is inside. It's not biting, I mean, when you're turning the patient. And then suctioning, if there's any secretions is coming out, so you suck out the secretions, secure patient's ET tube or the tracheostomy. And and also before doing the thing, prior to turn, perform anterior body wound care and dressing changes. So you better do those, you know, the wound care and dressing before you start turning the patient, right? And then empty the ileostomy or colostomy drainage bags, and make sure that the break of the bed is engaged and position the staff appropriate. So you have, if you are the leader, if you are the commanding officer there, so you have to place the staff where you want to do, and where you want them to be, and where what you want to do. So you better give the instructions prior to turning of the patient. So this is called the Cornish pastry method of prone position. There are many YouTube videos on YouTube, so you go and check it, you see how it does, and then there you keep two pillows, one under the shoulder, the other one in the legs, in the thigh area, and then and there are and the sheets covered, and from both sides you cover a sheet, and then you tuck it from both sides, and then you command whoever who's giving the commands, you have to first turn to 90 degrees, and then the proning, and then so on. So there are videos, you can see these on YouTube. Yeah, so this is how once it's done, this is how it looks. So you can see the patient is on the face on one side, and the hands on either side. So it's swimmer's position. We call this swimmer's position, and the abdomen should be freely moved. You know, it should not be compressed on any surface, right? So just after the turning, so immediately assess the patient, auscultate the lungs, and see whether any possibility that the tube has dislodged or has come out, disconnect. So make sure that the patient and the other monitoring, the vital parameters are there, right? And then the cushion, the head and the ear. Yeah, so you have to keep, these are the pressure points. So with to avoid unnecessary pressure effects, you have to make sure that the head is nicely kept, and then with cushions, and then ear and eyes and so on. So allow the abdomen to protrude, so we allow it to freely move, and so that the body alignment, position the arms, the swimmer's weave, and it's slightly head tilt up, so that is reverse Tenderenberg, and reassess the ventilator parameters. Once you done, reassess the ventilator parameters. So you can do either volume control or pressure control ventilation in prone position. And then a bit of the nursing care, so ensure adequate analgesia and sedation. So this is very important, even in the, so you may need to give more analgesia and even sedation during prone position, and the neuromuscular blockade. So these patients are paralyzed while they are on prone position, and monitor lines and ventilator connections immediately after proning, and look into the pressure points, face, chest, and the knees, and change the head. So when they're in you have to change the head and the head position 2 to 4 hourly, and check arms and legs for any dislocation. So those are again a possibility, right? And then remember reposition of the patient's head and extremities every 2 to 4 hours, and give oral care. So as you give the normal nursing care as a normal supine patient, so give oral care and suctioning as needed, and patients may require increased sedations during proning, and to reduce the risk of aspirating the gastric contents during and turning procedure, turn off the tube feeding 1 hour prior to turning, right? And then monitor the patient's response to proning by pulse oximeter and mixed venous oxygen saturation. And then once you are done with these procedures, you have to, the proper documentation is again very important. So this is one of the area that which is negligible, you trying to neglect. So don't do that. I mean, you have to document properly the when do you start and the time and everything. What you have done is very important. Patient's response to the and then the other thing, the patient's response to the therapy and ability to tolerate the turning procedure, length of the time in position and positioning reschedule, and then the monitoring complications and other interventions you have taken during this period. And then there's something called wake-prone ventilation. So that is again for the patients. For the last few months, I mean, we manage patients even at home. So you know that, and even in our hospital setup, HDU, we tend to when we manage in these patients who are not severely ill, even not severe respiratory distress, we always advise them to do this awake prone position, proning. So here again, the patient is on the lying position, lying on the prone position, and then every half an hour to 2 hourly, you have to turn the posture should be changed again into the left side, and then you can sit up the patient by putting some pillows and make the patient seated up, and then again on the put the patient on the right, the other side, whatever the other side of the other side, right? So this is just a summary, again a summary in the sense of the instructions and what are the contraindications and of the awake positioning, awake proning. So consider prone position only if the patient can adjust position independently, so that the patient should be conscious, rational, and should communicate and cooperate and know, and also we are not anticipating any airway concerns where the patient is spontaneously breathing and is not not in respiratory distress. And there are some absolute contraindications where, like respiratory distress, hemodynamic instability, altered mental state, unstable spine, recent abdominal surgery and thoracic injury. And then the relative contraindications are morbidly obese and advanced pregnancy, facial injury, and neurological concerns. So these are some of the contraindications and relative contraindications for awake proning. And then procedure, so as I said, explain the procedure to the patient and explain the benefit, so you can get the maximum benefit by doing this. You have to explain, because sometimes they are not used to this, and then so that the compliance would be poor unless you explain well to the patient. So ensure then secure the oxygenation therapy and so adequate length of tubing, yeah. And then the patient should be changed position as follows: so 30 minutes to 2 hours lying on the right side, and then 30 minutes to 2 hours seated up position, and then left side, and then prone, and then likewise it keep on going, right? And then monitor the oxygen saturation after every change, so that you can check the saturation and see whether the patient is responding. And then if deterioration of the oxygen saturation, you can increase the FiO2, or the other thing is consider return to the supine position if they are really deteriorating, right? And discontinue if the respiratory rate is more than 35 and if they are becoming tachypneic with more respiratory distress. And then if there's no improvement, again you may consider to stop the thing. And if the patient is unable, and if they are not happy to tolerate, I mean not cooperative to tolerate this for anymore, then again it is time to discontinue. So yeah, that's about the prone position, prone position ventilation. So, so you stay safe, and whenever you are doing this procedure, as I said, so it is better to start in a critically ill patient at the early stage rather than waiting until the last moment. Okay, thank you. Any questions?
Yeah. Thank you, Dr. Dushan Chatapat, on that detailed lecture on prone positioning. Seems like no questions. If any, yeah.
Okay. All right. Thank you.
Yeah, thank you. So we go to the last lecture of the day. Communication, consent, and documentation by Dr. Sudarshana Jayasekar. Over to you, sir.
Thank you. Can you hear me? Yeah.
Yes, can.
Yeah, I will share my screen then. Okay, can you see my slides here?
No, not yet.
Okay.
Yeah, we can see now.
You can see the slides, okay?
Yeah.
Okay, I'm going to focus on communication and consent here. And first I will discuss about the communication. These are the learning objectives. In this lecture, we'll be discussing what is communication and basic components and the process and barriers of effective communication and why it is important. And I will briefly discuss on what are the challenges related to communication in ICU and special occasions. So when you say communication, the word communicate derived from the Latin word communicare, right? That means it is to give, or like it's to impart information, to make known. So also it makes you participate and share information. So the communication is a process of sharing information, right? And so this involves giving, receiving, and exchanging information, and it can be opinions or ideas. And it can be in various means like writing, speech, and visual means. So that it can be identified, the material which is communicated can be identified completely by who's concerned. And usually there's a provider, like there can be more than one providers, and also there can be a sender and a receiver. The sender gives information and he will encode the message and send it through a channel, and the receiver will decode the information. and there will be disturbance, which is the noise. So when the messenger is gives the information, the coding, it can be either speech as a speaking, writing, or graphic, or even a video. And then the receiver will decode it and it will understand it. And there should be a common mode for them to understand, like the language. And also, if the receiver responds with a feedback, so that you can confirm the information is shared correctly. What are the negative outcomes of poor communications? So if you take like the communication breakdowns, which will cause treatment delays. Actually, the communication breakdowns will account for more than 86% of treatment delays. There are 4 main components of effective communication. The communication, it should be complete. So all the information, you should not give haphazardly. Everything need to be included. So it should be complete. And the message should be clear. And you should give only the relevant information, and it should be brief. And you should give the information at the correct time. Now we will look at the factors that affect the effective communication. There can be interruptions, like another person could come in and interrupt, or even when you're doing something, there's the communication will be difficult. Like if you're concentrating on one task and when you're giving commands or when you're communicating, it will be difficult. And also it should be like in a friendly manner. And if you give orders or any verbal abuse, and the message will not go into the receiver and he will not get it properly. And if you take fatigue, again, will affect the effective communication, and like factors like ambiguous orders or any change in the team members, which all lead to disruption in the effective communication. So when you take the barriers of effective communication, if you take the working conditions, if there are any lack of coordination or a follow-up between the team members or with the doctors or with the patients, there will be a defect in communication. And there can be distractions, like when you're doing something and if you're concentrating it on another patient, or misinterpretation, or if you're having a hierarchy, like if you're not having a friendly environment, or in a clinic setup, like the proximal proximity, like physical proximity, like if you are close to each other, even the patients will not divulge all the information to you, because the fear of hearing from the information to others. So if you take another set is the lack of resources, like the time. Time is a limiting factor. If you are in a clinic and if you want to see hundreds of patients and you can't allocate the proper time, then that will also lead to disruptions in communication with the patient. Again, the workload, something's related to that. And the technology, like if you take the technology, like if you are using IT and the persons who are using computers and you are not literate on IT, and then there will be disruption in communication. And another group of factors is the team composition. So if you have one set of team which are coming like day by day, like without any changes, there will be more, like the communication is more effective. But if you have changing team members every day, then there will be a difficulty in communicating. And lack of role clarity. That means like if they don't know what they are allocated for. And even some people are very defensive. And if you have any conflict or fatigue, all these factors will have barriers in effective communication. So what are the positive outcomes of good communication? So this will all lead to reduced length of stay, and we can give a high quality of care for the patients and a better outcome. And we will have a better understanding of the patient's needs and their family members' requirements, and also this will improve the patient experience. Communication is a part of a good teamwork and patient safety. So it's a key element of teamwork. So if you take this, see this triangle, the communication is one part, but others, like for a good patient safety and a care, you need other factors such as situational awareness, leadership, and mutual support. We look at the challenges of communication in critical care. So in an ICU setup, like it's a different environment, and you are handling with emergencies, and like sometimes you may have to attend to patients' needs briefly because it will because you can't delay the procedures and things, and then you might not have enough time to communicate even to staff or like even with the patients or relatives. So that's a challenge. And like also there is a lot of details, like not only the patient's vital signs, like there are a lot of drug infusions there, and for the even the nurses and everything. So there are high attention to detail. So their workload is more. And the situation changes very quickly, and there's uncertainty. And all these factors is a challenge in communication in a critical care. And in an ITU, like you will not only discuss, like you have to communicate with your patient, but here you have to, there's a team, like the nurses, the doctors, healthcare assistants, physiotherapists, radiographers, and dietitians. So wider range of people are involved. So it's very essential to communicate with all the parties and like to get the best outcome. And or not only that, you will be dealing with other specialties as well. Like you will be getting a cardiology input or respiratory input and other from the other specialties. So like need to have a good communication, and like they need to give the information very swiftly to have a better patient care. And if you consider the special situations in ICU, and especially a crisis communication, like in an emergency situation, in a cardiac arrest, we will discuss those by later. But the thing is, like the special situations, you need to practice to how to effectively communicate. And then you need to communicate, as I mentioned earlier, communicate with other professionals and discuss about the patients. And if you, it's not like a setup like where when you have a clinic patient, the patients are not conscious they are compromised, they are intubated, so you will not be able to communicate with them properly. And in an ITU setup, like you need to give information or communicate with their family members with their initial consultation when they admit, and also a clinical update, or in a special situations like end of life care, you need to communicate with them. We'll talk about crisis communication, like especially in an ITU setup or even in a ward, like let's say in a cardiac arrest situation or some emergencies like that. Here, two aspects we are talking: the task allocation and closed loop communication. First, we'll look at the task allocation in this special situation. So if there's a patient who is arrested, and if you just say, like if you wanted the adrenaline and you wanted the nurse or someone to bring the adrenaline, if you say, can someone draw up an adrenaline bolus? So this will not, like, this is not direct to a person, and you will not get your work done. But if you say, like if your colleague or a junior, you can say, someone, I wanted to draw up 1 in 1,000 adrenaline 10 ml bolus immediately and bring it to me as soon as it is ready. So you have to allocate the task to someone else and to be specific. That's called the task allocation. And we'll look at the closed loop communication. Here, a message is communicated, like if you say that the message is communicated only if it is sent and received only. Because like sometimes in a crisis situation, the people will like act differently, and then they think that they have given the instructions, but it's not said. And even if you say some instructions, it's not heard by the others because of noise and things. So even if it is heard, sometimes it's not understood. But again, if someone hears it, but if it is not done, again, there is a breach of communication. So in a closed loop communication, the sender initiates the message and the receiver accepts the message and need to provide a feedback, right? And then the sender again verifies the message which was received by the provider. So the closed loop communication is very important during emergencies, and it will be effective when you are removing the ambiguity from the instructions, as I explained to you earlier, and also allows questions if instructions was not heard clearly. And this will also allow others who are in proximity be aware of the proposed course of actions. They will know what is happening and then what are the actions are taken. So it will be aware by everybody. And another main thing is that the team leader need to have eye contact when making a request. Because the eye contact is a very, when you're giving an instruction to another person, even when you're asking by name, but the eye contact, then you know that it's directed to that person. And also it should not be in orders, and you have to give in a decent manner. And as I said, like it should be clear. Like if you say like you are ordering drugs or unfamiliar drugs in an emergency, because they're like, even if you give the instructions, the other person must not be like, will not be using it commonly. Like as an anesthetist, you will be very like you will be using propofol, for instance, if you will be using propofol very commonly, but the person who's going to get the propofol will not know about it as you. So what you have to do, like if you, rather than saying 50 of propofol, you have to tell 50 milligram or 50 ml, right? like that, and then you have to say like give 50 ml, 50 milligram of propofol, or like you have to say 5 ml of propofol, please, like in clear instructions. So we'll have an example like this here with a conversation with a doctor and a nurse. And then here the doctor says, Mala miss, I want you to insert a large book IV cannula to the new patient in bed 4 Silva, please. And the nursing officer is saying, Dr. Kamal, you want me to insert a 16 gauge IV cannula to the new patient Silva in bed 4. Then you are confirming that, saying correct. Then again, after doing that procedure, the nursing officer will say, I have inserted the 16 gauge IV cannula to the new patient, Silva in bed 4. Then you appreciate it. Thank you. So this is a closed loop communication. Next, we will look into interprofessional discussions like the handing overs and like informing a patient over the phone to your superiors and raising a concern and something about briefing and debriefing. First, we'll look at the handover. Handover is transfer of information along with the authority or the responsibility. Like it can be during a ICU handover from one medical officer to another, and or like after a transfer team is going and handing over to a patient to another hospital. And this will include opportunity to ask questions and clarify and confirm. And there can be a tool like I pass the button. You can use some tool like this to avoid missing out any information. So there's one tool called I pass the button. So in this, there's an introduction, patient, like I'll go one by one. In the introduction, like you have to introduce yourself, whether you are a registrar or the medical officer and your role. And then you have to tell about the patient, the name, identity, and the age of the patient. And also like you can tell the patient is coming from this hospital or the location or the ward. And then in the assessment, you have to tell the present chief complaint, like what is the patient is having, what's the problem, and their vital signs, symptoms, and if you have a diagnosis, the diagnosis, right? And next is the situation, and you have to say, tell what is the current status of this patient, whether it's an urgent case or emergency, like whether it's a routine transfer or something like the situation, and or any recent changes for this of this patient's situation. And then you have to tell about any safety concerns, any lab reports, or any allergies or alerts which will affect the patient care. Then you are telling about the patient's condition here, like you have to, if the patient having any diabetes or renal disease, the background, you have to tell about the background next. And what are the actions you have taken, like during the past time when the patient was with your care. And then you have to tell what are the things you need to do immediately, whether he needs some antibiotics in the next few minutes or any other insulin or anything, as though those things you have to tell, and what actions need to be taken as priority. Then finally, like you need to hand over the responsibility of the patient, who's responsible for this patient, and from this time who's responsible. And if you have any plans or like what are the things you are planned for future, then you have to tell about them as well. So if you have a structured pattern like this, so you will not miss out any information. Another acronym is ISBA. This is mainly used if you are giving any information, especially over the phone. So this is also a good structured approach so that it will avoid missing any vital information. So it's better to practice something like this so that you will not miss the information. So in this, like again, it's like it says, initially you identify or introduce yourself, who you are, your role, and then the situation, what is going on, and the background, and the assessment, and what recommendations you have. But when you see a patient, so you need to gather all this information before you are making the call, right? And for your superior, so you need to know the patient's name, age, and the location, and then when you are giving the call, like you have to why you are giving the call. So you have to think of the situation, why we are calling, and the background of, like you have to have the background medical conditions of the patient, and then the acute assessment of the patient, and what do you think, what are your recommendations. So we'll take an example here. Here's the task is like to inform the on-call registrar, like from the ward SHO, regarding a patient. So this patient is a 47-year-old male and a known patient with diabetes, and who's admitted to the ICU due to desaturation, and the RAT is positive. And now he's 5 hours in the ICU, but after that, saturation has dropped to 88% and on a oxygen mask with a non-rebreathing oxygen mask. And at this time, he can't complete his sentences, and a respiratory rate of 34 and a high heart rate. So if you just tell this information over the phone haphazardly, the person who is receiving doesn't get the information, all the information correctly. And it's very difficult for them to remember as well. So when you gather all this information, first assess the patient and take all the most recent notes with you, and have a small chart if possible, and then make the call. Like for an example, you can say, I am Dr. So-and-so, RHO from COVID ICU speaking. And then you need to confirm the person who's speaking, right? You can ask, am I talking to on-call ICU registrar? And wait for the confirmation, and from the other side saying yes. And then you can tell about the situation, like the same patient, like you can say, I'm talking about this newly admitted patient. So then the person who's receiving has an idea, and who's desaturating while on oxygen on non-rebreathing bag. So that's a very important thing, because like you need to attend something like that very quickly. So that information, the situation, you need to tell initially. So you need to highlight that. And then you can quickly say about the background. This is a 47-year-old and the patient so-and-so, and who was admitted with, who has a past medical history of diabetes, and he was admitted only for 5 hours from the medical ward and with a RAT positive report. So that briefly you can give the background. And then you can tell about the current assessment. He can't complete a sentence. He's tachypnic, and saturation is 88%, and blood pressure is 90/60. So then you need to give your recommendation, right? I'm concerned about this, whether of this ventilation, and then you have to give your recommendation. So this in this manner, and it will be more effective. And also you need to be assertive and raise your concerns. Like if you are concerned about the patient, you have to tell that I'm concerned or I'm uncomfortable, and there are some safety issues of this patient. So that if you raise that question, then it will be easy with your superiors. If you have any concerns, you have to tell them. Now we'll discuss something about the briefing. So this can be done like in an ICU setup or any other setup, like just after the handover. Among the team members, you can have a small briefing, like to map out the care plan. Like if you say like these jobs to be done today, so like you can allocate the task for the members, and then all the responsibilities like you can allocate in a small briefing. And also if there's any unexpected event, like if they need a if there's a cardiac arrest in the ward, who's going for the help, or like for the intubation, who's going. So those task allocation can be done in a small briefing. So then like if the patient, like other team members, they have any limitations, then they can say like I won't be able to attend a cardiac arrest in the ward because I'm not good at intubation, so I need more practice, or something like that. And then then in an emergency situation, you don't have to look for a person. Then in the morning, like among the team members, if you have a good briefing, then it will be very easy, and it will set the tone for the day, and it will be a good working environment for everybody. So the briefing is a good thing in the morning. So even at the end of a task, like after a cardiac arrest, like all the team members, if they done a task, a debriefing session would be also very helpful. So like you can evaluate how you have done, like how you have done good, or what the areas you have done wrong. So debriefing after CPR, then whether you have followed all the protocol, or you adhere to the protocol, those stuff, and whether they have any missing drugs or missing equipment or something like that. So after a task, whether you have done good, if you have done good, or if a person who has done brilliantly, so can appreciate that. So a debriefing is a very good thing after doing a task, so that it will help in the future patient outcome. I'll quickly go into specific challenges, which you all know with the COVID-19 patients. All these, like the identification, the role, like especially like you will not be able to identify your roles. So like it's better to have any labels or anything, say the doctors, nurses, and their names on the PPE, and also the instructions will be not heard properly. So you have to shout out. And also like if there's a COVID ward, and like you want to give information inside the patient, and if you're in the control in the outside, like better to use some mics or any other signs, like the boards. Like what we do is, like if you have the ventilated patients in a COVID ward, like you can have a good whiteboard, all the respiratory settings there, so that even from the outside, if you want to see quickly, you can see like that. You have to have different modes of like innovative methods of communication during this COVID-19 patients who are having, when we're having PPE, and also when the patients are cared as a barrier nursing. So we discussed about the communication as an important non-technical skill, and then we pay attention to these words as well. I'll quickly go through the consent. So in the consent, the learning objective are like we'll be discussing about what is consent and the importance of consent, and what if the patient is incapacitated. So all the clinicians, we as clinicians have an ethical obligation to respect patients' autonomy, even if this conflicts with the beneficents, like whether even if you are doing good, but if the patient saying like, no, I don't want this treatment, we have to respect that patient's autonomy. So, and the consent usually requires the capacity. The patient need to have a good capacity, and also you need to disclose all the relevant information, and the autonomy to make voluntary decisions, even if it seems irrational. Even if you think that this is irrational, what patient is saying irrational, that doesn't count. it's all the patient's autonomy. And there's an ethical aspect, a professional aspect, and a legal aspect in the consent. If you take the ethical aspect, the clinicians have the ethical obligation to respect the patient's autonomy. That is the right to be involved in their decisions that affects them. Like, it's not your decision, they are who's taking the decision. So even if it is not doing good, if the patient is not willing, you can have you can give all the information, but that they have the right, the patient autonomy, you have to respect that. And the patients may change their mind or even withdraw consent at any time. And still, you have to respect that. Even if they gave consent earlier and now not giving, then you have to respect that. And then there will be, there may be conflicts of interest, like it is not good for the patient. The patient even may die, if they even decline a life-saving treatment, but that's the patient's autonomy. And if you consider the professional aspect, this is a vital part of the doctor-patient relationship. And there's a professional courtesy to explain or any medical conditions or any medical encounters, and you need to give a chance or the opportunity to ask questions. Like, even if you're doing a surgery, like beforehand, like you have to get the consent, and like the risk, you have to explain the risk, and then you need to give a chance, like you have to explain the procedure, and then you have to give a chance for the patients to ask questions. So if you do a procedure without consent, that's an assault. And inadequate counsel while obtaining consent, like that means, like, if you don't give proper information and not counseling them properly, that is a charge of negligence. And the treating doctor is responsible for ensuring patient's consent, and it's the doctor's responsibility for the consent, not the nurses or anybody. That's your responsibility to get the consent. And also, you have to give all the risk, all the information when you are taking the consent. And as I explained to you earlier, refusal of treatment in a competent adult is legally binding. And even if the patient refuses treatment that will cause, that will not save his life, that is the patient's autonomy. And there are special instances the patients are having incapacity, right? So the patients without capacity can be treated of their best interest, right? Especially like a predictable patient, like a Alzheimer's disease patient, so they are not in a position to give you the consent, then the doctors can treat them. And even there will be persons with persistent vegetative state. And the other things like temporary, like during anesthesia, the doctors they will give the you give all the analgesics and everything during anesthesia. That is like the doctor has the right, and in a temporary incapacity situations. And this can be done in the patient's best interest, and also it should minimize the effects. And also there are some instances we have advanced decisions, like in like a Jehovah's Witness or any patients, like the patients will give advanced directives that you should not give a blood transfusion, but these can be given. So those treatment options can be documented before. So the consent can be either written or verbal, sometimes in an emergency, even in a emergency cesarean section. So we will be having a verbal consent. We will not be able to give a written consent, but all others, like they need the written consent. And you need to give information during that time about the procedure, the indication, and also any risk. And if there's a chance to, and an opportunity to ask any questions. and you need to document all those very clearly. So in an ICU patient, like every effort should be made to assist like temporary incapacitated patient to make their informed consent. Like if they're having a ET tube or a trachea, for instance, a trachea tube, and like they can't talk, like if they can write something so that for the consent, you can take those means. And also, if the patients lack competence, the informed consent can be obtained from the next of kin, but it's not actually legally, it's not the legal state, but you can ask. But mainly the patients is having the sole authority. And if you have any questions, you can ask, and I'll just quickly tell about the documentation, just to let you know, like all these you need to document very clearly. Even when you're writing something in your BHTs, you need to document them very clearly in a clearly, and also the time, date is very important, and because those are legal things, and after that you need to sign as well. Okay, if there's any questions, let me know. Thank you.
Thank you, Dr. Sudarshan. I don't think so. They might ask any questions from your lecture, I suppose. Yeah. Anyways, we'll be sharing the lecture videos on your Google Drive once all the programs are over. So, so that's we conclude today's anesthesiology training program. From tomorrow onwards, we are starting the pediatrics training. So do join by 8:15. Right. Thank you, Dr. Sudarshan Jayasekara, consultant anesthetist DGH Hambantota, on communication, consent, and documentation. Thank you very much. Okay.
Recording stopped.